Good morning, everyone. Good morning. Good morning. So, am I visible? Good morning, everyone. Am I visible, audible? Is the voice clear? Good morning. Good morning. Is the voice clear? Audio clear? Audio clear? Okay. Very good. Wonderful. Wish you a very good morning. And I hope you could revise. I know you had a class after that. Wonderful. So good to see you as all on time. Sorry to be on time. I, I, I tried to be on time, but I know sometimes people say you're too much on time actually. But we'll have some, if you couldn't have your breakfast, keep munching something and we'll have a break at 11 o'clock. You can eat at that time. All clear. Okay, wonderful. So, very good morning. Very good morning. And I have posted a video link if you just saw. It's a YouTube video of Missed YouTube channel. Dr. Vineet sir and I have discussed the integrated question of thyroid surgery and nerve injuries of ENT. So whenever you get time in the break, just revise those fine points which Dr. Vineet and myself have discussed to bring you more clarity on the nerve injury and thyroid surgery topic. Okay, fine. Now, tripod position is you keep your hand like this, which a tripod, like you want a tripod like this. When a baby will sit like this, can you see? When a baby will sit like this on the hand capped on the bed, there's a tripod here, tripod sign. Okay, no problem. If you could not revise, we'll try today. Do you have any class after the ENT class today? Do you have any class today after the ENT session? We finished the class around 5:30. Do we have a class today? After that? Okay. What time it starts? What time it starts? 5:30. Okay. Then we finish at 5 o'clock. Okay. Then you should get a break of 30 minutes. Okay, fine. Yeah. No, I understand that. Yesterday also I told you that because of the time limitation and we have to conduct every subject on time, we have to finish on time so that you get time for the revision after the session is over. I think you understand that part that we have to conduct the all the subjects on time so that you don't get really jittery that later on our subject is pending. So that's why the sequence of classes is very close. But try to make sure wherever you get time, please invest that time. But you believe me, you will have a lot of time in again after the session is over. Again, I hope yesterday I left you with thought that the day you don't have any class, whichever day, and in the future also, we have to spend 12 to 13 hours to study. It's not impractical. It's absolutely practical, not utterly motivational that 13 ghante padhna hai and all that. There's a scheme to do that 2 hours and after that break, 5 sessions of theory revision and 1 session of 2 to 3 hours of multiple choice question. It's a tested, tried formula, not something coming from just to motivate you guys. It has been tested. It has been found to be working, but you have to stick to one routine. Actually, that's very important. Sleep at one time and get up at one time. Don't change your sleep cycle every day. If you sleep from, like I sleep generally from 1 o'clock to 6 o'clock, 1 a.m. to 6 a.m. is my sleep time. And I think you need to also choose the cycle very, very, carefully, what matches your biorhythm, but follow that only. But don't sleep beyond 5.5 hours. That's not really going to help you. Now, let us now. लाइट का कुछ करता है आज मैंने आज पोजीशन चेंज किया है थोड़ा सा बिकॉज I've changed the camera actually. That camera was creating problem for me. वो कैमरा ऑडियो पिक करता है तो ऑडियो पूरा पिक नहीं कर पा रहा था. This is a normal laptop camera, but I'll see how can I increase the light because I changed my room also today. Chalo, anyway, let's whenever I need to explain, I will come on the full screen also. Don't worry about that. But let's revise the main points of laryngeal cancer. Smoking and alcohol both are risk factors. and it's more common in males. And the most common variety is in front of you, glottic cancer. So generally, the patient will be a smoker with a hoarse voice. So the chief complaint is hoarse voice, which is also called dysphonia. But we said that vocal cord cancer do not have neck node metastasis. Why? Because anybody, why? Anybody, why? Why? Why the neck node metastases are not there in glottic cancer? Anybody? Yes, because there are no lymphatic. Therefore, glottic cancer has a wonderful prognosis. Believe me, glottic cancer is a wonderful, like cancer if you catch it early. Okay. Now, let us go to the supraglottic cancer now. The supraglottic cancer, as I told you, supraglottic has got 5 parts. Let's revise. Number 1, epiglottis. Number 2, airy epiglottic folds. Number 3, false vocal cord. Number 4, ventricle. And number 5, saccule. Out of these 5, the epiglottis is the most common site. And this is what you're seeing on the screen right now. It's an epiglottic cancer, which is supraglottic cancer. What is the chief complaint of this patient? Generally, throat pain referred to ear. Number 2, you can say the dysphagia will be there, feeling of lump in throat is there, and of course a hot potato or plummy voice. And then finally we said the subglottic cancer is very rare, and the chief complaint of that patient is stridor. We're coming to treatment, don't worry about it. We're going to discuss everything. Now, first of all, let us discuss the staging of cancer. You must have done the cancer staging of breast cancer, prostate cancer, and tumor staging for laryngeal cancer. Now, this was a January question, T1. One structure involved. For example, one structure involved. For example, epiglottis or vocal cord. If epiglottis is involved, it is T1 supraglottic cancer. And if it is vocal cord involved, it is T1 glottic cancer. You can ask me, Rajiv, there are 2 vocal cord. What about that? Yes. Put 2 arrow. Put 2 arrow. If one vocal cord involved, then we call it T1A. And if both vocal cord involved, we call it T1B glottic cancer. What is cancer? Glottic cancer. T1A, T1B glottic cancer. Okay. T1B was January question. January 2023 question. Okay. Put a bracket like this. Both vocal cord should be mobile. Mobile. Vocal cord move, abduction, adduction. Okay, fine. Both vocal should be mobile. Mobile. T1B is your MCQ of January paper because they asked what is the correct description of T1B glottic cancer. Means both vocal cord involved, but vocal cord should be mobile. Now, everybody look at screen. Now, please see. Anybody, what is the staging of this cancer in front of you? What is staging of this cancer? What T1? What T1? T1 supraglottic cancer. T1 supraglottic cancer. Don't say A, beta. A and B is for vocal cord. Don't do this. Don't put A. Why you're putting A? T1A, T1B is for the vocal cord. Is it vocal cord? No, it's supraglottic cancer. Write down, beta. Write down T1. It is T1 supraglottic cancer. Don't say A or B. A or B is only for the vocal cord cancer. Beta. Okay. So T1 supraglottic cancer. Now tell me, what is this cancer? Beta? Now write down, beta. What is this cancer? Full name, beta. Full name. What is this cancer? T1A what? Now say T1A glottic cancer. Very good. T1A glottic cancer. T1A glottic cancer. Chalo. Now write down. What is this, beta? What if this is cancer spreads this like this? What is the name now? If cancer spread like this, what is the name now? If cancer spread to the other vocal cord also, what is the stage now? This is T1B glottic cancer. Very good. So you're absolutely clear. T1B glottic cancer. Wonderful. Very nice. Very nice. Now, Please see. So this is T1 aglottic, supraglottic cancer. Okay. Now, please see. Look at the T2 in your notes. Beta. Everybody read the T2. More than one structure involved. Can you see more than one structure involved? Beta? Please see, everybody. If the cancer goes from here, this is epiglottic cancer. If it involves the airy epiglottic fold also, what is the stage of this cancer now? Look at your notes where T2 means more than one structure involved. Now it is involving the epiglottis and also involving the airy epiglottic fold. Now its name is T2 supraglottic cancer. T2 supraglottic cancer. Very good. Wonderful. Such intelligent people you are. T1 supraglottic. Have confidence in you. T2 supraglottic cancer. T2 supraglottic cancer. Very good. Now T3 is a neat PG question. Whenever the MCQ says T3, a vocal cord is mobile, immobile, or fixed, T3 beta. This is neat PG question. T3 beta. T3 is a vocal cord fixed or immobile beta. And T4 is invasion of thyroid cartilage. If you see a CT scan and the thyroid cartilage is penetrated by the cancer, it is T4 beta. T4. Let's revise everyone. Let me put an audio on the group beta. Now, same thing beta, Hana, in English. Cancer larynx staging. T1 means only one structure involved, like epiglottis or vocal cord. If one vocal cord involved, it is T1A. Or both cord involved, T1B glottic cancer, but both cords should be mobile. T2 means more than one structure involved. For example, epiglottis and airy epiglottic fold. T3 means vocal cord is fixed or immobile. And T4 means thyroid cartilage is invaded. So this is cancer larynx staging. Somebody mark it and save it. Okay, fine. Chalo. Very good. Now, management. The main thing about staging is management. Okay. Now, T1, T2 is radiotherapy. T1, T2 radiotherapy. T1, T2 radiotherapy. T3, T4 is total laryngectomy followed by radiotherapy. Total laryngectomy followed by radiotherapy. Now, T1. Put an arrow like that. Nowadays, treatment for T1 M0 glottic vocal cord cancer is laser surgery better than radiotherapy. Laser surgery better than radiotherapy. There's somebody keep posting, saving all these audios in one place. Then at the end of the class, we'll put all the audios here. Okay. T1, T2 radiotherapy. But T1 glottic cancer, we will go nowadays laser surgery because radiotherapy has got a lot of side effects. But it's a very long therapy, maybe 40 days therapy, and a lot of side effects are there. Now, carbon dioxide laser is a wonderful laser, and we can use that laser to remove the vocal cord. For example, this is what we have the cancer. Why to give 40 days radiotherapy when you can do 40-minute surgery with a laser? Why? Because vocal cord do not have lymphatics, so they do not spread anywhere better. So therefore, it's very easy, to remove that. Vocal cord voice will anyway go bad, no problem after that. Okay, fine. Wow. Now, laser only for T1 glottic cancer, beta. Okay, laser only for T1 glottic cancer. Laser is only for its question written beta. Only for this thing, beta. Only for the T1 M0 glottic cancer. Beta. Okay, let's revise, beta. T1 means only one structure involved and like epiglottis or vocal cord. Beta. T2 means more than one structure involved. T3 means vocal cord fixed or immobile. T4 means thyroid cartilage invaded. T1, T2 small cancer needs small treatment like radiotherapy. T3, T4 big tumor, like big surgery like laryngectomy followed by radiotherapy. After laryngectomy, to give radiotherapy also. But now science is changing. For T1 glottic cancer, patient has got the requirement of laser surgery is a better treatment than radiotherapy. And which laser? CO2 laser. Okay, now, yes, for both T1A and T1B. Now, let's put an arrow here. After laryngectomy, you have to make a permanent hole in the neck. Okay, permanent hole in the neck. Okay, now, how you recognize permanent tracheostomy? Permanent tracheostomy, put an arrow, write down. It has no tube. How will you identify this, beta? You must have seen a picture of tracheostomy with a plastic tube here, beta. It has no tube in neck hole. To be simple, how will you identify it's a normal tracheostomy or a permanent tracheostomy, beta? Permanent tracheostomy, lifelong there's a hole because we stitched the trachea to the neck skin, beta. It has a hole, it has no tube in the neck hole, beta. Neck hole. Okay, fine. Now, laryngectomy has been done, beta. Please see on the screen, everybody. Laryngectomy has been done. How we do that? Please see on the screen. First, you lift the skin. Then you expose this one. Now, everybody, please see over there. Can you see over here? Everybody, can you see? You are cutting the larynx from trachea. Okay. Then you remove the whole larynx. Okay, very good. This is the total laryngectomy. Total laryngectomy. You have removed this much part. What is left? Trachea. Now nothing is left over there. Trachea. Now what you do is you stitch the edges of trachea to the neck skin. Are you seeing? There is no laryngectomy has been done with it. You have stitched the edges of trachea to the skin of the neck. Okay. So this hole will be permanent hole. All of you see over here. This is the trachea and you sutured it to the edges of the skin of the neck and there is no hole no tube in the neck hole. Okay. Now please see, laryngectomy has been done. Now your respiratory system start from here. Inspiration, expiration. Nose is useless now. Nose useless. This is your beginning of respiratory system. This is trachea and these are two bronchi. Okay, like that. There's no connection with the nose now. Okay, this is permanent tracheostomy. Okay, permanent tracheostomy. Okay, now everybody, just take a picture when I label it. Then you take a picture and post in the group. Please save these pictures, beta. When I say save the picture, you save another folder, beta. Permanent tracheostomy. Somebody keep saving all the audios and all the images which I say save and keep it with you, beta. Okay, fair friend. Okay, now, permanent tracheostomy has no tube in hole. No tube in neck hole. Wait. Let me write full beta. No tube in neck hole so that you have got everything in the listen. Write down. This is after total laryngectomy. Wait, beta. Wait. When I say click, then click. After sabar rakho bhaiya. After total laryngectomy in cancer larynx. Now, थोड़ा सा फोटो में ये हो जाता है ना, पूरा का पूरा ज्ञान आ जाता है तो कुछ रिवाइज हो जाएगा, ज्यादा रिवाइज हो जाएगा, है ना. चलो अब क्लिक करो. Lot of risk of infection, lot of foreign body problem, lot of filtration issue. Cancer surgery always has a lot of morbidity. That's why if you're smoking at your own risk. Okay, fine. रुको जरा. हाँ, मैं ये ढूंढ रहा था. थैंक यू यार. हाँ, एग्जैक्टली मैं यही ढूंढ रहा था, वो वर्ड ढूंढ रहा था. रुको जरा. Okay. So this picture to be saved. Chalo, very good. Chalo. Yeah. It's for your foreign body, dust particle, infection, everything patient has to, understand that. Okay. Everybody come to the end of the video here. I'm waiting for everyone. Come to the end of the video. Some people are lagging behind. Come, just watch it. And now I'm waiting for 1 minute. Everybody come at this place. When I say 1 minute, after that, you join from where I start speaking. Chalo. Now, somebody said, yes, loss of voice will be there. No? Yes, because laryngectomy, larynx is the organ of voice production that is removed. Now, next page, beta. Let us see voice production after laryngectomy. Very good, beta. I'm glad Sushmita, Meds, and a lot of people are thinking like that. Very good, beta. Ankita, Very good. All are thinking that how to live life after that. Very good. Voice production after laryngectomy, 3 methods. Number 1, esophageal voice. You can train the person to speak from esophagus. It's a poor method, useless method. The only for the MCQs only. Number 2, electrolarynx or artificial larynx. Keep thinking. I'm glad somebody thought कि बोलेगा कैसे भाई ये electrolarynx or artificial larynx. It is battery operated external vibrator. It's a battery operated external vibrator. It's a vibrator. You have to charge it. Okay, fine. Battery operated external vibrator. Okay. Battery operated. No smell, beta. No smell. With the no smell, taste is also less. Very bad life after that. That's why if you're smoking at your own risk. Cannot smell, foreign body problem, aspiration. But can he speak? Yes, he can speak, beta. He can speak, but it is a battery operated external vibrator. You have to charge it. You have to keep in the pocket. It's a very, I would say common method. People use it, and they have to, this costs around 6,000-7,000 rupees. And you have to touch it like this below the skin, below the mandible. You have to touch it, and the person has robotic sound, little as robotic sound, but it is understandable. It is understandable. And but only thing is charge it, beta, charge it, and थोड़ा सा 1-2 दिन लगते समझ आने में. But if you think, doctors can understand everything, family members can also start understanding a lot of things. A lot of things they start understanding, and that makes the like conversation possible. Beta. I don't know if you can hear it or not. If I please try to hear this, beta. If you can hear it, he will tell you the date of surgery, beta.
और आपका ऑपरेशन कब हुआ था? 15 मई। दोबारा बोलिए। 15 मई। कौन सी हॉस्पिटल में? हॉस्पिटल। और आपका ऑपरेशन कब हुआ था? 15 मई। दोबारा बोलिए। 15 मई। कौन सी हॉस्पिटल में?
I hope good robotic sound, है ना? Fine, ना? 15 मई, very good. Faizan, Salam, you have found it. Yes. पहली बार में ही, very good. 100/100 score. वाओ यार. पहली बार में आपने समझ लिया कि 15 मई को, when the surgery, डॉक्टर ने पूछा सर्जरी ऑपरेशन कब हुआ? He said 15 मई, बेटा. Very good, बेटा. Now guys, please understand, this needs charging. You have to keep it in your pocket when you go to the office. ऐसा नहीं कि आप ऑफिस चले गए, you go to the office and you leave it at home. घर रह गया आपका आइलैंड. If that is case, then you're full day on the mute mode only, बेटा. Full day. ऐसे होता है बेटा, ऐसे टच करके बोलते हैं, है ना? अगर आप ऑफिस चले गए, घर रह गया, तो पूरा दिन आप म्यूट मोड पे हो बेटा. फिर then you have to take it with you. Okay, keep it charged. Believe me, the life is not that bad. Family can understand everything. I remember there was a patient of cancer, laryngectomy done, follow-up was going on. After 3 months, they come this, and 6 months follow-up, they come. One patient came with his wife actually to the AIMS OPD. There was in AIMS in those days. And he was actually 3 months after surgery, he came for the follow-up. He had learned to use the electrolarynx, beta. हस्बैंड वाइफ कहीं भी लड़ सकते हैं बेटा, कहीं भी लड़. एम्स की ओपीडी में हस्बैंड की वाइफ की लड़ाई शुरू हो गई, और वहीं पे घमासान मच गया भाई. और वो वाइफ उसकी ऐसे बोल रही मुंह से, ये ऐसे जवाब दे रहा, पूरा से टच करके पूरा इलेक्ट्रो ऐसे जवाब दे रहा, वो ऐसे बोल रही, ये ऐसे बोल रहा. पूरी फुल फाइट इज गोइंग ऑन बिटवीन हस्बैंड एंड वाइफ. वाइफ इज अंडरस्टैंडिंग एवरीथिंग बेटा, एवरीथिंग. एंड नाउ प्लीज लुक एट मी बेटा, लुक एट मी. एंड बट लड़ाई पूरी बराबर की चल रही, अचानक इसकी बैटरी ड्रेन हो गई बेटा, बैटरी ड्रेन होगी, और जीता हुआ मैच हार गया, वो जीता हुआ मैच हार गया. एंड बड़ा फ्रस्ट्रेट बोला था, मतलब कह रहा था कि मैं घर जाके चार्ज करके बाकी बात बताऊंगा, है ना? चार्ज करना पड़ता है इसको, चार्ज करना पड़ता है. नाउ नेक्स्ट वन इज द थर्ड इज द बेस्ट ऑप्शन बेटा. टीईपी इज द वंडरफुल ऑप्शन एंड यू शुड नो अबाउट इट नाउ. टीईपी, ट्रेकियो puncture device, is the best option. This is put in the body. Example, Blom Singer prosthesis. Write down example, Blom Singer prosthesis. This you must know, write down capital TEP. This is latest now, and this is a wonderful device, and it is the best option actually. Okay. TEP is a unidirectional valve. It's like a valve. This is a valve. This is right now TEP. This is TEP. Okay. It is internal device surgically fitted between trachea and esophagus. Surgically fitted between trachea and esophagus. Internal device, put an arrow. TEP, tracheo-esophageal puncture device. Okay. Now, so let's revise better. There are three ways to speak. Number one is esophageal voice, useless method. Electrolarynx or artificial larynx, you should know the picture. It is a handheld battery operated external vibrator. Okay. The best option is TEP device. What is TEP full form? Tracheo-esophageal puncture device. And example is Blom-Singer prosthesis. Bolo beta besa bolo. Kya naam hai iska beta? TEP ka full form bolo. TEP ka full form. Everybody, are you? May I remind you again, it's not an online class. It's an offline face-to-face session kind of class where you and me are studying together in one room, one-to-one, discussing a topic like friends do. And so when I say speak, speak also. Say, what is TEP full form? Tracheo-esophageal puncture device. Tracheo-esophageal puncture device. Okay. Now, fine. And example is Blom-Singer prosthesis. Blom-Singer prosthesis. Okay, fine. Blom-Singer prosthesis. So it's a unidirectional valve. It's an internal device. It is surgically fitted between trachea and tracheo. Do we need any ventilator? Not at all. Patient can breathe himself. Okay, no, not at all. Okay, fine. Tracheo-esophageal puncture device, and patient can easily use it. Now, let me show you a picture now. Let me show you a picture of the TEP device. It's a neat PG question. Very good. Exam date, I have been telling you again and again, let us prepare as per 4th December exam data. Let us keep not, brain is very intelligent. Brain does not want to study. Brain wants to speculate, imagine, get afraid, get panic, get anxious, and just, start thinking about something non-academic. Not just your brain, my brain also does like that. Do not waste your single hour on thinking which date is the best. I'm saying again and again, we'll prepare as per 4th December date. Let us not really, keep wasting your energy and time. You are mature guys, and you need to understand that please control your brain. Otherwise, you will end up getting exhausted without having any output of the day. Because that's what I also do actually. So I have a mastery in wasting time. I'm already, double PhD in how to waste time, how to, postpone things, how to procrastinate. I have wasted 19 months at a stretch in my life. I know how brain works. So please do not do all that. But you focus on just studying as per 4th December. We'll see. Okay, now, this is TEP device. Everybody, once I label it, you just picture it. Abhini, not now. Example is Blom-Singer prosthesis. 1 second, beta. After total laryngectomy. Can we stop discussing on the Telegram? Okay. If you have a question, post it to me, but don't discuss amongst yourself. But focus on you never know which question can come from which part. So look at what is shown on the screen. If you have a question, write it one. I'll see. Don't worry. Okay. If there are too many posts, I will not be able to reach the question if you are there. Okay. So this is important. This plastic nipple-like thing is TEP device. But this is the TEP device. You can see. Okay, fine. So this is anybody. What is this? This is permanent tracheostomy. Permanent tracheostomy. Chalo. Now take a picture. Chalo. Now. So this is a three-way again. I say the best option is in front of you. There will be a lot of problem after the surgery. Patient cannot smell, patient cannot taste the food also. Breathing has to be from here. You have to take care of infections, everything. But this is what the result of the surgery is. You have to be like, after you remove the breast and breast cancer, you have to really think about, how to make it cosmetically better later on. But that's a morbidity. Everybody cannot afford the implants actually. So you have to be, in cancer, there is always a morbidity after surgery. Okay. Now, There is no need of any ventilator. Somebody asked, do we need to have a ventilator? Not at all, brother. You have a normal breathing like anybody. Laryngectomy and tracheostomy, how can it be same, beta? Jyotsna, laryngectomy means you remove the larynx. Tracheostomy means you make a hole in the trachea, which is very common surgery we do for any airway problem. Okay, fine. Now, but this hole is a permanent hole in the neck of the patient. This hole will not go anywhere, beta. This hole will be there, and you have to take care because infections can happen. Dust particle can go inside, and you're in the rainy season. Rain is there. It can go. Water can go directly into your lungs, beta. You have to take. But people learn to live with it. Let me tell you, first few months people get a lot of problem, but when they come for 6-month follow-up, beta, they actually start to learn to live with it. Actually, to be very honest with you, I remember one of the patient who came to the AIMS OPD in the follow-up after 6 months of the surgery. He was having hole in the neck, permanent tracheostomy in the neck, and we were going from the OT to the OPD side. This guy was from Rajasthan, from the city called Sikar se tha, 62-year-old man, laryngectomy done 6 months back. Now for follow-up in cancer clinic in AIMS after 6 months, क्या कर रहा था बाबा? क्या कर रहा था? सीकर वाले बाबा क्या कर रहे थे? सीकर वाले बाबा यहां से बीड़ी पी रहे थे, फिर से इधर से ऐसे पकड़ के ऐसे खड़े हुए, इधर से बीड़ी पी रहे, इधर से यहां से स्मोकिंग फ्रॉम हियर. 6 महीने में ये भी सीख जाते हैं ये लोग, है ना? तो तुम्हें लगता है बहुत मुश्किल होगा? एंजॉय करना सीख जाते हैं. इधर से बीड़ी पी रहा है वो. वहां पे एक पीजी को बहुत गुस्सा आ गया, बाबा तुम क्या कर रहे हो? दोबारा से तुमने बीड़ी पीना शुरू कर दिया. बाबा ने निकाला इलेक्ट्रोलैरिंक्स अपना. बाबा ने निकाला इलेक्ट्रोलैरिंक्स यहां रखा. बाबा कहते हैं बेटा जो होना था हो गया, अब सब ठीक है, तुझे टेंशन मत ले. बाबा डॉक्टर को बोला तुझे टेंशन मत ले. उसने बोला कि बाबा तुम्हें पता है बीड़ी पी के यहां से दूसरा कैंसर हो जाएगा, लंग कैंसर हो जाएगा तुम्हें. सिगरेट पी के यहां से सिगरेट पियोगे तो लंग कैंसर हो जाएगा तुम्हें. बाबा ने फिर निकाला इलेक्ट्रोलाइटिंग रखा. बाबा कहते हैं कि बेटा आप लोगों में पूरा भरोसा है, आप उससे मुझे बचा लोगे. सो लाइफ गोज ऑन बेटा. लायरेंजेक्टमी के बाद लाइफ रुकती नहीं है, लाइफ गोज ऑन है ना. फाइन, चलो फाइन, चलो जी बेटा. Now let's do the next one, beta. Next is just anatomy topic, beta. Level of neck nodes. Let's see, beta. Level of neck node. 1A submental, 1B submandibular. Okay. Now 2, 3, 4 is important, beta. Everybody, 2, 3, 4. Put a bracket. This is upper deep cervical, middle deep cervical, low deep to which muscle, beta? Deep to sternocleidomastoid muscle and around internal jugular vein. Internal jugular vein. In laryngectomy, we remove whole larynx. So deep to sternocleidomastoid and around internal jugular vein. When you reach the internship, you will see all these cases. Don't worry about it. So do the internship in a medical college. You'll see all these cases there. You'll get, idea about it. It really happens. So level 5 is very important, beta. MCQ. Level 5 is posterior triangular knee, beta. Posterior triangle, also called supraclavicular. You have you done these neck nodes in anatomy or surgery? Have you done this level of neck node in anatomy or surgery, beta? This is an MCQ of your paper, beta. Level 5 anatomy question, beta. Have you done this neck node in anatomy or surgery, beta? Anatomy you done, na? So it's a revision. Anatomy. Okay. Level 6 is the anterior compartment, operitracheal. Level 7 is mediastinal. So you know all the neck nodes. It's just for your information that we should see that the majority neck nodes are deep to sternocleidomastoid muscle and around internal jugular vein. But please mark this question, beta. This is the MCQ which is important, that the level 5, the posterior triangle or supraclavicular. Okay. Let's revise. No problem, beta. We can revise again. 1A, beta. 1A is, look at me, beta. 1A is submental. 1A is submental, beta. 1A is submental, beta. Submental here. Okay. 1B is submandibular. Now 2, 3, 4 is here, beta. Below the sternocleidomastoid, na 2, 3, 4 over here. Okay, and level 5 is posterior triangle. Level 6 is here, beta, in front of trachea, pretracheal or anterior compartment, and level 7 is mediastinal. Once again, let's save this, beta. Level of neck nodes: 1A is submental, 1B is submandibular. Level 2 is upper deep cervical, level 3 is middle deep cervical, level 4 lower deep cervical. These level 2, 3, 4 are deep to sternocleidomastoid muscle and around the internal jugular vein. Level 5 is important question. Level 5 is posterior triangle or supraclavicular group of lymph nodes. Level 6 in front of trachea, anterior compartment group of lymph nodes. And level 7 is mediastinal lymph nodes. Okay. Yes, level 6, yes. Level 6 is also called Delphian, but no need to remember that. Such questions are not coming now. But if you know in anatomy, you may be told this is Delphian lymph node. Level 6 is level. After the class over, just revise these audios quickly also, beta, hai na? In the tea break. Now, next page, beta. Yes. This picture is very good, beta. Somebody post a picture. This picture is very nice, beta. Very nice. Now, radical neck dissection, beta. R&D, right? We very commonly do R&D surgery in the head and neck cancer. It's a surgery done in metastatic secondary neck nodes in a case of head and neck cancer. In a case of head and neck cancer. In a case of head and neck cancer. Try the audios, better try the audios in other subjects also. You might find it a useful thing. I'm not saying for everyone, but if you like this idea, it can really be, like, okay. Now, everybody, have you done the breast cancer beta in surgery, or you're yet to do that? Have you done breast cancer? Dr. Vinita has told breast cancer, or yet to be doing? Breast cancer have you done? So in breast cancer, you must have, not done. Maybe for some people, okay, you must be knowing, maybe you may be knowing, for breast cancer, there's to do surgery, MRM, a modified radical mastectomy with axillary lymph node dissection. And axillary lymph node, this axillary lymph node dissection we do. Similarly, dissection matlab, remove the lymph node along with all those structure coming in contact with these nodes also, so that you make the area clear of cancer better. Okay, so MCQ is, what are the structures better? List of structure removed in R&D. Okay. Now, no problem. I'm just giving an example. In breast cancer, the surgery name is the axillary lymph node dissection for the metastatic neck nodes. For head and neck cancer of this area, we do the surgery called R&D, radical neck dissection. Like for example, somebody has tongue cancer along with level 2 lymph node enlargement. Please see, tongue cancer along with level 2. Now you know level 2 is upper deep cervical group of lymph node. Level 2 metastasis is there. So for tongue cancer, you did a glossectomy or hemiglossectomy. But for the neck node, you will be doing what? R&D surgery. What is R&D? Radical neck dissection. List of removed in R&D are level 1 to level 5 neck nodes. Number 2, sternocleidomastoid muscle. Number 3, internal jugular vein. Please see, majority lymph node are below which muscle? Sternocleidomastoid and internal jugular vein. Accessory spinal nerve. 11th nerve, hai na? That is the nerve supply of this thing. There will be morbidity after surgery. I'm telling you, shoulder cannot be lifted and all that. Number 5, omohyoid muscle. Omohyoid. This question will come in ENT, in surgery, everywhere. Tail of parotid gland and submental gland. So R&D surgery is radical neck dissection. It's done for metastatic or secondary neck node in a case of head and neck cancer. We sacrifice a lot of structures. Let us revise and I will record it for you. Okay. Let's revise. Everybody revise with me now. I will speak and revise. And after I share, you also share. Did you revise or not, beta? Because forget about it as an online class. We can make it almost offline experience for you. If you are able to shed away, I will not speak. Lago na bhai, kya problem hai? We came like a monkey. Let's die like a monkey. इन बिटवीन लेट्स बिहेव लाइक पेट डॉग ऑफ अवर सेल्फ बेटा, है ना? फाइन, चलो। कोई भी निमोनिक, आई एम नॉट फॉन्ड ऑफ निमोनिक्स बेटा। निमोनिक इतने ज्यादा हो जाते हैं कि इट्स हर फैकल्टी 19 मिनट की फैकल्टी निमोनिक बता रही होती है, तो निमोनिक को याद रखिए कि निमोनिक चाहिए होता है बेटा। जहां जहां थोड़ा बहुत होगा वहां पे होना चाहिए, बट ट्राई टू डेवलप योर ओन थिंग्स बेटा। अपने निमोनिक थोड़े बहुत खुद बना लो, बेटर रहेगा। वरना निमोनिक चाहिए होता है निमोनिक याद रखने के लिए बेटा। तुम्हें भी बताइए, इतने निमोनिक इकट्ठे हो जाते हैं। अच्छा, नाउ प्लीज सी बेटा, let me start now. Structures removed in radical neck dissection are level 1 to level 5 neck nodes. Number two muscle are removed: sternocleidomastoid muscle and omohyoid muscle. One vein is removed, internal jugular vein. One nerve is removed, is accessory spinal nerve, and 2 salivary glands are removed, are tail of parotid gland and submandibular salivary gland. Okay, but fine. Now, fine. Chalo. Now I've saved this. Please save this audio. Okay, fine. Very good, brother. Nitesh, keep saving all these audios. At the end, let us put all the larynx audios once, बेटा। एक काम करते हैं आज, larynx के audios और important images जब break के time पे डाल देंगे, है ना? फाइन, ऐसे मजा आएगा। तो ये पूरी पढ़ाई होनी चाहिए, आधी दूरी नहीं। Now let's come to the tracheostomy topic, बेटा। tracheostomy। ये क्वेश्चन आता है बेटा R&D में, नीट पीजी में, नॉट MCI FMG क्वेश्चन, बट नाउ पेपर इज इंक्रीजिंग। ऑल आर रिमूव्ड इन R&D एक्सेप्ट, दे ऑलवेज आस्क ऑल आर रिमूव्ड इन R&D एक्सेप्ट बेटा। चलो, नहीं, अपने निमोनिक खुद बनाना बेटर रहता है बेटा। अपने निमोनिक से क्या होता है, कोई कहानी आ जाती है ना? लेकिन निमोनिक तब बनेंगे जब आप फोकस से पढ़ोगे, अपने ध्यान से पढ़ोगे, चाहे जितना भी टाइम बचता है उसके बाद जब आप पढ़ते हो। कितने लोग बताओ, चलो। और हर बंदा जवाब देगा। 2000 लोग हैं भी ग्रुप में, उससे ज्यादा लोग हैं। 2000 people are there in the group. All of you answer this question very honestly to me. If you study for 2 hours, do you check the mobile phone in between? Yes or no? Of course, no, of course. Sometimes yes, no, yes, yes, no, yes. तो एक काम करते हैं बेटा, चलो इधर देखो, मैं तो देखो, इधर देखो। चलो ठीक है, ओके। चलो इधर देखो, मैं देखो। नाउ प्लीज लुक एट मी बेटा, लुक एट मी। आई से स्टडी फॉर मिनिमम 2 hours एट अ स्ट्रेच। उस 2 घंटे में मोबाइल फोन को देखना भी नहीं। टच तो दूर रख दो, देखना नहीं है। Let us make a commitment between 2 of us better. If you think, look at me as a faculty, then you say, बका रहा है या तो बोर कर रहा है यार, ये फालतू की ज्ञान बक रहा है। लेकिन if you look at me that, this guy has really, passed through all these stages, and, he has also wasted a lot of time, and now he is telling from his own experience that what works in my case, मेरे केस में क्या काम करता है। Don't look at me as a faculty, look at me as an elder brother. And for your own betterment, for making sure whatever you study should be useful for the exam day, let us pledge today. At least for those 2 hours when we are studying, let's not touch even, let us not look at even mobile बेटा। निमोनिक तब पैदा होंगे बेटा। मैं सच्ची बोल रहा हूं, अगर तुम बायोकेमिस्ट्री पढ़ रहे हो, खतरनाक टॉपिक्स, और फोन पे तुम इंस्टाग्राम देख रहे हो बेटा, वो तुम्हारे किसी कजन ने अपने हनीमून की फोटो डाली हुई है, तुम्हारा दिमाग पता क्या कह रहा होता है, यार क्या मेरी लाइफ है यार, यहाँ बायोकेमिस्ट्री चल रही है, वहां रियल केमिस्ट्री चल रही है ना? हो गया ना कांड बेटा। ब्रेन डज नॉट वांट टू स्टडी बेटा, ब्रेन वांट्स टू मेक बेबीज ओनली, इफ यू रिमेंबर, है ना? ब्रेन को कहाँ निमोनिक सूझेंगे, पढ़ाई नहीं हो रही, दिमाग और तरफ चला जाता है, यार क्या लाइफ है, क्यों डॉक्टरी ले ली, कौन मेरा दुश्मन था जिसने डॉक्टरी लेके मुझे यहाँ भेज दिया भाई, है ना? एक से दूसरी चौथी से छठी थॉट, बस यही प्रोग्राम चलता रहना है ना? टू सेव योरसेल्फ फ्रॉम दैट होल थिंग, एक काम करते हैं, जब हम बायोकेमिस्ट्री पढ़ रहे हैं तो फिर केमिस्ट्री छोड़ दो भाई, वो वाली, है ना? छोड़ दो, होगी तुम्हारी भी शादी होगी एक दिन, तुम्हारा नंबर आएगा, लेकिन टाइम लगेगा, थोड़ा सा टाइम लगेगा, सब्र रखो, पढ़ लो, है ना? अभी पढ़ लो, तो मत कर दो यार, मत करो यार ये सब चीजें। ब्रेक में थोड़ा बहुत गाना वाना सुन लिया, कुछ चेक कर लिया दाएं बाएं, मैं इतना नहीं कहता बिल्कुल छोड़ दो, मतलब वो बहुत मुश्किल हो जाता है। दैट इज ऑल्सो क्योंकि व्हाट्सएप है, टेलीग्राम है, कुछ देखना है और ब्रेक में चाय पीते हुए देख के फिर चुपचाप पढ़ने, लेकिन ब्रेक का टाइम फिक्स है, 20-25 मिनट ब्रेक लेके बैठ के फिर पढ़ने शुरू कर दिया, उसी से बात बनेगी बेटा। चलो नाउ ट्रिक्योस्टमी, पहली बात तो ये इज इंपॉर्टेंट टॉपिक बेटा। ट्रिक्योस्टमी इज मोस्टली डन टू सिक्योर एयरवे इन अपर एयरवे ऑब्स्ट्रक्शन, any problem above the trachea in upper airway obstruction. Okay, it is mostly done to secure the airway in upper airway obstruction. My dear friend, it will not be of any use for asthma patient beta. Asthma patient, the problem is below the trachea beta. Please see, think like a doctor. Any problem above trachea, any blockage here, you do tracheostomy hole, it's wonderful for the patient. But if there's a problem below trachea, why to make a hole in trachea then? Okay, in asthma patient, there's no role of tracheostomy. In asthma patient, asthma problem is below trachea. Any problem in the upper airway obstruction, you go for tracheostomy. Most common site of tracheostomy is second and third tracheal ring. This is called mid-tracheostomy. Mid-tracheostomy. Why we leave the first ring? We leave the first ring to prevent damage to larynx. We leave the first ring to prevent damage to larynx. Okay, fine. Fine. We leave first ring to prevent damage to larynx, beta. Everybody look at screen, beta. Everyone. This is your tracheostomy being done. You give a cut on the neck and open quickly, and leave it. Now, please see the uppermost ring is cricoid ring. Can you see the number one top of the picture ring is cricoid ring, then first tracheal ring, then second tracheal ring. Where you make a hole? You make a hole between second and third tracheal ring. Okay? Okay, can you see second and third? First, you are not touched. Okay, first, why you don't touch the first ring? It can damage the larynx. And after that, you put the tube. Anybody? Is it a permanent tracheostomy or a standard tracheostomy? Is it a permanent tracheostomy or standard tracheostomy? Standard tracheostomy, because permanent tracheostomy will be no tube in the neck hole. Very good. That's my you're smart chapter. Today you have to make a commitment to your elder brother that we will not use mobile phone during our revision. बस इतना बोल दो, मैं बड़ी बड़ी बातें नहीं करता, मैं छोटे छोटे रूल बना के फॉलो करने में बिलीव करता हूँ। बड़ा बड़ा यानी कि मैं सब कुछ त्याग दूंगा एंड ऑल, वो सब पता नहीं कितने लोग कर पाते हैं, कई लोग होते कर पाते हैं। Actually, the only thing is make a commitment, fulfill that. Make a small commitment, fulfill that. That gives you confidence to make bigger commitments. ऐसे चलता है काम बेटा, है ना? इतना बड़ा खतरनाक टाइम टेबल बना लेते हैं, फॉलो ही नहीं हो पाता हमारे से। 9 से 11 फिजियोलॉजी, 11 से 11:15 टी ब्रेक, 11:15 to 1 o'clock we'll read the physiology part 2. तुम्हें लगता है 15 मिनट में टी ब्रेक हो पाती? मुश्किल हो जाता है बेटा, है ना? Make the realistic program. So one commitment let us make today. During revision बेटा, जब हम रात को रिवाइज करें, कभी भी उस समय मोबाइल का स्ट्रिक्टली प्रोहिबिटेड है, टच भी नहीं करना है। वो जो हमारे अंदर इच होती है ना, इच होती है, इरिटेट, हमारे अंदर इच हो रही थी, देख लेता हूँ, समझ नहीं आ रहा, आई एम नॉट एबल टू अंडरस्टैंड टॉपिक, टू रिलीव दैट फ्रस्ट्रेशन आई जस्ट वांट टू वॉच on the phone some YouTube, some Instagram. That actually defeats the whole purpose. Brain does not have long-term recall now. Okay, bache, fine? Okay, fine. Chalo. Now guys, please see. Now MCQ of your paper. What is high tracheostomy? Write down. The high tracheostomy Chalo. High tracheostomy, it is done in cancer larynx. No, don't cross talk, but don't cross talk. Only you'll talk to me. Only you have to put question to me and talk to me. Whatever doubts you have in your mind about ENT, otherwise put to me. Don't cross talk to each other. Okay. Cancer larynx. Cancer larynx. High tracheostomy, it is done in first and second ring. It is done in first and second ring. So let's revise this one. Generally, we do tracheostomy at second and third tracheal ring, which you saw in the video. That is called mid tracheostomy. We leave the first ring to prevent damage to larynx. But in cancer larynx is already damaged, beta. Why to worry? So we do high tracheostomy. And two MCQs. One, where we do the high tracheostomy, and what is site of the high tracheostomy. Once again, let's revise, beta. Fine. High tracheostomy is done for a patient of cancer larynx is an important question, beta. Okay. And it is done in first and second ring. Tracheostomy reduces dead space by 50%. Physiology question. You know the dead space of physiology? Tracheostomy reduces dead space by 50%. Next question, beta. Tracheostomy is a temporary procedure except after total laryngectomy. It's temporary procedure except after total laryngectomy. You remember? After total laryngectomy, put an arrow, we have permanent tracheostomy. Yes, it is reduced to half. Permanent tracheostomy. Permanent tracheostomy. So otherwise tracheostomy is for 1 day, 1 week, 1 month, 1 year, but not forever, not throughout life. But after laryngectomy, lifelong there's a hole in the neck. But I told you, laryngectomy ke baad zindagi bhar gardan mein hole rahega beta. In English, after laryngectomy, you have permanent hole in the neck. But otherwise, tracheostomy done for other indication, it's only for some days, some weeks or months or a year. Okay, fine. Chalo. So tracheostomy is done at second and third ring, Jasmine, in every case, except in cancer larynx, where we do first and second ring tracheostomy, and that's called high tracheostomy. Now, two MCQ in the next page. One is your NEET PG question. This one is, second question is your FMG question. Chalo. Now, tracheostomy can lead to apnea. Apnea, anybody, what is apnea? Dyspnea, difficulty in breathing. Apnea, breathing stops. Why? Due to CO2 washout. You must have read in physiology, the main stimulus for respiration to continue is your carbon dioxide level. Main stimulus for your respiration to continue is your carbon dioxide level. But what happened? Patient has got breathing problem, lot of carbon dioxide in the body. The moment you gave a cut on the trachea, what happened, beta? The whole carbon dioxide leaked from the body. When there's no carbon dioxide in the body, the breathing stops for some time. Beta. So, if it is a physiology question, beta, the tracheostomy reduces dead space by 50%. Why apnea happens? Because of the CO2 washout, beta. Because CO2 washout. Because CO2 washout. See, carbon dioxide washout. Why? Because when you gave a cut on the trachea, whole CO2 leaked from the body, and this carbon dioxide, when no carbon dioxide there, how can the breathing continue? That's why for some times the apnea happens. This is a very famous question of NEET PG. CO2 washout is a cause of apnea. This must be remembered by you. Your paper question was tracheostomy can lead to surgical emphysema. Put an arrow. Surgical emphysema, put an arrow, is equal to air in subcutaneous plane. Air in subcutaneous plane. Collection of air below the skin. They asked, two questions are there. What is surgical emphysema? First question, beta. One question is this one also. Basically, collection of air below the skin is called a surgical emphysema. It's a very, confusing word. Emphysema is of lungs. No lung problem here. Surgical emphysema is air in subcutaneous plane. In your paper, they ask very intelligent question, cause. Cause is tight skin sutures. This question came in August 2020 paper. During COVID-19 beta. That was one of the very high level papers in the history of Fmge beta. But still, 12.6% people pass in that paper also. Beta. So every paper, however difficult it may be, there will be close to 180, 190 questions which you have fair idea about. Only thing is, don't do silly mistake. Don't do overthinking. Don't change choices. Too many questions. Whenever you have changed the choice, you have always regretted. 80% of cases you regretted. Pehle sahi lagaya tha. First I marked the correct one, then why did I change? Because you overthought. Because why? First you marked the answer like a very innocent MBBS doctor. then you suddenly become neurosurgeon, cardiologist, cardiothoracic surgeon, and no, it cannot be so simple. I want to think rare, and I want to change the answer to rare. Common things are asked commonly, rare things are asked rarely. When you change the answer from common to rare, you lose the marks over there. So please behave like innocent MBBS doctor, not like cardiothoracic surgeon over there. Okay, now, fine. Tight skin suture. Let me show you, beta. Let me show you this. Please see this video, beta. You put a tube through that, beta. There's a hole in the trachea and you put a tube. Now see this picture, beta. Everybody. What happens, beta? From the hole in the trachea, some amount of air keep leaking and that air collect below the skin of the neck, beta. Some amount of air keep leaking and from here, beta. Please see on the screen, beta. This is the tracheostomy, beta. Now, please see. Some amount of air is leaking from the hole in the trachea, but no problem, beta. This air will not be a problem. Why? It can easily come out from here, beta. No problem. It can easily come out from here, no problem. But some surgeon do what? To control the bleeding or whatever, they put very tight sutures here, beta. Very tight sutures here, and now air cannot come out. Too much of air start collecting below the skin, beta. This collection of air below the skin, this is called surgical emphysema. What is surgical emphysema? Not lung problem. It's collection of air below the skin. Why? Because there are tight skin sutures and the air is unable to come out. Okay, fine. Now, tracheostomy tubes. There are two types of tubes. Number one is the PVC. Number two is the metallic. No, we don't touch the thyroid gland. But thyroid gland is not removed. PVC is the main one. Please label it. They can be cuffed and uncuffed. Uncuffed, put an arrow, are used for children. Uncuffed are used for children, beta. Cuffed are most common tubes. This is the most common tube used for most situations, beta. Let us label this tube, beta. This is Vortex PVC. Cuffed tracheostomy tube. Vortex PVC cuffed tracheostomy tube. Okay. Now, two questions, beta. Now, this visual question, this photo should be known to you. This is the Vortex PVC cuffed tracheostomy tube. It is the most common tracheostomy tube used. It is best tracheostomy tube. Most common tracheostomy tube, best tracheostomy tube, best for ICU patient. Whatever the question may be, the answer will remain same. Okay, fine. Vortex PVC cuffed tracheostomy tube is the most common tube, best tracheostomy tube, best tube for ICU patient. One answer only, beta. Okay. Why cuff is so important, beta? Cuff decreases aspiration. The main thing is cuff decreases aspiration, beta. This is cuff, beta. This is the cuff. This is your cuff. Balloon is the cuff, beta. Let me show you. Okay. Now please see. Let me show you the cuff. Shivali is asking how to differentiate cuff and uncuff, beta. Can you answer, beta? Which one is cuff, beta? Tube number 2 or tube number 1? Which is cuffed? Shivali, everyone. Can you tell me which is cuffed? Is the one cuffed, beta? Dhruv, is the one cuffed? This is cuffed, beta. Read the number carefully. Don't do silly mistake, beta. मैंने purposely order उल्टा लिखा था. Brain पहले को first मान के चलता है. Okay. है ना नितेश, हो जाता ना ऐसे गलत, हम एज्यूम कर लेते हैं यही तो वन होगा ना. रीड द क्वेश्चन केयरफुली. एग्जाम में बहुत टेढ़े होते हैं भाई, मैंने जानबूझ के किया था, आई डिड पर्पसली. तो अब पता लग गया. चलो ये कफ है. नाउ व्हाट इज द रोल ऑफ कफ? कफ सील्स द ट्रेकिया बेटा. पुट दिस इज अ कफ बेटा. नाउ patient is unconscious, whatever. Now can you see beta, no saliva can go down in the lungs beta. Why? This is going to block the flow of saliva to the lungs because cuff has totally sealed the trachea beta. There is no space for the saliva to go down to the lungs beta. Okay, fine. Now cuff is placed inside the tracheostomy tube beta, in the trachea. Okay, now next one beta. Metallic tube is just optional to remember. It's very uncommon nowadays, but this tube is still there in the department. Chevalier-Jackson tracheostomy tube. Chevalier-Jackson tracheostomy tube. Not for tracheostomy tube, Arjun. Tracheostomy in children we use. Endotracheal tube is only for 1 hour, 2 hour. Tracheostomy tube is for months maybe. So we cannot use that. In children, we still use the uncuffed tube. Chevalier-Jackson tracheostomy tube. It is an outer and inner tube. Inner is longer. This is outer tube. This is inner tube. Inner is longer, but this inner is little longer. Ankush, when you go to internship now, you'll see all these practical things over there. How to achieve the seal. Everything you'll get to know over there, beta. Okay. But we have in our PG training, we know we have a bulb outside. Can you see, beta? This is a bulb over there, beta. This bulb will tell you how much pressure is there inside, beta. We can touch it and see. Okay. Now, very famous question of NEET PG. By chance tube get blocked. Put an arrow. It is airway emergency. Why uncuffed for children? Because children have got very soft trachea. If you put cuff has a lot of pressure, beta. Cuff pressure can damage the trachea for children. Okay. It is airway emergency, beta. Treatment. Remove tube immediately. And in the bracket, and put a new tube. But the answer is remove tube immediately, beta, because this is very serious situation. It's a star PG question also, beta. Why? Because if tube is blocked, how can you breathe now? So don't do suction, don't start oxygen, because the tube cannot really give oxygen to your body, because tube is blocked by secretions, beta. The secretion of the lungs have got dried up inside, totally dried up secretion inside. Now they can't be removed with the suction due to improper suction. Even if they don't try improper suction, if tube is blocked, what is the answer? Remove the tube immediately and put a new tube after that, beta. Okay, fine. Now, on the next page, right, beta, indication of tracheostomy. Indication of tracheostomy. Number one, for airway management, everybody write on the next page, airway management. In upper airway obstruction. Chinmoy, metallic is not that good actually, you're right. Infection is very high. Airway management in upper airway obstruction. Number two, for patients on ventilator, more than 7 days. For ICU patient, in the ICU. Think like a doctor. For patient on ventilator, more than 7 days. Because till 7 days, you're there an endotracheal tube. And after the 7 days, you remove the endotracheal tube, you put the tracheostomy. Number three, for bronchial toilet. Bronchial toilet. Toilet का मतलब ये नहीं है स्वमूत्र चिकित्सा. Bronchial toilet मतलब bronchial toilet स्वमूत्र चिकित्सा नहीं है, ऐसा कुछ नहीं है. Bronchial toilet you could do cleaning of lungs बेटा. Toilet मतलब cleaning. Cleaning of lungs. Okay. Bronchial toilet, beta. If you want to clean the lung, there's too much secretion in the lung, you can make a hole and do suction in the ICU patient, in the ward, medicine ward patient is suffering of COPD, and like you can do suction very easily. Beta. Number 4. Very possible question, beta. Maxillofacial trauma. This must be remembered by you. Maxillofacial trauma. Any trauma in this area, to make a hole here, the patient can breathe comfortably. No aspiration of blood, beta. Accident case, beta. Number 5. Laryngeal diphtheria. For airway management in upper airway obstruction, beta. Laryngeal diphtheria. Laryngeal diphtheria. Laryngeal diphtheria. There's a membrane of diphtheria in the larynx. By chance, you do intubation, beta. The membrane of the diphtheria will go to the lungs, and that will increase the diphtheria problem, beta. Laryngeal diphtheria. Then cervical spine injury. You know, in orthopedic, they say in cervical spine injury, the first rule is immobilization of neck. Never move the neck, better, because if you do the neck movement, the spinal cord may be damaged. But for intubation, you have to do direct laryngoscopy like this, and you make the neck like this, and then you do the intubation. This might be a big problem for a patient who has got cervical spine injury. It might damage the spinal cord also. Better. Okay? Cervical spine injury. Better. Okay. Number 7. Laryngospasm. Above the trachea problem, laryngospasm. Number 8, severe laryngeal edema. In severe laryngeal edema, you cannot do the intubation. I told you, first is intubation. If you cannot do that, then you go for tracheostomy. Can you see, beta? Please see, intubation cannot be done. Intubation cannot be done. Intubation cannot be done. Intubation cannot be done. So first is intubation. But in those situations where intubation cannot be done, then number 2 is tracheostomy. And if that time is also not left, then you do the cricothyroidotomy. It's a rare procedure. My dear friend, please don't forget maxillofacial trauma. This is a trending question nowadays in NEET PG segment. Maxillofacial trauma. Let's revise one more time. The main question of tracheostomy. Everybody, now hear me out. Now everybody hear the ma'am regarding audio for you. The tracheostomy summary. The most common site of tracheostomy is second and third tracheal ring, and it's called mid tracheostomy. But in cancer larynx, we do high tracheostomy at first and second tracheal ring. Tracheostomy reduces dead space by 50%. Tracheostomy is mostly temporary, except after laryngectomy. Tracheostomy leads to apnea. The answer is it is due to CO2 washout. Surgical emphysema means collection of air below the skin, and after tracheostomy, it is due to tight skin suture. Most common used tube for tracheostomy is Potex PVC cuffed tracheostomy tube. Cuff decreases aspiration. And tube is blocked due to improper suction. Mark the answer, remove the tube immediately. And indication of tracheostomy, remember, it's always the first option is airway management in upper airway obstruction, then bronchial toilet, any patient on ventilator more than 7 days, for a patient of laryngeal diphtheria, cervical spine injury, and very important word is maxillofacial trauma. Now this is the indication of tracheostomy. Now guys, let us go to the next topic, pharynx. After you do the question revision, then you do the question, okay? Don't do question randomly. Guys, don't do cross discussion. That will distract everyone. I know this question, ring edema. Don't write. Don't write any. This is wrong. This is wrong. I'm telling everyone, refrain from writing any other platform things over here. because this is a missed group actually, because this is not right actually. It will come on the faculty that we are, having the please do not do all that. Please let us make this only academic thing. If you have a question, you put it at the end. Don't start discussing the thing intermittently. Like any question related to this, you post it. But if you flash any other app, this thing, the admins of Mist would not be really, like acknowledging that, and it will be really reflecting back bad. It should not be done. It's not really right actually. If you have a question, write down that question. I know that question you're talking about. Rinke edema. The correct answer is dysphonia only. Beta. Please trust your notes. Beta. Trust your notes. Otherwise, you'll be wasting time on the Google search, and you will end up doing only 10 questions in 1 hour. Beta. Maxillofacial trauma means any injury of the maxilla or the mandible. So patient is not able to breathe properly due to injury of this area. There's a bleeding going on. If you do tracheostomy, two advantage of maxillofacial trauma. One is breathing is okay. Second, the blood will not go to the lungs. Better. Regarding that question of Rinke edema, you can just write the Rinke edema. One app says that this. Then what's the answer? I know that question, beta. It's dysphonia only. Have faith in your notes, beta. Every faculty would be telling you some notes. Revise that point, go forward. Because MCQ have a lot of mistakes, beta. Beta. Why laryngeal diphtheria? Now, this is a very good question somebody's asking. That's nice, beta. This is a question somebody should ask, beta. Laryngeal diphtheria, madam, membrane is there. And if you, diphtheria membrane in the larynx, if you do intubation of that patient, the membrane will go to the lungs and the problem will increase. So that's why in that case, let's go for tracheostomy. Okay. Very good. Beta. No problem. Beta. That's okay. But let us, lay the foundation, beta, like that. This is not, because this is structured way we are doing things. Chalo. Anybody now, any question left, beta? In laryngeal diphtheria, yes. In every patient, there is a problem of breathing, beta. Laryngeal diphtheria, can you imagine? Diphtheria membrane growing in the larynx will cause airway obstruction. Everybody say all clear? All any deficient question, anything you've done and you found that I'm not clear about that. Maxillofacial trauma intubation should not be done. Why? Mandible is mandible आधा टूटा था रिया उसका और patient unconscious था. तुमने laryngoscopy करी intubate करने के लिए पूरा mandible तोड़ दिया उसका. Chalo, very good, beta. Very good. So in fracture of the maxilla and face and all, you should not really do the intubation. Why? Because for intubation, you need direct laryngoscopy. Moment you put a direct laryngoscopy, you break the mandible further. Chalo. Now let us start the second topic, pharynx. Very, very important topic and scoring topic also. Easy topic, scoring topic, and easy to revise also, beta. Chalo. Everybody. Let me open this one. Very, very interesting topic. And believe me, it's a very scoring topic also. Chalo. After TP, we don't need electrolarynx. No. No, TP cannot be used in dumb. That problem is different. That problem is hearing problem. Workbook question you should do after you do the revision. Chalo. Now, everyone, pharynx. Now, first review. Aphonia is total loss of voice. Yes. Aphonia is total loss of voice. Can glottic cancer spread through blood vessels? No. Every cancer does not spread through blood vessels. Chalo. Now let's start pharynx. Now. Pharynx is a fibromuscular tube from skull base to C6 vertebra. Right on the top. On the top, right down. At C6, if you remember, at C6, the larynx become trachea. Yesterday class, we said that larynx is from C3 to C6. And at C6, pharynx becomes esophagus. Esophagus. Okay. This is very nice thing we have today. Above the C6 is different name. Below C6 is different name. Please see. Above C6, what is the name? Please see. This is larynx. This is what beta? The larynx, pharynx, vertebra. Larynx, pharynx, vertebra. Below C6, the name changes. Trachea, esophagus, vertebra. Again, remind with me. Above C6 is larynx, pharynx, vertebra. Below C6, the name is trachea, esophagus, vertebra. Okay, fine. Now, it's a fibromuscular tube. Beta. So let me show you. Everybody now focus on the screen, understand it. Beta. Chalo, let's understand it. This is the skull base. Beta. It is from skull base to C6 vertebra. Skull base to C6 vertebra. What is between skull base and C6? Your neck. In the neck, whatever hollow column you have is called pharynx. So pharynx is a fibromuscular tube from skull base to C6 vertebra. Okay. Some people must not have liked this picture in the morning, but I'm sure you will like this picture better. This is the skull base, beta, and this is C6 vertebra. Skull base and C6 vertebra. And it's a fibromuscular tube. What is the name of muscle? Constrictor muscle. Beta. Constrictor muscle. Beta. Now, everybody, let us write the name of this muscle. Beta. What is the muscle? Beta? SC. SC is superior constrictor. Number 2, beta. MC. ये वो वाला MC नहीं है, पंजाब वाला बेटा. MC, middle constrictor muscle बेटा. And number 3 is IC, inferior constrictor muscle. SC, MC, IC बेटा, है ना? Inferior constrictor muscle बेटा. Inferior constrictor has got 2 type of fibers. One fibers are the oblique fiber called thyropharynges बेटा. Thyropharynges. Circular fiber called cricopharynges. Thyropharynges, cricopharynges. Okay, fine. Now, everybody, please see on the screen. This is your pharynx. And this is your esophagus. At C6, pharynx finishes, esophagus start. This is the upper esophageal sphincter. It is also called as cricopharyngeal sphincter because it is made by circular fibers of the cricopharyngeus muscle. Once again, pharynx is a fibromuscular tube from skull base to C6 vertebra. Muscular name, muscle of my name is constrictor muscle. There are 3 muscles: superior constrictor, middle constrictor, inferior constrictor. Inferior constrictor got 2 type of fiber, oblique and circular. Oblique is called thyropharyngeus, circular called cricopharyngeus. And the circular fiber of cricopharyngeus form the upper esophageal sphincter. Okay, to find. Now look at the screen. Look at your notes. Superior constrictor, in middle, inferior. Inferior got 2 type of fiber: the thyropharyngeus, cricopharyngeus. Cricopharyngeus, put an arrow. It forms upper esophageal sphincter, also called cricopharyngeal sphincter. At which particular level? C6 level. Yeah, you can take screenshots, no problem. No video. No video record, but you can take screenshot, you can keep it for you, no problem. And I have already shared the PDF of that images with you. I'll repost it today, no problem. Nitesh, you can do that. There's a PDF, the images PDF, you can repost today in the break. Okay. Chalo. Nitesh is my, colleague. You remember 2 chief surgeons yesterday? Cricopharyngeal sphincter. Now, let's draw a diagram. This is skull base. Not chief, chief surgeons. Now, this is the pharynx. This is esophagus. At C6, the name changes to esophagus. We both are cheap surgeons, bhai. We did disaster yesterday in thyroid surgery. SC, MC, बस MC में वो मत बोल देना तुम जो तुम्हारे दिमाग में आ रहा है ना? थोड़ा सब्र रखो. MC. Now put a triangle here. In this triangle, write down KD. K dot D. This is the TP beta. This is CP. TP plus CP is IC. चलो बोल लो यार, पार्टनर इन क्राइम. Not this PDF, beta. I'll post the PDF again. This is not the PDF, beta. This is not. I'll tell you. Okay, fine. Hello, beta. I think it's clear, beta. Now this is KD and write down here SOM. We're going to discuss these two topics now: cynomolgagny, Killian disease, beta. Now, first of all, KD. हाँ, ये वाली ठीक है भाई. देखा, ये है ना चीफ सर्जन अभी जो ए के नाम से है, आयुषा शायद. एक कोई लिख रहा है, कनुप्रिया लिख रही है कि नितेश एडमिन गुस्से में हमें गलत पीडीएफ भेज रहा है. बेटा सर्जन गुस्से में है, ध्यान से रहना. Killian disease is a triangular area in the inferior constrictor muscle between the fibers of TP and CP. Draw कर लो बेटा. चलो बना लिया डायग्राम. Anybody please take a picture and post in the, if somebody has not drawn it, post in the group better. This diagram you have drawn. Let us start KD now. Main question is KD. Asked 2-3 times in your paper. Killian disease is a weak area. There is no muscle there. It lies in which muscle? Inferior constrictor muscle. First question of your paper. Beta. Second question was between the fiber of what and what? Thyropharyngeus and cricopharyngeus. This area lacks muscular support. Therefore, the weak area of pharynx. The third question of surgery, ENT, anatomy. It is site of formation of Zenker's diverticulum. Very important topic of general surgery, beta. Zenker's diverticulum, also called pharyngeal pouch, beta. Pharynx pouches out from there because there is no support for the mucosa. There is no muscle there. Must very weak area. TP and CP. Ash, please see, Ash, it's written over here. TP is written over here, na? Thyropharyngeus, cricopharyngeus written. Okay, fine. Zenker diverticulum or pharyngeal pouch, beta. Okay, Zenker diverticulum or pharyngeal pouch. This is surgery significance. For ENT people, it's a weak area. We have to be very careful. We might cause perforation during endoscopy, beta. It's a possible site of perforation during rigid endoscopy, beta. During rigid endoscopy. Okay, okay, fine. So it's a Zenker diverticulum. Okay, please see your screen, everybody. Please see. This is a area here. There is no support over there, beta. Please see. This is your pharynx, beta. From here, it herniate pouches out, beta. Why? This is ZD, beta. What is ZD? Zenker diverticulum. And from where it pouches out, that weak area is called KD. What is KD? Killian disease, beta. Okay, Killian disease, beta. Chalo. But for ENT, the significance is the possible site of perforation during endoscopy, beta. Chalo. Now look at the picture. You have another word I have highlighted. We discussed KD, beta. KD. But there's another word called SOM. Next word, SOM. Next page, beta. Okay, SOM. KD written. Now, SO. Next page, give a hiding. SOM. Sinus of Morgagni. It is space between skull base and upper border of superior constrictor muscle. It is space between skull base and upper border of superior constrictor muscle. Rigid endoscopy is absolutely done. Beta. In ENT, we do mostly rigid endoscopies. Beta. Bronchoscopy, esophagus, all are rigid endoscopies. Beta. It is space between skull base and upper border. I think this very picture very clear. Beta. SOM. Sinus of Morgagni. It is space between this one. Beta. It is space. But look at the star, black star. It is space between skull base and upper border of superior constrictor muscle. Now look at me, beta. This is your ear over here. Na? This is your ear, middle ear, middle ear. From middle ear, one tube comes to the pharynx. What is the name of tube, beta? From middle ear, which tube comes to the pharynx, beta? Eustachian tube. And there's a muscle around that tube also. And that muscle is called tensor villi palatini muscle, beta. Tensor villi palatini muscle, beta. Very good. So two structure pass through it, beta. Anatomy question, Eustachian tube and tensor villi palatini muscle passes through. This is for anatomy, beta. So let's say beta, sinus of Morgagni. Bolo beta, bolo. Sinus of Morgagni. It is space between skull base and upper border of superior constrictor muscle. Which two structure pass through sinus of Morgagni? Number one, ET. What is ET? Eustachian tube. Number two, TVP. What is TPV? TVP, tensor villi palatini muscle, beta. Okay, fine. Now, everybody go to the first page, which is the vacant page, beta. Right behind this picture, please see pharynx title page. There is this empty page, beta. Can you see empty page over there, beta? Now, write down a few things over there, beta. Question number one. Go to the first page of pharynx, which is empty. Pharynx first page is empty page, beta. Can you see that page? Now, write down first question, beta. Write down first question. Most common site of impaction of foreign body in digestive tract is. Most common site of impaction of foreign body in digestive tract is cricopharyngeal sphincter. Most common site of impaction of foreign body in digestive tract is cricopharyngeal sphincter. At the level of C6 vertebra, beta. At the level of C6 vertebra. Most common site of impaction of foreign body in digestive tract is the cricopharyngeal sphincter, which is the beginning of esophagus at C6 vertebra. Okay, very good, beta. Now, write down. Very famous question. You will be knowing this question for sure. Radiology question and all that. Question number 2, beta. Second question, beta. Write down the heading. Everybody write everything when I say it and then we discuss, beta. Coin shadow in X-ray neck. Chest. Coin shadow in X-ray neck and chest, beta. The many question, beta. We need 2 X-ray views. We need 2 X-ray views. Keep writing, beta. We need 2 X-ray views in the bracket AP and lateral view, beta. AP and lateral view. Now, put to arrow. If right now, full coin visible on AP view, and edge of coin visible on lateral view if coin is in esophagus. Very important, beta. Coin is in esophagus, beta. put an arrow. Treatment. Rigid esophagoscopy and removal. Rigid esophagoscopy and removal. Okay. Now, right now, if let's make it reverse. If edge of coin visible on AP view and full coin visible on lateral view. Coin is in trachea. It's an airway emergency. Treatment is urgent rigid bronchoscopy and removal. Urgent rigid bronchoscopy and removal. Urgent rigid bronchoscopy and removal. This is important, Bina. I'll show you. Urgent rigid bronchoscopy and removal. Please note it down. Okay. Now, everybody. Now, please see, Beta. Please see, everybody. Now. Now, please see. This is a coin. Imagine this is a coin. Now, that's the coin here. Coin. When the coin is in esophagus, it's like this, Beta. Like this. It's passing like this. In the esophagus, the largest diameter is like this. So it passes like this, Beta. So please see. If right now the coin is in esophagus, if I do the AP view, I see the full coin. But if I do the lateral view, please see, lateral view will show the edge of the coin. Now read your notes, if full coin is visible on the front AP view and the edge of the coin is visible on the lateral view, then the coin is in esophagus. But if it is in trachea, okay, fine. Please see, if it is in the trachea, it passes like this. In trachea, the largest diameter is like this, passes like this. Now, please see. Now, right now, if you do the AP view, so you see the edge of the coin. If edge of the coin is visible on the AP view, but when you do the lateral view, you can see lateral view. On the lateral view, you see the full coin. So, if edge of the coin is visible on the lateral view, on the AP view, and the full coin visible on the lateral view, then the coin is in trachea. In esophagus, it passed like this. In trachea, it passed like this. In esophagus, like this. In trachea, it passed like this. That is why you should see this thing. Now, everybody, please see let me show you the both X-ray and then you take the screen. Now, please see this one. Now, Yeah. So guys, let me show you the both X-ray and please pause the picture once you click that button. है ना? Now, let me label it. So basically, in the ESO, it passed like this button. Okay. So this is esophageal foreign body right now. Now please see. So what will happen? This is the AP view button. This is the lateral view. Somebody take a picture and post. Okay, very good. One other way is, please see, can you see AP view O beta? O. O for esophagus. When you see O on the front X-ray, na, O for esophagus also. Okay, fine. Now, please see, when the coin passes like this in the trachea, like this. Okay, now, this is what is required. This is the AP view, and this is lateral view. We need two X-ray view, but not single X-ray view. Okay, two views, but to be sure about it. Okay, but fine. In the trachea, it passes like this. So please see coin and trachea. Okay, very good. Now keep these two pictures in yours. These two pictures you have to save with yourself. Now, next is, by chance the child has taken the battery beta. Write down next question number 3 beta. Write down. Now question number 3. Disc battery in esophagus is emergency situation. Disc battery in esophagus is emergency situation beta. Disc battery in esophagus is emergency situation. जल्दी निकालना पड़ता है इसको. इसलिए जल्दी नहीं निकालना पड़ता कि बैटरी से बच्चा स्टार्ट हो जाएगा. ऐसा नहीं है. Why? Write down why. Because battery releases alkali. Battery releases alkali beta. Alkali, which can lead to esophageal perforation. Battery releases alkali, which can lead to esophageal perforation. So the treatment is urgent rigid esophagoscopy and removal. 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 The word is urgent. Urgent. Okay, fine. No. Fine. So next is how to differentiate coin from the X-ray. A coin and battery on the X-ray. How can you differentiate that? Please see. Coin has a single edge. The battery, if you can see carefully here, battery has a double edge. Double edge. Double edge. Same double edge is visible on the X-ray also. Write down. Battery will show you double edge on the X-ray. Rigid is only used, Shefali. The flexible is used for diagnostic thing in OPD beta. For the operative surgeries, we do the rigid procedures. We cannot use flexible. Can you imagine how will you give the air to the patient beta when you're doing the procedure of bronchoscopy beta? Okay, fine. So Shefali, everybody, flexible endoscope you see more in the OPD, diagnostic areas and all. In the OT, you will find more rigid things over there. Okay, fine. बच्चा चार्ज नहीं हुआ इसलिए नहीं, but alkali release will lead to perforation. And how we differentiate the X-ray feature of the coin versus battery? Battery can show you double edge, and in the double edge is very nicely visible over here. Okay, fine. Everywhere, battery anywhere you have to remove it better. You can't leave it. Trachea, esophagus, yes. Battery, you will have to do the, Dr. Vineet will cover that part, stomach part, beta. Battery will show double ring sign. Double ring, beta. Double ring. Can you see double ring? Yes. Yeah, double edge or double ring. Chalo. Now, come back to the pharynx notes, beta. Everybody, this is very, very important. I'm telling you, foreign body are creating a lot of question nowadays, beta. That's why I put a more focus in that. Chalo. Now, everybody, pharynx got three parts, beta. Three parts. Pharynx, beta. Spelling pharynx, pharynx. Three part, beta. Yeah, but M is middle ear, beta. Middle ear. Yes. Pharynx got three parts: nasopharynx, oropharynx, laryngopharynx. Nasopharynx, oropharynx, laryngopharynx. Chalo. Look at me, look at me, everybody. Everybody look at me. Behind the nose is nasopharynx. Behind the oral cavity, oropharynx. Behind the larynx, laryngopharynx. It's very systematic, beta. In the front part, you see what is there, beta. All of you look at your own, picture in the image in the mirror. Nose, naak ke piche, nasopharynx, where you have the adenoids. Oral cavity, uske piche oropharynx, where you have the tonsils. Larynx ke piche laryngopharynx. So systematic, beta. Nasal cavity, oral cavity, larynx. Column nasopharynx, oropharynx, laryngopharynx. Nasopharynx is the place of adenoids, beta. Oropharynx is the place of tonsils, hair. And behind the larynx, laryngopharynx, beta. Now, laryngopharynx, number one, is also called hypopharynx, right? This is a first part, beta. Hypopharynx, lowest part. Now, this is important question source, beta. Three parts. This is MCQ, three part. Why three? Whenever there are three parts, they can easily make a question. All the following are part of laryngopharynx except. What are three parts? Number one, pariform sinus, right and left. Okay. PS, also called, right now, also called pariform fossa. Pariform fossa. Put an arrow on both sides of larynx. So larynx, laryngopharynx. Pariform sinus is two, on the right and left, on the both sides of the larynx. Number two, PCA, post-cricoid area. Put an arrow. Post behind larynx. And number three, posterior pharyngeal wall, PPW. Posterior pharyngeal wall, PPW. Okay. Now, let's revise with everybody. What is the three part of laryngopharynx? Number one, pariform sinus, right and left on both sides of the larynx. Number two, PCA, post-cricoid area behind the larynx. Post-cricoid, behind the larynx. Cricoid is larynx now. And number three, posterior pharyngeal wall. Posterior pharyngeal wall. All of you draw the larynx here, beta. This is your larynx, beta. This is your larynx. This is red one is laryngopharynx, and this blue thing, of course, vertebra. I'm sure you remember. Is it above C6 or below C6? Anybody? Is this picture above C6 or below C6? Above, because it is below C6 is another name, trachea esophagus vertebra. Below C6 name will be trachea esophagus vertebra. So it is above C6. Very good. Now please label it a PS. What is PS? PS. What is PS, beta? What is PS? Pariform sinus, right and left, beta. And PCA, right and left. This is right and left. Okay, PCA, post-cricoid area. On the side of larynx, you have the pariform sinus, beta. PCA is post-cricoid area, and this mucosa is PPW. Posterior pharyngeal wall. Beta. Posterior pharyngeal wall. Very good. Beta. Now please see. This is a visual question of NEET PG. Very possible in your paper. And this answer is pariform sinus. If you ever see an arrow on the side of larynx, is pariform sinus. Beta. If you ever see its arrow on the side of the larynx, it's pariform sinus. Also called pariform fossa. Sinus and fossa. This is the NEET PG question, very likely in your paper. If you ever see a question with the, on the side of the larynx, whatever you see an arrow, mark it pariform sinus. Also, sometimes they write pariform fossa. It is one and the same thing. Beta. It's a food tract. Beta. Please see, it's a food tract. Beta. This is your larynx, beta, and this is your laryngopharynx. My dear friend, this is the laryngopharynx, beta. This is PS, PS. This is PCA, post-cricoid area, and this mucosa is called PPW, posterior pharyngeal wall. Am I clear, beta? Fine. On the both side of larynx, but the arrow PSPS, but PSPS, pharynx sinus, but PCA, it's one channel, beta. It's a food channel, beta. This is the laryngopharynx, beta. Now, all of you see the video, beta. Now, where is the laryngopharynx in the yesterday video? This was your larynx, beta. Larynx, okay, very good. So this is your larynx, beta. Okay, now, everybody focus. Can you see larynx vocal cord? Can you see arytenoid? Something will open on the side of the larynx and behind that. Whatever will open now is laryngopharynx, beta. Please see, beta. 1, 2, and 3. This is laryngopharynx, beta. Ye kya, beta? Larynx. Larynx. Let me open laryngopharynx. The word is, beta? Laryngopharynx opening for you, beta. So larynx is visible. Now I open laryngopharynx for you. Once again, larynx is the air tract of your body. It ends into trachea. This is your laryngopharynx, beta. On the side of the larynx is piriform sinus. Behind that post-cricoid area, and the PPW is posterior pharyngeal wall, beta. Once again, बेटा, मुझे कभी समझ नहीं आया MBBS में, बेटा. मुझे सच में कभी समझ ये कहाँ होता है laryngopharynx, बेटा. मुझे तो larynx तो दिख जाता है. Actually, larynx is like this, visible. But मेरे को PG में समझ आया, अरे भाई ये था अपना laryngopharynx. 1, 2, larynx, laryngopharynx, larynx. I open laryngopharynx. On the side of the larynx is on the side of the larynx is piriform sinus. Behind that is the post-cricoid area, and this full mucosa at the back of the picture is PPW. What is PPW, beta? What is PPW? Posterior pharyngeal wall, beta. Yes, that's the vocal cord, beta. Of course, that's white thing is vocal cord, beta. Chalo. Now, most common site of hypopharyngeal malignancy is piriform sinus. Piriform sinus. Okay. Right. Most common site of hypopharyngeal malignancy is the piriform sinus, beta. Okay. VQ, a visual question, beta. Okay, fine. Whenever you see any arrow on the side of larynx, it's definitely piriform sinus, beta. This is piriform sinus. That's the question, beta. The main thing is don't forget piriform sinus, beta. Don't overthink and change the answer. Okay. Esophagus will be down this. If you go from piriform sinus down, you'll enter esophagus. Dr. Vineet will be showing you that. Okay. Ye rasta, esophagus. Please see. If you go from here down, beta, from here you go down, 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 you take the endoscope down like that, you go enter the esophagus. If you go from here, you enter the trachea. So please see, beta, this is number 2. If you enter from the number 2 gate, you enter trachea. If you enter from the number 1 gate, you will enter the esophagus, beta. Okay, chalo. Laryngopharynx इसलिए ओपन हुआ कि मैंने इसको रिक्वेस्ट करा है अर्जुन पाठक. I've made the patient do a maneuver to open it up. Yes, food go through this. Okay. Now, chalo. Next is the internal branch of SLN. Internal branch, not behind that. Below that. If you go from pharynx down, you go to esophagus. Okay. Now, please. Now let me go to the next page. Internal laryngeal nerve. I told you yesterday also. It's a very important nerve. If you remember, on the sensory nerve supply of larynx, it's the main nerve to prevent aspiration. It gives sensory supply to number 1, supraglottis, number 2, piriform sinus. Supraglottis, number 2, piriform sinus. Okay, fine. Supraglottis, number 2, piriform sinus. Now please see on the screen, beta. This is your pharynx. This white thing is what, beta? Vocal cord. And I'm sure you remember, this is supraglottis of your larynx. What is PS? Piriform sinus, right and left. Now there is one nerve, beta. Yesterday class, ILN. What is ILN? Internal laryngeal nerve, also called internal branch of superior laryngeal nerve. it gives sensory supply to supraglottis. And the same nerve gives the sensory supply to piriform sinus also. Okay, but you're fine. So once again, let's revise, beta. Fine. The internal laryngeal nerve, also called internal branch of supralaryngeal nerve, it gives sensory supply to supraglottis and number 2, piriform sinus. And if you remember yesterday class, this is the main nerve to prevent aspiration. It's a branch of the vagus nerve ultimately via supralaryngeal nerve. Now please see, this is your air tract. This is your food tract. Air tract, food tract. Okay. So this is the air tract, this is your food tract. So you have to really, be careful when you eat. Actually, food can jump from this area to that area. That's why this nerve is if this nerve gets stimulated, you get to cough so that you bring that thing out actually. This nerve does not allow aspiration. Okay, fine. So the very important question is internal laryngeal nerve. Shefali, esophagus will be down below it. When you go, you take an endoscope down, beta. Okay. Esophagus will be shown in the surgery, beta. If you take your endoscope from it downward, after C6, esophagus will come, beta. Now, let's revise, beta. Internal laryngeal nerve, other name of internal branch of supralaryngeal nerve, it gives sensory supply to supraglottis and piriform sinus, beta. Okay, fine. Now, patient presents in emergency with throat pain due to accidental swallowing of the fish bone. Bengali hoga pakka. Bengali bande mein hilsa kha liya. Hilsa fish, very tasty fish. Yeah, particularly the hilsa which comes from Bangladesh is very tasty, but very careful to eat. A lot of bones, small bone hilsa, and by chance one fish bone got stuck in the somewhere, and surgeon removed the foreign body. While removing foreign body, surgeon injured the internal laryngeal nerve. Where was the foreign body stuck? Piriform sinus. Because you just said that piriform sinus is supplied by internal laryngeal nerve, and surgeon has damaged which nerve, beta? Internal laryngeal. That's why answer is piriform sinus. Beta. Okay to find? No. Chalo. Now. Chalo. Everybody okay? No. So this is a very important question, beta. This is a very important question. Keep in mind, beta. No. Everybody tell me, what is this arrow, beta? Somebody asked, explain the picture, beta, of the... This is your... Where is the epiglottis, beta? You have gone, just take the endoscope below the epiglottis, beta. Epiglottis is above this. Endoscope can be at this level. Now are you below the epiglottis level, beta? That's why every picture will not show epiglottis, beta. Okay, fine. Both, yes, very good. Now, Ganesh has said very good thing, beta. Yes. Piriform sinus, both are... Actually, it is one system, beta. Ganesh has said very right thing. This is one system, bache. It's in continuity with each other. Like this, it's continuity. That's why these all things, if you go through any route, beta, any gate number 1, piriform sinus, beta. Gate number 2, piriform, gate number 3, postbed area. Whichever gate you enter, all 3 are together, they will enter into esophagus. After C6, esophagus will start, beta. Very good, beta. Fine. Now, this is piriform sinus, beta. Explain the question again, beta. Now, the question. Please see, which nerve got damaged, beta? Internal laryngeal nerve. So where was the foreign body stuck? Which area is supplied by the internal laryngeal nerve? Piriform sinus, beta. Okay. So basically the surgeon damaged which nerve? Internal laryngeal nerve. He's asking where was the foreign body stuck? The answer is the piriform sinus, beta. Yes. Yes, absolutely. Chalo. The question is clear, beta? Okay. Now, laryngeal crepitus, beta. Everybody hold your larynx like this. Hold your larynx like this, beta. Hold your larynx and move it right, left on the vertebra. Move it right, left on the vertebra. Can you feel a clicking sensation? Daba ke karo. Can you ऐसे रगड़ते हुए जाओ बेटा, रगड़ते हुए. Can you feel that gritty sensation? जैसे कि larynx आपके vertebra पे रगड़ रहा हो. In English, you feel a clicking sensation when you're rubbing it. Yes or no? Yes or no, beta? Okay, fine. Now, clicking sensation felt when larynx moved or cervical vertebra. This is absent in. This is a normal finding everybody has. It's absent in post-cricoid carcinoma. अगर नहीं आया तो कौन सा कैंसर है बेटा? पोस्ट क्रिकॉइड कार्सिनोमा। अगर ये नहीं आया आपके तो कौन सा कैंसर है बेटा? पोस्ट क्रिकॉइड कार्सिनोमा। अब जिनके नहीं आया ना बेटा, वो अपनी गर्दन दबा के पूरा चेक करेंगे। अब तो देखना, अब तो नहीं भी आ रहा तो कर करके वो दो चार बार चेक करेंगे, है ना? दोबारा करो जिनका नहीं आया, क्योंकि अगर नहीं आया, इफ यू डोंट हैव दिस क्रेपिटस, देन यू हैव व्हिच कैंसर बेटा? पोस्ट क्रिकॉइड कार्सिनोमा बेटा। ओके, पोस्ट मर भाई, ज्यादा जोर से दबा देना। पोस्ट क्रिकॉइड कार्सिनोमा। Okay, fine. What is post-cricoid area, beta? Anybody? What is PCA, beta? Post-cricoid area, my dear friends. By chance, you have cancer in this area. Please see. Oh, you have got cancer in this area. Don't you think so? If your cancer is the post-cricoid area, this cancer will not allow the larynx to reach the vertebra. This cancer is between the larynx and vertebra, beta. Larynx and vertebra will go away from each other. So, in post-cricoid carcinoma, PCA, the larynx cannot touch the vertebra. That is why this is going to be fine. Now, next one, beta. This is okay. Now, everybody, डराओ मत। अगर नहीं आया तो डराने, ना बता रहा हूँ, डराने और बताने में फर्क होता है जी। व्हाट इज आंसर एवरीबॉडी? ब्रेक देंगे 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 देंगे। ब्रेक में 60 सेकंड बचे हैं बस। चलो बताओ, 60 सेकंड्स फ्रॉम द ब्रेक। व्हाट इज आंसर? चलो चलो, जो क्वेश्चन आए वो भी तो पता होने चाहिए। पारिफॉर्म साइनस पे, है ना? कोई डाउट तो नहीं किसी को? कोई डाउट तो नहीं है? पारिफॉर्म साइनस। चलो, वेरी गुड। चलो पढ़ो क्वेश्चन। आई नीड पीजी क्वेश्चन। ऐसे लिखना बेटा, क्वेश्चन नंबर 10 का आंसर, 10 का आंसर लिखना बेटा। 10 का, 10 का, 10 का, या व्हाट इज आंसर बेटा? सी, internal laryngeal nerve. Why? Because he kept a xylocaine in piriform sinus. Beta. Piriform slide which nerve? Beta? Internal laryngeal nerve. This is applied anatomy question. Beta. Yes, look at the question. This is actually the question which will need some thought. Think beyond notes. Beta. Ratta maar lena. Piriform slide by internal laryngeal nerve. That is 100 questions. Beta. 100, 105 questions. But next जो 100 question है वो think beyond notes. Beta. Get ready for that. Okay? ये हमने कर लिया जी बेटा। क्वेश्चन नंबर 11 नाउ। 11 व्हाट इज आंसर बेटा? इंफीरियर constrictor. Killian Dyson belong to which muscle? Inferior constrictor. Very good. Yes. Now question number 12. Answer is 12 का आंसर। तो 12 का ए लिख रहे हो, ध्यान से देखो। 12 का आंसर है सी। एज ऑफ द कॉइन विजिबल ऑन द लेटरल व्यू इज द ईसोफेगस बेटा, है ना? ऐसी गलती नहीं करनी पेपर में। ट्रेक जल्दबाजी में गलती हो जाती है ना बेटा। फाइन, बहुत इजी है बेटा। देखो ये देखो बेटा, जब अगर फ्रंट पे देखो बेटा, देखो इधर देखो बेटा, बहुत इजी है, ज्यादा मुश्किल नहीं है। अगर फ्रंट एक्सरे में एज दिख रहा है, जस्ट इमेजिन वन मोर लाइन ओवर दैट। What is T? T for what, beta? T for trachea. T for trachea. And if you see the O for esophagus, beta. बहुत सिंपल है। फ्रंट में अगर पूरा दिख रहा है O for esophagus, और अगर एक लाइन दिख रही है ऐसे देखो, अगर लाइन दिख रही है तो इमेजिन वन मोर लाइन ऑन टॉप ऑफ दैट एंड यू जस्ट सी O, it become what, beta? Trachea. That's all. Okay. Now. Last question, beta, before the break. All are part of hypopharynx except. मैंने ऑप्शन चेंज कर देना अब। 13 का आंसर है सी, वेलिकुलर पार्ट ऑफ ओरोफेरिंग, डिस्कस करेंगे आगे। चलो लेट्स टेक ए ब्रेक हियर एंड आगे हम शुरू करेंगे नेजोफेरिंग्स और ब्रेक ऑफ 15 मिनट्स। चलो वेरी गुड। जाने पहले कुछ लोग वीडियो देखना चाहते थे, वो वाला दोबारा से प्लीज से गो। लैरिंग्स इज द एयर ट्रैक बेटा, ये एयर ट्रैक है। अब जब हम खाना खाते हैं, व्हेन यू ईट फूड इट ओपन्स बेटा लाइक दिस, लैरिंगोफैरिंग्स, ये लैरिंगोफैरिंग्स, दिस इज लैरिंग्स। व्हेन यू ईट फूड इट ओपन्स बेटा लाइक दैट, लैरिंगोफैरिंग्स। ये लैरिंग्स हमेशा दिखता रहता है। ये मैंने लैरिंग देखा आपका, ये लैरिंग्स, और ये जो अभी खुला लैरिंगोफैरिंग्स बेटा। वेलिकुलर पढ़ेंगे बेटा, पढ़ेंगे, विल डिस्कस वेलिकुलर डिस्कस। चलो ऑल ओके बेटा, फाइन। चलो फिफ्टीन मिनट्स बेटा। Hello guys, welcome back. Let's start the next part now, nasopharynx. Okay. Now, the last word on the notes was if laryngeal crepitus is not there in post-cricoid carcinoma due to any other reason, then the name of that sign is Moore sign. Absence of laryngeal crepitus is called which sign? Moore's. M-O-U-R-E. Moore's sign. Absence of laryngeal crepitus is called Moore sign. M-O-U-R-E. Everybody, are you there, beta? Welcome back. Okay. Fine. Yeah, Moore sign, beta. Sure. Now let us start nasopharynx, beta. So basically, nasopharynx is the space behind the nose, beta. To put it simply, the area behind the nose, is called nasopharynx. And I told you nasopharynx is that place where you get to see the adenoids actually. It has two important landmarks, beta. What are two important landmarks? Number one is the eustachian tube opening, and number two, adenoid tissue, which is lymphatic tissue, more prominent in children, beta. Everybody, the nasopharynx, NPX, beta. NPX, nasopharynx, let's start that now. It's the area behind the nose, and it has got two important landmarks, okay? The eustachian tube and adenoid tissue. Now let me label it, beta. This is your number one is the eustachian tube opening, and this tissue is called adenoid. Normal adenoid tissue is lymphatic tissue. This much normal adenoid is there. Now, very important concept for everyone. Guys, as I told you, your middle ear is, what is ME, middle ear. Your middle ear is connected to nasopharynx through ET. What is ET? Eustachian tube. This is the eustachian tube opening. Okay. Now this is ME with the middle ear. I hope you remember, ear is connected to the pharynx through eustachian tube. Your middle ear mucosa is producing mucus continuously, and this mucus is coming via this eustachian tube opening, and it comes to your, pharynx. Pharynx. It's a continuous process like that. But by chance, any problem happens, and the eustachian tube gets blocked. For example, the adenoid becomes bigger in size. Please see, this is adenoid, beta. Adenoid became bigger in size and it blocked the eustachian tube opening, beta. Okay. Now, the mucus cannot come to the pharynx. Middle ear producing mucus continuously. Now, the mucus is unable to come to the pharynx, beta. Now, that mucus start getting thicker and thicker and thicker. This thick mucus is called glue ear. What is called a glue ear? The thick mucus, the disease is called glue ear or serous otitis media. We'll discuss it as a complete topic in ear again, and that's the glue ear. Glue ear. Glue ear. And I think you will say that, that if the middle ear is full of glue, can you conduct sound normally to the inner ear? No. So you will be having CHL. What is CHL? Conductive hearing loss. Okay, fine. Now, if you read this blue line paragraph, read with me. The eustachian tube connects middle ear to nasopharynx. Therefore, nasopharyngeal diseases can lead to middle ear diseases like glue ear, also called serous otitis media, which lead to conductive hearing loss, CHL. This is a very important integrated question of pharynx and ear asked by the examiner in FMG paper, NEET PG paper. Now, there are three topics in nasopharynx. One is adenoid problem, one benign tumor called angiofibroma, and number three, nasopharyngeal carcinoma. Write down. They can lead to glue ear. Can cause glue ear. So, nasopharyngeal diseases can lead to middle ear diseases like glue ear, and that there can be integrated question of pharynx with the ear. Let us already know about it. Now, everyone, now we'll discuss glue ear as a complete topic in the ear. No problem. Now, everybody go to next one. The first topic, right? Number one, first topic is adenoid. Adenoid is also called nasopharyngeal tonsil. It's also a type of tonsil, but tonsil with a lymph, right? Tonsil means lymph tissue. What is tonsil? Tonsil is a general word. Tonsil matlab lymph tissue in pharynx. Lymph tissue in pharynx. Okay. Adenoid is a collection of lymph tissue in nasopharynx. It's a collection of lymph tissue in nasopharynx. Okay. Now, it has no capsule, no crypt, no definite blood supply. In the bracket, it is ill-defined tissue. Ill-defined tissue. No capsule is there, no proper blood supply is there. There is blood supply, but no named artery. There is blood supply, but no definite blood supply. Not a single artery supplying this area. Any random artery supply this area. Okay, now. It is present at birth. It increase in size up to 6 years of age. In every child, they are there at birth. They increase in size up to 6 years in every child. Normal physiological increase in size. They start decreasing in size at puberty and disappear by 20 years of age. By 20 years, they are completely disappeared. Adenoid is a normal tissue. It's a lymph tissue, very useful in children. In every child, adenoid keep increasing in size up to 6 years. Everybody, what is this structure? Anybody? Eel matlab not properly defined. Jonathan, eel matlab not properly defined. It's a little scattered tissue. What is the number one? Number one is ET opening, ET, not ET, not ET, ET opening. And this is number two is adenoid. Number two is adenoid. Very good. Now, please see. This is the number one endoscopy, number two. Both are normal. Can you see in a child, you see beautiful adenoids. But in adults, adenoid disappear. Adenoid disappear by which age? 20 years. So this must be a child, adult about 20 years of age. Okay, beta, fine. Wonderful, beta. Wonderful. Can you see both are normal endoscopies, beta? Both are normal, beta. Both are normal. Both are normal. Normal. Both are normal. This is for the child, for the adult. It's a normal endoscopy for the one for the child, one for the adult. So one is adenoid disappear in adult by 20 years. Take a picture, post in the group, beta, for revision. Okay, very good. Now, please see. Now, right now, adenoid, one more line. It's a single mass. Single midline mass. Like we have two tonsils in the throat, no? But adenoid is only one. With two tonsils, right tonsil, left tonsil. But adenoid is a single midline mass. But single midline mass. Okay. Draw like this. This is your adenoid. Adenoid. And please draw on the both side ET, ET. Both sides is eustachian tube opening. But adenoid is a single midline mass. On the both sides, we've got one opening of the eustachian tube. Very good. So let's revise this much again. Adenoid is lymph tissue in the pharynx. It is ill-defined, not properly defined, because it has no capsule, no crypt, no definite blood supply. They increase in size up to 6 years. They disappear by 20 years of age. That's the main point, but it's a single mass. Now, everybody, adenoid hypertrophy is a disease. Hypertrophy, too much of enlargement. It's a disease of school-age children. Adenoid is a very important question. This time also it came better. In March paper also, in July paper also came better. It is more than physiological enlargement of adenoid. More than physiological enlargement. Everybody tell me, adenoid increase in size up to which age, beta? Up to which age adenoid increase in size, beta? 6 years, 6 years. So, more than that, normal enlargement is the hypertrophy, beta. 6 hypertrophy. It is due to recurrent upper respiratory infection. It is due to recurrent upper respiratory infection. It is due to recurrent upper respiratory infection. Okay. Now please see what a hypertrophy means. Too much of enlargement. Now everybody look at this picture, beta. Look at this picture. Now you tell me, beta, everybody, which is normal picture, beta? Which is normal picture? Which is normal picture? Who is normal, beta? What is the diagnosis of number one? Can you see? What is the diagnosis of the picture number one, beta? 2 is normal, you're right. 2 is normal. And this is adenoid hypertrophy. Adenoid hypertrophy. Here you have lot of space to breathe. But here you can't breathe, beta. The nose is blocked from behind. Nose is blocked from the behind, beta. So let us see this child, beta. The child cannot breathe through nose. So typical, problem will be mouth breathing child. And the look of the child is called adenoid face, beta. Guys, whenever you get the MCQ with mouth breathing child, it's a question of adenoid hypertrophy. Do not change the answer. Do not become neurosurgeons on that day and think of rare possibility, chondroma, chordoma. Don't do all that, beta, because whenever you have changed the answer, ultimately you have found, I just marked it correct first, beta. So let's learn from that mistake. Everybody says, sir, mere test mein number kam aa rahe. I said, that is okay. Everybody, it will be first revision, second revision, third revision. Then only after third revision, you get some idea about the subject. Till that time, please learn from the mistakes, just silly mistakes, beta. And whichever point you don't know when you do the test, like today test, please go back to the note and see that question at least, beta. You never know which question will come on the exam day. Hai? Fine. No. Next one is the look of the child is called adenoid face, and adenoid face has 4 features. Let's write this is number 1 is the open mouth. Number 2, pinch nose. High palate. Crowding of teeth. Crowding of teeth. Open mouth. Main thing is open mouth, beta. Dental alignment is not proper. Palate is high. Pinch nose. Nose is useless actually now. Patient is not breathing through the nose. Patient is breathing through the mouth actually. Okay. Let us say, everybody, the 4 feature adenoid face, beta. Let's revise. Number 1, open mouth. Everybody speak with me. Number 1, open mouth. Number 2, pinch nose. Number 3, high palate. And number 4, crowding of teeth, beta. Now, number 3 is rhinolalia clausa, in the bracket, dull voice. When the nose is blocked, you have a dull voice. Like you get cold, na? Dull voice. Anybody? Rhinolalia clausa is hyponasality or hypernasality? Hyponasality or hypernasality, beta? Rhinolalia clausa is hyponasality or hypernasality? Hypo, very good, hypo. Crowding of teeth, teeth is not properly aligned. One teeth is above, because when the palate is problematic, teeth is also problematic. Palate, teeth are part of what? Palate only, no? Okay. Glue ear. Mostly bilateral. Mostly bilateral, no? As you would agree with me, there is one adenoid, beta. And there are 2 eustachian tube. If it is largest, mostly it will block both eustachian tube opening, beta. Mostly bilateral, but can be unilateral. Some people get so rigid about the notes, they don't think about patient, they think about their line written in the notes actually. It's not always bilateral, it's mostly bilateral. Okay, fine. The failure to thrive, this is a pediatric term. Failure to thrive means child is not gaining weight and height. कुछ लोग बोलते हैं ना ओपीडी में आगे, डॉक्टर धवन मेरे बच्चे का वेट ही नहीं बढ़ रहा, मेरे बच्चे की हाइट नहीं बढ़ रही, माई चाइल्ड इज नॉट गेनिंग वेट, माई चाइल्ड इज नॉट गेनिंग हाइट. द टेक्निकल पीडियाट्रिक वर्ड फॉर दैट इज फेलियर टू थ्राइव. ओके, एंड देन ओएसए बेटा, ऑब्स्ट्रक्टिव स्लीप एपनिया. ऑब्स्ट्रक्टिव स्लीप एपनिया बेटा, है ना, ऑब्स्ट्रक्टिव स्लीप एपनिया. During breathing, during sleeping, the you can say these system is totally blocked beta. Obstructive sleep apnea. Let's revise once again beta. The main clue in the question is mouth breathing child beta. Head nod face, 4 feature, open mouth, pinched nose, high palate. Crowding of teeth, मतलब teeth are not aligned beta. Look at me. Your teeth have got space, and then crowding of one another teeth is overriding with each other beta. Basically, dentition is not proper. You can just see that. Okay. Now, the surgery is called adenoidectomy. Okay. Position of patient during surgery is called a rose position. Rose position is about neck extension. You can see in the picture also, neck is extended under general anesthesia. Same position is used for tonsillectomy also. Okay, same position is used for tonsillectomy also. Over neck extension, please see better. Don't extend the neck too much. It can lead to a very serious complication, atlantoaxial subluxation. Atlantoaxial subluxation. This is called Grisel syndrome. Very important question. Grisel syndrome. Grisel matlab name somebody's name. Grisel syndrome. Now look at me beta. Look at me. Grisel syndrome. ये सारे नाम अंग्रेजों के हैं बेटा. Guts maneuver, Treacher-Collins syndrome, Pere-Robin syndrome, Grisel syndrome. ये हमारे नाम तो है ही नहीं. इंडिया ने लिटरेचर लिखा नहीं. India never wrote medical literature, so all syndrome are the name of Europeans mainly actually. But Indian brain is very resistant to remember these names because we don't have anybody called Grisel. हमारी गली में किसका नाम Gutsman है, किसका नाम Treacher है, Collin है, Grisel है. We don't have those names as popular name in our, and that's why बहुत मुश्किल है. इंडियन ब्रेन के लिए बहुत मुश्किल. हमारा लिटरेचर लिखा नहीं. हमने लिखा है शीरी फराद लिखा है, सोनी मेवाल लिखा है, हीर रांझा लिखा है, बट हमने लिटरेचर नहीं लिखा, मेडिकल लिटरेचर नहीं लिखा. इसलिए अगर हमने लिटरेचर लिखा होता तो बहुत ही मजा आ जाता. क्यों? कोई ना कोई सिंड्रोम होता, गुप्ता जी सिंड्रोम, शर्मा जी साइन, कोई गुप्ता जी याद आ जाते, कोई गुप्त रोग, कुछ ना कुछ याद आ जाता है ना, किसी ना किसी बात से कोई बात मिल जाती तो कुछ चीज याद आ जाती. बट ये अंग्रेजों के नाम है. इट्स टफ टू रिमेंबर बट मेक सम स्टोरीज, है ना. ओके, नाउ ग्रिसल मैंने कैसे याद रखा था? ग्रिसल, लुक एट मी. अगर आपने साइकिल चलाया है, साइकिल, इफ यू डन साइकिलिंग, संडे को साइकिल वॉश करते थे, साइकिल वॉश द संडे, देन आफ्टर वॉशिंग द साइकिल वी यूज्ड टू पुट लॉट ऑफ ग्रीस ऑन द चेन. ग्रीस लगाते थे चेन पे ताकि फ्रिक्शन कम हो, फास्ट जाना होता था ग्रीस. बट जब भी आपने ओवर ग्रीस लगाई, अगर आपने कुछ ज्यादा ही ग्रीस लगा दी, ओवर ग्रीस लगाने से क्या होता था, पहला ही पैडल मारते चेन एक्सल से सबलक्सेट हो जाती थी. कुछ ओवर करने से चीज सबलक्सेट हो जाती है. ग्रीस मतलब ग्रिसल सिंड्रोम, ओवर नेक एक्सटेंशन से अटलैंटोएक्सियल सबलक्सेशन हो जाता है. ओके, फाइन. पुट एन एरो. चीफ कंप्लेंट, neck pain and spasm after surgery. Neck pain and neck spasm after surgery. Okay, fine. Why failure to thrive beta? Because the child is not getting proper oxygen beta. The system is blocked already, na? Hai na? The oxygenation is improper. Okay, now everybody. Now Grisel syndrome is important question. If you could, after surgery, if the child is crying with neck pain, neck spasm, think of which question. Grisel syndrome. Write down method of surgery. Write down conventional method. Conventional method of surgery is curettage. Curettage. Grisel syndrome is the name beta. If you do overextension of neck, there will be subluxation of C1, C2 vertebra. Atlantoaxial subluxation due to over neck extension. That disease is called Gristle syndrome. Rose position. Rose position. Rose position. The name of position during surgery is rose position. And if you see the rose position, it is neck extension, but don't do over neck extension. That can lead to atlantoaxial subluxation, which is called the Gristle syndrome. If a child is crying with neck pain and spasm after surgery, think of Gristle syndrome. Method of surgery is curettage. Okay. Name of instrument is St. Clair Thompson adenoid curette. Method of the curettage, put an arrow. For the curettage, what is the name of curette? St. Clair Thompson adenoid curette. Put an arrow. It's a blind surgery. So, more chance of bleeding. It's a blind surgery, so more chance of bleeding. It's a blind surgery, so more chance of bleeding. Okay, fine. Now, everybody, please do the stream run. Let me show you. We cannot see what we are operating in this case because the patient is under general anesthesia. The position is rose position. This curette is called St. Clair Thompson curette, and this is adenoid removed. Blind procedure, beta. Blind procedure. भगवान जाने आपने क्या निकाला बेटा? एडिनॉइड निकाला है कि आपने सेरिबेलम निकाल दिया उसका पकड़ के? क्या पता सेरिबेलम वहां से हर्निएट कर रहा हो और आपने सेरिबेलम निकाल दिया. More chance of bleeding, more chance of complications. है ना बेटा? Fine. Okay. So it's a blind surgery. The name of surgery is the anodectomy. The method is curettage, and this instrument is St. Clair Thompson curette. Blind matlab you cannot see beta. Okay, fine. Okay, so that's why there is the possibility of more complication, more bleeding. Beta. Now there are new methods available. Just write down next one. Write down beta. Write down new methods. Numerical surgery is number one, coblation. Coblation is best method. And this is the MCQ of July paper. We have new method now, coblation. Coblation, controlled ablation, no bleeding. Coblation. Number two is suction diathermy. Diathermy is cautery better. And number three, coblation, suction diathermy. And number three is the microdebrider. This is a cutter, microdebrider. Put an arrow. These are endoscopic guided methods. You see when endoscope and operate, so less chance of bleeding. The main word here is coblation. Coblation is the best method. Don't forget it. Coblation is controlled ablation. Coblation is the controlled ablation. You will see I'll show you. With the endoscope, you see and you remove the adenoid while seeing it, and there is hardly any bleeding. Okay, fine. Okay. Now, coblation is controlled ablation. So, coblation, suction diathermy, microdebrider are endoscopic guided methods. So, less chance of bleeding. But what is the best method of surgery? Coblation. Let us see coblation. I'm seeing the adenoid with the endoscope. This is a hole in the adenoid. This is a coblation tip. It's a coblator. Coblator. Can you see it's removing the adenoid? But hardly any bleeding. There's no bleeding at all. Adenoid, you are removing adenoid, no bleeding बेटा. ये तो ऐसे जैसे किसी को मार भी रहे हो और रोने भी नहीं दे रहे बेटा. रोने भी नहीं दे रहे उसको बेचारे को, मार भी रहे, रोने भी नहीं दे रहे बेटा. ब्लीडिंग होने नहीं पा रही बेटा, है ना. देखो कितना प्यारा सा एडेनॉइड, यू सेफ सर्जरी बेटा. देखो देखो, नो ब्लीडिंग बेटा, नो ब्लीडिंग, है ना. फाइन, याद रखना. थोड़ी सी ब्लीडिंग होगी यहाँ पे और थोड़ी सी ब्लीडिंग हुई यहाँ पे, चुप रहे, कोई बात नहीं, ओके ओके ओके, बंद करा दिया, होगी ब्लीडिंग, बंद हो गई. वाह. सो इट्स एंडोस्कोपिक गाइड मतलब. फाइन, नाउ वेरी गुड बेटा. So please do remember the word Grissel syndrome. How we manage Grissel syndrome? We refer to neurosurgeon. Beta. This patient will go to neurosurgery people. Okay. Do remember the method of coblation, rose position, etc. Beta. It's not laser. It's a coblator. Coblation is not laser. Beta. Okay. Fine. It's in the operation theater under general anesthesia. Beta. It's a child of 6 years. Beta. Okay. It's not laser. Beta. Now, everybody. Adenoid is important question. It was asked this time in the paper, beta. Okay, so the second topic of this is angiofibroma. Yeah, it's cutting and coagulating at the same time, but not laser, beta. It's not laser. It's cobblator is a new technique, beta. But the most safest method is the best method is coblation, beta. Now, okay, chalo. No answer. My best method is coblation, beta. Coblation is written over there, bache. MB is written over there, beta. Best method. Do you think curettage can be best method, MB? Do you think curettage will be best method, beta? Now, angiofibroma, beta, also called JNA, beta. JNA, juvenile nasopharyngeal angiofibroma. Juvenile matlab it is seen in younger kids. Nasopharyngeal tumor, that's why nasopharyngeal angiofibroma, beta. Okay, fine. Now, it is the most common benign tumor of nasopharynx. Nasopharyngeal tumor. It's a benign tumor. Beta. Okay. Okay. Site of origin is sphenopalatine foramen. In nasopharynx, there are many areas. Okay. Sphenopalatine foramen. If they ask you best method, Raman, it's coblation. It's a highly vascular tumor. Look at the word, angio. Angio is the blood vessels. It is made of blood vessels. Okay, angio. It is seen in adolescent boys. Adolescent boys. 12 to 16 years. Okay. The surgery you saw was coblation, beta. So it's a look right now here, beta. It's a benign, locally invasive, highly vascular tumor. 3-point beta, benign, locally invasive, highly vascular tumor. 3-point to remember. It's a benign, locally invasive, highly vascular tumor of NPX. What is NPX? Nasopharynx. It's a benign tumor. It's a locally invasive tumor, but it is a highly vascular tumor. The name is angio, मतलब blood vessel. It is made of blood vessels. Okay. Now, it is locally invasive. It can go to nose, cheek, orbit. In orbit, proptosis will happen. You know what is proptosis? The eye will come out, and that is called frog face deformity. Frog face deformity. Frog face deformity. Number 4, brain. So the eye comes out. Eye comes out, and the deformity is a very popular question. The eye coming out. See, adenoid face was different, beta. The mouth is open, is adenoid face. Let us compare this with the picture of this one. The eye is coming out, beta. Let me label it. Proptosis. Proptosis, beta. In angiofibroma, the tumor can go to the eye also, and that lead to frog face deformity. What is the proptosis? The eye coming out. Somebody take a picture, beta. In angiofibroma, what is the name of look? Frog face deformity, and basically it is about the proptosis. Proptosis. Okay. So open mouth is adenoid face, eye coming out, eye protruding out. Proptosis in angiofibroma is frog face deformity. Okay, fine. Now, brain can also be involved. It's a benign tumor, beta. It will not spread through blood. But in locally invasion can be happen, beta. 12 to 16-year-old boy with a nasal mass with profuse epistaxis. When you see three things in the MCQ, beta, three things in the MCQ, beta. See, if you see 12 to 16-year-old boy with a nasal mass and with the profuse epistaxis, think about the angiofibroma. This is not frog face deformity, beta. This is Cruzon. Okay. Now, 12 to 16-year-old boy with nasal mass with profuse epistaxis. Okay, fine. Now, let me show you a question of your paper, beta. That what question has come in MCA very regularly about angiofibroma, beta. Now, can you see, beta, your paper question? 12-year-old boy, male child, present with nasal mass and profuse epistaxis. Epistaxis is bleeding from the nose, beta. Epistaxis is bleeding from the nose bleeding. Okay, fine. So young boy, nasal mass, bleeding from the nose, epistaxis. What is the answer, beta? Angiofibroma, beta. So young boy, nasal mass, epistaxis, angiofibroma, beta. Okay. Anybody? What would you like for this, beta? Question number 14. What is the answer? मैंने आंसर चेंज कर दिया ऐसे 14 का आंसर 14. अच्छा इसका आंसर भी डी इसका भी डी चौथा का आंसर भी डी दोबारा सोच लो बेटा एक बार रिव्यू करके दोबारा फाइनल आंसर पोस्ट करो बेटा व्हाट इज द आंसर ऑफ 14 क्वेश्चन बेटा थिंक अगेन इफ यू वांट टू Very good, beta. Very good. Let me tell you the answer. What is the answer to this question, beta? The answer to the question is, what is the answer, beta? Socho. The answer is still D only, beta. Angiofibroma. D only, not A. Don't change the answer. मैं सोचने ही बोलता हूँ तो आंसर चेंज कर देते हो है ना मैं यही हटाना चाहता हूँ मैंने बोला सोचना दोबारा सोच के अच्छे से लगाओ दोबारा आंसर चेंज करके कांड कर दिया ए लगा दिया नहीं यार इतना बड़ा क्वेश्चन है इतना सिंपल तो नहीं होगा इतना कुछ लिखा हुआ है ना ये तो बहुत ज्यादा हो जाएगा है ना इसका आंसर भैया डी रहेगा ध्यान देखो पेपर ऐसे पास करना है हमने ये तो देखो पेपर ऐसे पास होगा बेटा ये तो देखो सब में तो देखो चलो आयो न्यूरो सर्जन वाले बन गए ना दिमाग है ना मैंने एक बार बोला सोच लो फाइनल प्लीज सी जिन्होंने आंसर नहीं चेंज किया उन्होंने सूत्र समझ लिया कि पास होना कैसे है देखो यंग बॉय है नेजल मास है एपिस्टेक्सिस है यहां तक तो एंजियोफाइब्रोमा है नाउ मोर फीचर कमिंग हाइपोनेजालिटी ऑफ वॉइस नोट्स में तो नहीं है कंडक्टिव हियरिंग लॉस नोट में बिल्कुल भी नहीं है चीक स्वेलिंग ये भी नहीं है भाई ये पॉइंट तो डॉक्टर धवन ने लिखवाया ही नहीं फालतू की बातें करके चले गए है ना तुम्हें लगता है तुम्हारे एग्जामिनर ने ये नोट्स पढ़े हुए हैं डू यू थिंक योर एग्जामिनर रेड दीस नोट्स नेवर दे डोंट इवन नो दैट दीस काइंड ऑफ नोट्स एग्जिस्ट ऑन द प्लैनेट उनके दिमाग में अपने केसेस होते हैं कॉन्सेप्ट्स 45-year experience, HOD, head of department, very senior people are there, beta, working as very qualified surgeons, very good administrator, total busy life. Paper questions are designed after 10 o'clock. When everything is done after dinner, they open up their laptop, open up their brain, which is full of cases, concepts and all, no books, no books. And they open the bottle also, teacher bottle. Teachers. They open the bottle also. Now, when the first 60 ml question, first 60 ml are sweet question like this. First 60 ml, very sweet question like this. Wow, young boy, nasal mask, everything. One more 60 ml. One more 60 ml. Yeah. ये 120 ml वाले क्वेश्चन है 120 ml वाले क्वेश्चन ये प्लीज सी ये जो यहां तक है ना ये तो 60 ml का था ये वाला जो इफेक्ट है ये प्लस 60 ml का एक्स्ट्रा इफेक्ट आ गया भूल गए किसको पूछ रहे हैं सुबह जो केस है मॉर्निंग केस dull voice then cheek swelling whatever was there written but can they change the science? No, they can change the way they ask the same science, but even if they add extra rare symptom, if the main theme of question is matching with your answer, do not change the answer. Answer will remain NG Fabrum only. Okay, fine. और जब बेटा बता रहा हूँ 180 ml and above, फिर आते हैं वो क्वेश्चन खतरनाक वाले, जैसे लास्ट पेपर 1 वाले क्वेश्चन है ना पिछली बार, सारे 180 ml and above थे. सारे क्रिप्टोजेनिक जीन गामा 123 is linked with all of the following disorder except. तुम्हें ये भी होता है क्रिप्टोजेनिक जीन क्या होता है गामा 120 तो बहुत दूर की बात है. सो पेपर में टाइप ए क्वेश्चन विच यू नो स्ट्रेट फ्रॉम द नोट्स लाइक दिस. These are 100, these are type A question beta. 100 to 105, 110 question will be this category beta. I'm talking about difficult paper. Then paper these are type B question, means extra thing written, little bit more thought. Think beyond notes. How to solve TBN is think beyond notes beta. Think rationally. Young boy है, nasal mask है, episis है, I'll not change my answer beta. और फिर आते टाइप सी क्वेश्चन. सी तो फिर सी होते, तो पता ही है बेटा, है ना. सी तो फिर सी होते हैं, तो उनका टेंशन नहीं ज्यादा लेनी बेटा, वो तो आएंगे बेटा. Till now, nobody has scored 300 out of 300 in FMG paper. It means the topper is usually around 230 to 235 is the average highest score, 235. So even though they don't know 60-70 question, yeah, it's okay, no problem. The game is out of 200 question beta. Type A 100 question, type B 100 question, type C 100 question in a difficult paper like last time paper was like this kind of paper. Type A question 100, type B 100, type C was 100 question like that. 100 was unknown question, PSM was totally unknown question, but still there were type A and type B question which were collectively close to 185, 190, you can say. People who played smartly, did not change the answer, stick to the main concept, they were on the other side of 150. If they can do, we can also do better. Okay, fine. Chalo. Now, let's go back. Now, let us write the extra symptom. अब लिख लेते हैं. Plus minus cheek swelling, plus minus dull voice, plus minus conductive hearing loss due to glue ear. Can we revise it, beta? Young boy with nasal mass, epistaxis, plus minus cheek swelling, dull voice, conductive hearing loss, or glue due to glue ear. These are maybe there, may not be there. Cheek swelling, dull voice, and plus minus conductive hearing loss. Okay, fine. Now, next one, beta. Let me show you the cheek swelling picture, beta. The cheek swelling picture. This one. Now, this is a tumor which has started from here, beta. Tumor was here, from behind the nose, from here. It came to the nose, came over here, nasopharynx. Then it went to the cheek over here. It's a low, benign but locally invasive tumor. Now there is this maxillary sinus here, beta. The tumor has pushed the posterior wall of the maxillary sinus, beta. This sign on CT scan is called the Hallman-Miller sign, beta. Investigation, biopsy is contraindicated. This is a very famous question. It's such a vascular tumor, never do biopsy. Number two, the CT scan or the CECT will show the Hallman-Miller sign. It is anterior bowing of posterior wall of maxilla. Anterior bowing means push. Bowing means push. It is anterior bowing of posterior wall of maxilla. Bowing means push. Tumor pushes the posterior wall of maxilla forward. This is called the Hallman-Miller sign. Bowing means push. Push. Anterior bowing of posterior wall of maxilla. Anterior bowing of posterior wall of maxilla. Please see. I'm talking about this one. Please see. Once again, let me draw it for you. After this thing, everybody please see. This is maxilla, and maxilla contain one sinus called maxillary sinus. Now tumor is over here, beta. Tumor is behind the nose, in the nasopharynx. First you come to nose, then go to cheek, like this, and it reaches cheek. While doing this, what it does do, it pushes the posterior wall of maxilla forward. It pushes the posterior wall of maxilla forward. Tumor pushing the posterior wall of maxilla forward. This is called Hallman-Miller sign. Okay, Hallman-Miller sign. Now let me show you on the CT scan. When I label it, then you click a picture. First of all, CT shows Hallman-Miller sign. It's a feature of angiofibroma. Okay, so this is axial CT. Look at me, axial like this. Like this is axial. This is coronal, but axial is this one. This is normal side. This is tumor. This red arrow is a tumor. M is maxilla. M is maxilla. This red is the arrow is a tumor. Tumor has pushed. This is the posterior wall of maxilla, normal side. This is the posterior wall of maxilla, no, disease side. Can you see the red arrow? The red arrow is the tumor. It has pushed the posterior wall of maxilla forward. This radiological sign is called Hallman-Miller sign. This radiological sign is called Hallman-Miller sign. Okay. So this is an important question for radiology also. What is the Hallman-Miller sign? The tumor pushes the posterior wall of maxilla forward, defined as anterior bowing of posterior wall of maxilla, and that called Hallman-Miller sign. Okay, fine. Number 3 is angiography. We always do for vascular tumor angiography to find out what is the main source of blood flow for tumor before surgery. And the treatment is surgery. Treatment is surgery. Fine. Let's quickly revise the angiofibroma. Let me record a summary for you for angiofibroma. Everybody, now please see. Let me record it for you. Juvenile nasopharyngeal angiofibroma, also called angiofibroma, is a benign, locally invasive, highly vascular tumor of nasopharynx arising from sphenopalatine foramen. It's more common in young males, 12 to 16-year-old boy. The tumor can go into nose, cheek, orbit, and brain. The orbit part will cause proptosis, and that is called frog face deformity. The MCQ comes like this: young boy, 12 to 16 years with nasal mass and perfuse epistaxis. There can be cheek swelling, dull voice, or conductive hearing loss given along with that. Biopsy is contraindicated, and the CECT shows Hallman-Miller sign, which is anterior bowing of posterior wall of maxilla. We also do angiography, and treatment is surgery. Please label it the angiofibroma summary. What is Hallman-Miller sign, Aditya? Just see this tumor. See this one. This red arrow shows tumor. The white line shows posterior wall of maxilla, and this tumor, red arrow means tumor, is pushing the posterior wall of maxilla forward. Look at this arrow, beta. This red arrow shows tumor. It is pushing the posterior wall of maxilla forward, beta. Okay. Chalo. Angiography will be taught by the radiology people, beta. Angiography can be done. I'm telling you, it's an investigation, beta. Biopsy is contraindicated, beta. Now, Govind, how can you confuse Hallman sign with mumps actually? I'm not understanding your question. Mumps is a viral parotid swelling, beta. Angiography will tell you by which artery is the most common source of blood supply for the tumor, beta. Now, the next one, beta. The third topic of nasopharynx is NPC, beta. Nasopharyngeal carcinoma. Angiography will tell you what is the most common source of blood supply for the tumor, beta. Because you should know it before surgery. Because by chance surgery has a lot of bleeding, which artery I should ligate, beta. Okay, fine. Now, NPC, beta, nasopharyngeal carcinoma, it is more common in China. Please don't say that you are confusing mumps with this tumor, beta. Govind, can you please tell me? And the person who replied that how can you confuse mumps? This is a highly vascular tumor. Mumps is a parotid gland swelling, beta. Are you saying mumps only or some other problem? Mumps is viral parotid gland swelling, beta. Don't even think about mumps. Differential diagnosis cannot be like that. You cannot confuse Parkinsonism with nephrotic syndrome, beta. Can you confuse Parkinsonism with nephrotic syndrome? Govind, can you elaborate your question? So mumps is a different disease altogether, beta. This is what I'm telling you, that you need to up your game, beta, because paper is getting stepped up now. Because if we keep thinking bizarre, just atypical things, the paper is changing, metamorphosing in a very high level manner, beta. Let me be very clear with you. Last time paper I analyzed pretty in detail, actually. This was almost of the same level as NEET PG is currently. Certain areas were higher than NEET PG, beta. Does mumps have epistaxis? Forget about that, beta. Does mumps have epistaxis? No, na. Then how can you confuse, beta? That's what I'm saying. The most important thing, which is the learning of last two papers, is you guys need to clinically imagine situations in a very, able manner, like a clinician does actually. For that, differential diagnosis means that you have to think two most probable thing, beta, not two differently not related thing, beta. Then we'll be confused with the wrong two choices, beta. Hai. First, zero down to two most common diagnosis, beta. Then go for the commoner diagnosis over there, beta. Okay? I hope you understand my point, beta, because that is my major concern, beta. Because FMGs really work hard. FMGs got a brilliant, mind, sufficient IQ to handle the data. Time is a problem, and the second problem is we have not seen cases in our university postings actually. That makes it a little more challenging task for you guys, because when you've not seen the cases, you tend to confuse. Genuinely, if I would not have seen the cases, I will genuinely, tend to confuse between bizarre things also. But as you're studying, try to be more imaginative. I understand you've not seen the patient, that's a problem. But when you feel like mumps versus angiofibroma cannot be at all a differential diagnosis. Mumps, parotid gland swelling, fever, pain in parotid area. This is a young boy with a nasal tumor, nasal mass, and epistaxis. And Hallman sign is a radiological sign, not a clinical sign. CCT. Now, what Govind has said now, a lot of people like to. I'm not pointing the finger at Govind. This is not your issue. Actually, this is the issue of many FMG students actually. What I've identified, because last paper we had a good one score, but this paper I really deep dive into it. Actually, it's my habit. Actually, I don't deal superficial thing. I didn't do that many interviews with the people who passed the paper, but I actually checked upon those people who scored between 141 and 149 after studying the second time, third time in such a proper manner with a lot of like dedication actually. One thing was very evident actually, that people don't imagine the clinical situations actually. That is what is creating me like little bit concern, that this batch we should be telling straightforward the paper is moving the direction of NEET PG. Clinical conceptual question are dominating the paper. So for that, this analytical capacity to compare and differentiate and think, analyze is important rather than just mugging up data. The era of just mugging up data is over in FMG exam. Let me be point blank and clear with you. Era of doing old style questions, era of doing old notes only, era of doing only rapid revision is getting very drastically over now in the FMG paper. Let us be informed today. What is the right thing I should do? When I read intersusception in surgery, I must look for any other thing which I can think about as a differentiator. I cannot confuse the intersusception with sigmoid volvulus actually. You have to see the age bracket is different and symptomatology is different. So don't have this thing as a bizarre thinking. Now let us start thinking clinical. Now let us focus on this topic, NPC, and see how we do that. Okay, fine. Surgery done is, what is surgery done? We remove it. We remove it. There's no name of surgery. Nasopharyngeal carcinoma, NPC, is more common in China. If it is Chinese cancer, the etiology has to be a virus. That's why very popular question. Epstein-Barr virus. It is Chinese cancer, so it has to be a virus etiology. Is a proven and 2-time MCQ. Cytosis Fossa-Rosenmuller. This is a star question. Fossa-Rosenmuller. This is a visual question of NEET PG this time. This fossa lies just above ET opening, right? Remember this yellow arrow is FOR. This is very important. Now, please see, it will lead to unilateral ET blockage. Please see, very soon this cancer will grow from here. It will block the eustachian tube from here. Okay, fine. Okay. It will lead to unilateral glue ear, also called ceostritis media, and then do unilateral conductive hearing loss, CHL. Unilateral, single side. Okay, I think we already discussed that nasopharyngeal diseases can lead to middle ear diseases like glue ear. Okay, but adenoid is seen in children, mostly bilateral glue ear. This is the adult patient. Adult. (50 to 70 years). 50 to 70 years. Now, NPC is a hidden cancer or occult primary. So put an arrow. Most common manifestation of NPC is metastatic. Cervical lymphadenopathy. Fossa-Rosenmuller is an anatomical area. It's just an anatomical area above the eustachian tube. It's not for any function. It's just a depression there. It is also called a secondary neck node. Fossa-Rosenmuller is an area of anatomy. Secondary neck node. This is a very famous question. Glue ear means the collection of sterile mucus in the middle ear, which is very thick like glue. We'll discuss glue ear in the ear also, but mucus become thick like glue, and the collection of that is called glue ear, beta. And when the glue is in the middle ear, you cannot conduct sound normally. Therefore, there's a conductive hearing loss, beta. CHL. This is a hidden cancer or occult primary. So the most common manifestation of this cancer is metastatic cervical lymphadenopathy, beta. Look at screen, everybody. This is your FOR, beta. Somebody asking what is FOR? This is FOR, fossa of Rosenmuller. And this is your eustachian tube opening. My dear friend, I think it is understandable that if the cancer start from here, within few weeks or months, it will cover the eustachian tube. And this will lead to, in the middle ear, which problem? Glue ear, beta. And glue ear on one side, the patient is adult, and it will lead to unilateral conductive hearing loss also in that patient. Okay. Now, it's a hidden cancer. Right behind the nose, the cancer is growing. Nobody knows that. Why? Nobody can see behind the nose. Cancer is growing this area. Nobody can see behind the. Can you see behind your nose, my nose? No. So without you getting known that you have a cancer, it's an unknown primary, occult primary, hidden cancer. Okay. So without your knowledge, even that you have a cancer, it will metastasize to neck nodes. There will be big lymph node over here. So the most common presentation of the NPC is metastatic cervical lymphadenopathy. Patient will come to my clinic and he'll say, Dr. Dhawan, I have got these neck swellings. Patient does not know he has a cancer. Even I don't know he has a cancer. Maybe this neck node can be tuberculosis. This neck node can be sarcoidosis. This neck node can be lymphoma. I don't know. I order a test called FNAC. What is FNAC? Fine needle aspiration cytology. After a few days, patient come to my clinic and the report is metastatic squamous cell carcinoma. It's a metastatic secondary, beta. I don't know where is the primary. Now, when I do the nasal endoscopy, I put the endoscope in the nose, I see behind the nose a big cancer over there. So it's a reverse diagnosis. Otherwise, what happened, beta? You have a breast cancer patient. After breast cancer, you diagnose, you check the axilla for lymph node, the secondary lymph node, beta. Here, the secondary neck node is in front of you. You don't know the primary, hidden primary, occult cancer, occult primary. So the most common presentation of this cancer is metastatic cervical lymphadenopathy or secondary neck node, beta. Guys, this is the skull-based cancer, beta. It causes paralysis of cranial nerves, beta. Anybody? Nasopharynx, the upper part of pharynx. Anybody? Pharynx is from what to what? Write down in the chat box. Pharynx is from what to what, beta? Pharynx is from what to what? Level. Pharynx is from what to what? Level, beta. Skull base. Very good. The first word, very good. Skull base to C6 vertebra. Look at me. Skull base has got many foramina of cranial nerve. You remember? Rotundum, foramen ovale, jugular foramen, hypoglossal canal. All are lying where, beta? On the skull base. Therefore, there are cranial nerve palsies in this patient. So we have a triad, beta. Because of the cranial nerve palsy, we have a triad called a Trotter's triad. Now, Trotter's triad is seen in NPC. The mnemonic is also NPC. What is NPC? Nasopharyngeal carcinoma. But the mnemonic is also NPC, beta. What is N? The neuralgia in word is missing, beta. In temporoparietal area due to fifth nerve, trigeminal nerve involvement. There's a lot of pain in this area, beta. Neuralgia in temporoparietal area due to fifth nerve involvement. Palatal palsy due to 10th nerve involvement. And conductive hearing loss, beta, due to glue ear. Okay, due to glue ear. Now everybody knows glue ear. Collection of glue in the middle ear will lead to hearing problem, conductive hearing loss. All unilateral, beta. All unilateral. All unilateral, beta. Okay. Secondary neck node, beta. Secondary neck node. Okay, let's revise, beta. The name of triad is Trotter's triad. It is seen in NPC. What is NPC? Nasopharyngeal carcinoma. And the mnemonic is also NPC. N for neuralgia in temporoparietal area due to fifth nerve involvement. P for palatal paralysis due to 10th nerve involvement. And C for conductive hearing loss due to glue ear, beta. Treatment is a very famous question. The best answer is chemoradiation. The second best answer, I told you, where a symbol is there, matlab, if this is number one choice, second best choice is radiotherapy. Chemotherapy with radiotherapy is a very good idea, best treatment. By chance, chemoradiotherapy is not in the choice, then you write a radiotherapy as a treatment of choice. Okay. Anyone, any question on nasopharynx? Anyone, any question on nasopharynx? Adenoid, angiofibroma, NPC. Any question I missed? I have not answered, beta. All okay, beta. All right, and all okay. Any question pending in your mind that I don't understand that? Okay. Okay. We don't do in NPC. You don't do surgery, but it's a very radiosensitive tumor. Fortunately, we don't prefer chemotherapy, beta. Starfish. We're saying chemo radiation. It's a combination of chemo with radiation, beta. When I say chemo radiation, matlab main thing is radiotherapy. Chemotherapy is additionally, beta. Chemotherapy with radiotherapy. Chalo. Let me record the summary of this topic, beta. Now all of you revise with me in your mind, beta. Now, nasopharyngeal carcinoma, NPC, is more common in China. The etiology is Epstein-Barr virus. Site of origin is fossa or Rosenmuller, which is just above the eustachian tube opening. That's why it causes unilateral conductive hearing loss due to unilateral glue ear. The patient is mostly adult, 50 to 70 year. NPC is a hidden cancer, matlab occult primary. Therefore, the most common presentation of this cancer is metastatic cervical lymphadenopathy or secondary neck node. The name of triad is Trotter's triad. The Trotter's triad has got the mnemonic NPC, N for neuralgia in temporoparietal area due to fifth nerve involvement, P for parietal palsy due to 10th nerve involvement, and C for conductive hearing loss due to glue ear. And the best treatment is chemotherapy with radiotherapy, matlab chemo radiation. If that is not given the choice, then you mark radiotherapy. Sure. There's no specific name of surgery for angiofibroma. Yes, please label these two, everybody. Nitesh, at the end of pharynx, put the audio of angiofibroma, NPC. Okay, chalo. No name of just surgery, beta. Yes. Now, before we go to the oropharynx, beta, let us see few questions, beta. Question number 21. The answer is A, beta. Very good. Patient has got neck swelling, in the posterior triangle. His hearing is also declined on the right ear. The answer is A. A. It's a metastatic lymph node from nasopharyngeal carcinoma, beta. Now, 22. Right, 22. Now wait here, and everybody, let me tell you, how can we avoid getting stuck at 148, 149 beta? What is the commonest presentation of this NPC beta? Everybody saying conductive hearing loss. No. We just said that it is cervical lymphadenopathy. Can you identify why we get stuck up at 148, 149? I'm going point blank with your batch, beta. First time I'm being point blank because I don't want that result again in the coming session with you guys, even if paper is of that level, beta. We have to crack the paper, even if paper is of that level, because this is a known question. We do mistake in the known question also, beta. We assume things which are not. बिकॉज तुमने कंडक्टिव हेयरिंग लॉस बहुत बार पढ़ा हुआ है, तुम्हारे दिमाग में पहले कंडक्टिव हेयरिंग लॉस आएगा बेटा, और वही कहानी खराब हो रही है बेटा. Many people could have passed if they would have done 3-4 less silly mistake only, beta. I would not let that happen with your batch, let me tell you. Because I want you guys to pass the paper and start your clinical life at the earliest. This is what is stopping us to achieve it. Not the lack of knowledge, but lack of skill of attempting the paper. Beta. Did you get the answer? Tell me. Forget about this question. Did you get the hint? What I'm telling you? Where is the secret of passing this paper? Beta? Tell me. Forget about Shivai. Shivai, forget about that. Faculty will remain same. Paper will remain same. Beta. Are you getting what I'm saying? Beta? Even if the paper is difficult, Shivai, there still were 185, 190 questions which were doable, manageable. Beta. Rather than putting onus on other people, let us take responsibility. FMGs are way, way, way smarter. You are very stable people. You are very, internally strong people. We can take the responsibility on ourselves rather than putting blame on other people. Beta. Let us not blame anyone right now. वो वही करते रहेंगे बेटा, हर बार वही करते, कभी पेपर 2 डिफिकल्ट, कभी पेपर 1 डिफिकल्ट, ये चलता रहेगा. मैं कुछ उसमें, दैट इज नॉट अवर डोमेन बेटा, ठीक है. नेक्स्ट कैसे होगा ऊपर वाला जाने, ओनली. बट व्हाट आई एम सेइंग, प्लीज टेक दैट with lot of clarity. Even if the paper is that difficult as the last paper was, we can crack the paper if we just did right now this kind of thing we don't do in the paper. Beta. Are you getting my point, beta? Absolutely. बस जैसे ही गलती करी ना, ऐसे सीख लेना है. डरना नहीं है कि यार क्यों क्यों गलती हो रही है, ये नहीं सोचना. अरे अच्छी बात है गलती हो रही भाई. ये लोग सोच के, अरे मेरे से गलती, सर मैं सिली मिस्टेक बहुत करता हूँ टेस्ट में. अरे भाई ये टेस्ट की कोई वैल्यू है? बताओ ना यार, कोई वैल्यू नहीं है. अच्छा सिली मिस्टेक करके इन्हीं सिली में से सीखेंगे. लेट अस नॉट रिपीट द सेम काइंड ऑफ मिस्टेक इन द पेपर. एक्चुअली दैट इज द लर्निंग. Your how many marks are coming in the test, Tuesday test, this test, that test, has no value for me, to be very honest. I'm glad you're doing mistake, but there are two reaction after mistake. One, मैं क्यों कर रहा हूँ ऐसे, मेरा कैसे होगा, मेरा तो नहीं होगा यार, मेरे से तो होता ही नहीं है, पता नहीं क्या प्रॉब्लम है, मेरा ही दिमाग कमजोर है शायद. दूसरे लोग वो होंगे जो यार अगली बार ऐसी गलती नहीं कर, अगली बार ऐसी गलती नहीं कर. तुम कैसे बनना चाहते हो बेटा, कैटेगरी 1 और कैटेगरी 2? टेल मी. यू वांट टू सल्क, व्हाई डिड आई डू दिस मिस्टेक, मेरे से नहीं होगा, मेरे से नहीं हो पा रहा है, मैं ही ऐसी गलतियां करता हूं. या तुम समझदार बन के ये बनना कैटेगरी 2, मतलब सब गलतियां करते हैं पर मैं ये वाली गलती दोबारा नहीं करूंगा. प्लीज अंडरस्टैंड दैट बेटा. Let us learn from the mistakes. No, yaar, I have done a lot of mistakes in my life, but it's not that it's easier, but we have developed our thought process on our own. But I'm sharing with you what I've learned in years to really reach this level of clarity that mistakes do happen, beta. Mistakes karna, but repeating the same mistake is not a good idea. But, fine. That is what actually. Let us not do the ENT as a subject only. My aim and wish and prayer is that may you all pass the exam. Whosoever, like 2,000 people are studying together, may God bless your hard work, beta. May God bless your hard work. May you pass the paper. But only thing is 148, 149, 147 can be easily avoided by just looking, because this question looks like aata hai mere ko. Then once we come out, yaar ye galti kaise ho gayi, hai na? That is what we have to. But we have to learn from our mistakes, beta. Very good, beta. From today onward, we'll not concern about how much marks I scored in this paper or that one. Did I learn from my mistake or not? Number one. Number two, did I do those questions from our notes which I was not able to answer in the paper? Biopsy is not diagnostic. Biopsy is contraindicated with a, right. Question number 27. Beta. 27 is angiofibrillary. Fine. Chalo. 28. Unilateral, it cannot be SNHL. It is unilateral conductive hearing loss, but not bilateral. है ना? चलो 29. Was soft Rosenblatt. This is used taken tube opening. 30th. Epstein-Barr virus. That is Epstein-Barr virus. Very good. So let's start oropharynx now. Behind the oral cavity is oropharynx, beta. Okay. When you check somebody's oral cavity, you know, please over there, beta, please see. This is the oral cavity. Between the teeth is oral cavity, beta. Please see, this is tongue depressor. This is tongue depressor. And then you open the mouth. And right behind the oral cavity, this area, uvula, palate, you know, tonsil, this is the oropharynx area right now in front of you. Okay. Now, basically, whatever is in between your teeth is the oral cavity, beta. Okay, this area is OPX. What is OPX? Oropharynx. OPX. This is oropharynx. Actually, tongue has two parts, beta. Anterior 2/3 of tongue, posterior 1/3 of tongue. Palate has got two parts, hard palate, soft palate. Anterior 2/3 of tongue and hard palate are part of the oral cavity. Posterior 1/3 of tongue and the soft palate is a part of oropharynx, beta. Now, draw, beta. Oropharynx has got the following parts. Soft, right, number one, soft palate. Number two is uvula. Number three, anterior posterior tonsillar pillar. Between the two pillars is tonsil called palatine tonsil. Posterior 1/3 or base of tongue that contain lingual tonsil. You know, lymphatic tissue was a lingual tonsil. Lingual tonsil. PPW, what is PPW? Posterior pharyngeal wall. And number 8 is vallicula. What is vallicula? Put an arrow. What is vallicula? It is space between base of tongue and epiglottis. Space between base of tongue and epiglottis, beta. And epiglottis. Space between base of tongue and epiglottis. Space between base of tongue and epiglottis is called vallicula, beta. You know now where the tongue ends, epiglottis is there, beta. The space between base of tongue and epiglottis is called the vallicula. Vallicula. Okay. Now, you guys can everybody. Now this is your oropharynx. Let me label it for you. First of all, this is the soft palate, uvula, anterior and posterior tonsillar pillar. Between the two pillars, there is tonsil, which is called the palatine tonsil. On this side also, on this side also. This is BOT, base of tongue. On this, we have got small lymph tissue called lingual tonsil. And this is the PPW, posterior pharyngeal wall. Okay, fine. Posterior pharyngeal wall. Okay, somebody take a picture and post it. The uvula, soft palate, anterior posterior tonsillar pillar. Between the two pillars is a tonsil called palatine tonsil. The real tonsil. On the base of tongue, we've got lingual tonsil and posterior pharyngeal wall, and vallicula is the space between base of tongue and epiglottis. Space between base of tongue and epiglottis. Very good. Fine. Sure. Now, everybody, Let me show you vallicula, beta. All of you see on the screen, everybody. This is your larynx. We saw that on the other day. Guys, please see, this is your base of tongue. Let us go slow. Now, this is your tongue, teeth, end of teeth, up to teeth oral cavity. This is in front of you is the uvula. Now can you see soft palate, two pillar? This is the tonsil. Right there in the valley, in the deep in the well, you can see epiglottis. There is the this is the uvula, and there lies the epiglottis. Can you see there is some space between the base of tongue and epiglottis? That space is called, this space right now, when the tongue is ending and there is in the well there is the epiglottis over there on the side. On this side you see over there. This is your epiglottis. This space between the two is called vallicula. So vallicula is the space between base of tongue and epiglottis. Okay, fine. It's already marked in the image. Okay. Now, all of you, let's revise with me the various parts of oropharynx. Okay. All of you draw here, beta. Draw a picture. Okay. This is your soft palate, uvula. Draw the soft palate uvula, and this is the base of tongue. These are two pillar, tonsil. This is your oropharynx. On the oropharynx, this is your lingual tonsil. Lingual tonsil. Now you know vallicula, valley beta. When the base of tongue ends, epiglottis start. There's a space between base of tongue and epiglottis, and that valley between the base of tongue and epiglottis is called vallicula. Okay. Fine. Chalo. Now, can we go further now? Next one. Bed of tonsil. Bed of tonsil, it is made by superior constrictor muscle. Protrusion of tongue and epiglottis got no relation with it. It's independent. Bed of tonsil is made by superior constrictor muscle. Look at me, everybody. Look at me, everybody. This is your bed of tonsil. Everybody touch the angle of mandible. Let me show you like this. All of you touch the lobule of pinna. This is the parotid gland, angle of mandible, and below the angle of mandible, this area, beta. This area is the bed of tonsil. Everybody, this area is the bed of the tonsil. Touch the bed of tonsil. This is the bed of tonsil. There are three muscles, superior constrictor, middle constrictor, inferior constrictor. This is the bed of tonsil. Okay, it is made by which muscle? Superior constrictor muscle. Superior constrictor muscle. Okay, so bed of tonsil is made by superior constrictor muscle. Two structures lie in the bed of tonsil. Styloid process and glossopharyngeal nerve lie in the bed of tonsil. I think you would agree with me. From the brain styloid, the glossopharyngeal nerve is coming down. It's here. And of course, a bony process from the skull, styloid process is also here. Okay. Now, everybody, this is your styloid process. Okay. And this is your styloid process. And this is your ninth nerve, beta. Ninth nerve, styloid process. Once again, beta, the bed of tonsil is made by the superior constrictor muscle here. Two structures lie in the bed of tonsil, styloid process and glossopharyngeal nerve. And now, disease, beta. Eagle syndrome, the long styloid process touching ninth nerve lead to throat pain referred to ear. Long styloid process touching ninth nerve lead to throat pain referred to ear. This is called Eagle syndrome. Eagle syndrome or Fmge. Which syndrome? Eagle syndrome. Eagle matlab, remember the eagle holding the snake. Eagle holding the snake. Eagle syndrome. Eagle syndrome or Fmge. Look at screen, please see. As if eagle is holding the snake. Okay. Now this is the claw of the eagle. This is the styloid process. And this one is the ninth nerve. Try to remember the picture of eagle holding the snake with the claw. The claw of the eagle, jo eagle ke panje hai, the claw of the eagle, they represent styloid process, long styloid process. Or jo snake hai, jo saap hai, that represents the glossopharyngeal nerve. So you remember the pictorial memory, beta, hai na? Eagle syndrome matlab long styloid process pressing glossopharyngeal nerve lead to throat pain referred to ear. This is called eagle syndrome or Fmge, beta. Eagle syndrome or Fmge. क्या बात है, क्या ड्राइंग है यार, ये इलेक्ट्रिक ईगल लग रही है बेटा, बहुत अच्छी ड्राइंग है। तुम्हारी ड्राइंग देखकर मुझे अच्छा लगा कि मेरी भी ड्राइंग ठीक है, मतलब इसके बाद तो ईगल सिंड्रोम Fmge. बट पिक्टोरियल मेमोरी इज अ वंडरफुल मेमोरी। मैं बता रहा हूं तुम्हें, पिक्टोरियल मेमोरी नहीं भूलती पता। नाउ टॉन्सिल इज इक्वल टू पैलेटाइन टॉन्सिल। Okay, tonsil has capsule. It's lymphoid tissue, na? I hope you know. It is lymphoid tissue. It has capsule, crypt, and definite blood supply. Tonsil is also just like adenoid, but I told you the complete name of tonsil is the complete name of the tonsil is palatine tonsil. And it's just like adenoid, lymphoid tissue. Adenoid also lymphoid tissue, but adenoid has no capsule, no crypt, no definite blood supply. Beta. We said it is ill-defined tissue, not properly defined tissue. But tonsil is a well-defined tissue. Beta. It has capsule, it has crypt, it has definite blood supply. Okay. Now, we'll draw a bit of crypt like that. Crypt depression in the tonsil. One crypt is very deep. The deepest crypt is called crypta magna. The deepest crypt is crypta magna. This is crypta magna. The deepest crypt is called crypta magna. Crypta magna. Triplet depression. Tonsil epithelium has got depression like that. The crypta magna. Main blood supply of tonsil is a NEET PG question. FMG question, sorry. Tonsillar branch of facial artery. Which PYQ shall I do? 2019 onwards, beta. 2019 onwards. Okay. So 2019, 2020, 2122, and now 231, paper actually. So basically you can say roughly, 9 papers are there, but है ना? 19, 20, 21, 22 के 8 पेपर हो गए, और ये एक जो 23 का भी हुआ बेटा, है ना। तो कुल मिला के 2019 के पहले वाले क्वेश्चन ज्यादा रेलेवेंट नहीं है बेटा, है ना, बिकॉज ज्यादा नहीं कर पाएंगे। मैं इतना आइडियलिज्म डजंट वर्क बेटा। मैं ये नहीं कहता कि सारे क्वेश्चन कर लो, इतनी मोटी मोटी किताबें छपी हुई हैं, लेकिन फोकस मोर ऑन क्वेश्चन विच आर 2019 एंड आफ्टर दैट बेटा, है ना। सो दीज 9 पेपर शुड बी लाइक डन। लेट अस डिफाइन द वर्क सो दैट वी आर एबल टू डिलीवर दैट। और हर सब्जेक्ट के बेटा, हर सब्जेक्ट के कर लेने से वो PYQ टॉपिक्स से अच्छा रिवीजन मेन पॉइंट का हो जाता है, लेकिन दैट शुड नॉट बी द ओनली रिवीजन, दैट, है ना बेटा, फाइन। बट फॉर अ डिफिकल्ट सब्जेक्ट इन द एंड, इफ यू आर लेफ्ट विद सम सब्जेक्ट, you can adopt this strategy. You can do the PYQ paper, TND paper, MIST will give you test and decision paper. All those topics should be done more properly. If you find any subject bit difficult, but pharma cannot be one of them, patho cannot be one of them, OBGY should not be one of them, surgery should not be one of them, IENT should not be one of them. They are very scoring subjects and they should be taken very seriously, beta. Okay, like you, if you find any problem in anesthesia, see the PYQs of that topic, and in case you find it, but if you have a summary of, but don't adopt this strategy for the most subject. It should be only reserved strategy for the last part of preparation, in case you find it difficult to finish anything, beta. Okay, fine. But पढ़ो इतना कि हो जाए बेटा, और कुछ नहीं करना भाई, और कुछ नहीं करना है, हमने पढ़ाई करनी। कोई नहीं जा रहा अपनी कजन की शादी पे। अगर पेपर पोस्टपोन हुआ तो भी हम कहीं नहीं जा रहे, चुपचाप बैठ के पढ़ रहे। घर पे हो तो घर पे रहेंगे, यानी घूमने चले गए कहीं पे, 4-5 दिन ब्रेक भी ले लेना, कुछ नहीं करना। पेपर 4 दिसंबर के हिसाब से तैयारी कर रहे हैं, वी प्रिपेयरिंग एज फॉर 4 दिसंबर। No day should go waste. You want to take half day rest, you can take. Your family might call you, beta. If you're staying in the hostel or anywhere and all that, I don't know where most of you are staying in the. If your parents are around, call them and make them hear this. Actually, if your parents don't go for any family wedding, etc. But no festival should be needing your presence right now. In India से कोई कजन की शादी नहीं, कोई फैमिली फंक्शन पे तुम्हारी ऑब्लिगेशन नहीं है जाने की, कुछ भी नहीं है अभी बेटा, अभी कुछ भी नहीं करना है। 1-2 दिन का मामला नहीं होता बेटा। लड़कों के लिए तो 1-2 दिन का मामला होता है कि भाई यही शर्ट पहन के हम हर भी चले जाते हैं। फॉर लड़कियों के लिए ऐसे नहीं होता, पूरा तैयार होना पड़ता है, हर चीज मैच करनी पड़ती है, नेल पॉलिश से लेके क्या क्या सब कुछ मैच होता है। 2-3 दिन लग जाते हैं, और फिर उनके अपनी कजन की शादी से वापस आए घर पे, फिर से पढ़ाई करने का बैठ गए दोबारा से। फिर तुमने खोली बायोकेमिस्ट्री, फिर दिमाग पता क्या है, यहाँ बायोकेमिस्ट्री चल रही है, वहां रियल केमिस्ट्री चल रही है तो सेम ही एज है हमारी, क्या चल रहा है लाइफ में। फालतू में कुछ नहीं रखा इन बातों में, टाइम वेस्ट होगा। कोई बात नहीं, अगले साल फिर शादी आएगी, उस कजन की नहीं आएगी, किसी और कजन की आएगी, है ना। अगर और कजन की शादी आएगी और हम खुश होंगे, हमारे पेपर पास हो गया होगा, तो उस शादी में पूरा सर दर्ज के जाएंगे और अपने लिए भी मैट्रिमोनियल अलायंसेस वहां ढूंढने शुरू करेंगे, है ना। लाइफ में सही टाइम पे सही चीज कर लेनी चाहिए, थोड़ा सख्त होना पड़ता है, थोड़ा सा अपने साथ स्ट्रिक्ट हुए बिना लाइफ में कुछ भी अचीव नहीं होता। मैं तुम्हें क्लियरली बता दूं तुम्हें ये बात। अगर तुम सोचो कि मजे मजे पढ़ाई होगी तो मजे मजे मतलब टाइम भी निकल जाएगा सारा, ऐसे नहीं होता। यू हैव टू बी स्ट्रिक्ट। मैंने अभी एक डाला था ऑडियो, विदाउट सेक्रीफाइसेस मैजिक डज नॉट हैपन बेटा। सेक्रीफाइस बिना मैजिक हो ही नहीं सकता। अगर आप सेक्रीफाइस कर रहे हो, हर चीज त्याग के बैठे हो, पढ़ाई कर रहे हो, ऊपर वाला करे सब। किसी ने भी लिखा वी विल पास, मैं फिर कह रहा हूं ये नहीं बोलना होता, वी विल पास इट्स एक्चुअली नॉट अ राइट थिंग एज पर द थीम ऑफ द यूनिवर्सल डिजाइन। एक्चुअली उसके साथ नहीं मैच करती। हम बहुत छोटे हैं बेटा, बहुत ज्यादा ही छोटे हैं। वी आर सो मिनिस्क्यूल दैट वी विल पास, मतलब हम पास होके दिखाएं। मैं फिर कह रहा हूं ये नहीं बोलना है, हम मेहनत करके दिखाएंगे, हम मेहनत करके दिखाएंगे, ऊपर वाला करे कि हमारी मेहनत जो है सफल हो। मे गॉड ब्लेस अवर हार्ड वर्क। वी विल पास नहीं, मे वी पास। No, we will pass नहीं बेटा, may we pass with the blessing of our parents, our grandparents, our siblings are praying for us, and we are doing hard work, and on that day magic can happen with that. Sacrifices attract blessings better, because on that day you might be stuck with 148 question and you put 100 out of 100, you put all the guesses. Maybe you 2 extra guesses get right and you pass the paper better. This is called magic. But do you think this magic can happen without hard work? No. You have to draw the blessings for this magic to happen by doing sacrifices. Don't celebrate Diwali, Dussehra, Eid, Navratras, cricket, World Cup, IPL. ये सब छोड़ना पड़ता है भाई, छोड़ के ही पढ़ाई होती है। उसके बिना सिर्फ ये है कि आप चमत्कार की वेट कर रहे हो कि शायद हो जाए, नहीं होता है। तुम्हारा पहला पेपर है, मेरा 26वां पेपर है नीट पीजी का, मेरे को 19 साल हो गए बेटा, 19 ईयर्स हो गए। मैजिक डज नॉट हैपन विदाउट हार्ड वर्क, मैजिक ओनली हैपन विद हार्ड वर्क बेटा। Magic only happen with hard work, my dear friends. So please understand, I want to make it clear for everyone that please make sure that you understand it very clearly. Okay. The magic will only happen if we do hard work in a consistent manner. In a consistent manner. Every day, in a consistent manner. Magic will only happen if you do hard work in a consistent manner. Sacrifices attract blessings. Please print this in your brain. That's why I'm writing it for you. Sacrifices attract blessings. Nothing will happen without hard work. Consistent hard work. बिना रुके ब्रेक नहीं लेना है. फेस्टिवल्स नहीं, शादियां नहीं घर पे, ऑब्लिगेशंस नहीं, सोशल ऑब्लिगेशन नहीं, किसी का बर्थडे नहीं, छोड़ छाड़ के पढ़ना पड़ता है. Without becoming strict with you, we cannot expect nature to bless us with it. First you do the hard work, then nature might choose to bless your hard work. Okay, so always say, मैं पास होके दिखाऊंगा. No. We will pass. No. May we pass. May our friends also pass. May we pass together. May nature choose to bless our hard work, our consistent hard work. To become eligible for the blessings, you need to do sacrifices. It's a simple mathematics of life. I don't understand too much of religion. I'm not that spiritual person, to be very honest. This is what I have based my life on, actually. That's how I work. So maybe if you just like this philosophy, it might give you some comfort that मैं अपना hard work कर रहा हूँ, ऊपर वाला करे कि मैं pass हो जाऊँ. This is what actually, and seek blessing of parents also. Very important. Grandparents, parents, everyone. Chalo. Now let's go further, everyone. The tonsil main blood supply is tonsillar branch of facial artery, and the venous drainage is paratonsillar vein. Paratonsillar vein. Paratonsillar vein. Put an arrow. This vein is the main source of bleeding during tonsillectomy. This vein is the main source of bleeding during tonsillectomy. Now, tonsillectomy, there's a lot of, bleeding. A lot of bleeding is there, beta. So let's revise this one, beta. Tonsil is also called a palatine tonsil. Tonsil has capsule. Tonsil has the crypts, and the deepest crypt is called crypta magna. The main blood supply of tonsil is tonsillar branch of facial artery. The venous drainage of tonsil is paratonsillar vein, and this vein is the main source of bleeding during tonsillectomy. This vein is the main source of bleeding during tonsillectomy. Okay. Now, the tonsillectomy has got the three type of hemorrhage. Primary hemorrhage is during surgery. Let me show you. When you're doing the surgery of tonsillectomy, there's a lot of bleeding going on and on and on. Please see on the screen, everybody. You're doing tonsillectomy. You held the tonsil like this, and you give a cut on the tonsil, and the bleeding starts. This bleeding you're seeing on the screen is the primary hemorrhage. This is from anybody. Primary hemorrhage is from which vessel? This bleeding is coming, but the bleeding seen on the screen right now is coming from which one? This is primary hemorrhage. It coming from which vessel? Write the name of vessel. Paratonsillar vein. क्या नाम बेटा? Paratonsillar vein. Okay. Now you do the dissection, and then you finally dissected a tonsil, beta. Okay, fine. Then you do what, beta? Then you put a wire around this base. Okay. Then you tied that wire, tied that. The tonsil is now getting removed, beta. Now, all this bleeding which is occurring now is primary hemorrhage, primary hemorrhage, primary hemorrhage. Now you control that bleeding, beta. You put a stitch over there to tie that vein, and at the end of the surgery, it should be super clean like this, beta. And before you send the patient back to the operation theater, to the ward, it should be absolutely clean. If the patient start bleeding again after surgery, within 24 hours of surgery, it's called reactionary hemorrhage. So reactionary hemorrhage is the within 24 hours of surgery, and it is due to slippage of ligature. You tied that vein with a stitch. That stitch was loose. Slippage of ligature. Slippage of ligature. Okay, fine. Fine. ये कौन कंबल लेके सो रहा है भाई, जिसने वीडियो डाला है? ये कौन कंबल लेके सो रहा है भैया? अरे भैया कौन कंबल लेके सो रहा है? ये क्या आराम से पड़े हुए हैं? कौन है भाईजान? ये पूछो इनको, कोई इनको चाहिए, कोई दूध चाय पानी की चाहिए तो बताइए. It's an emergency, beta. Therefore, why, beta? Because it is severe bleeding. The child may die of the hemorrhage, beta. Okay. Yeah, there is a chance of aspiration. We have to be very careful during surgery, beta. It is severe bleeding. Treatment is re-exploration in operation theater. नहीं, don't delete it. रहने दो यार, अच्छा लग रहा है मेरे को तो. नहीं, रहने दो भाई, डिलीट नहीं करना है, अच्छा लग रहा है. Okay. RE reactionary, RE re-explored. RE reactionary re-explored. Primary hemorrhage right now, beta, in the operation theater. Primary hemorrhage in the operation theater, beta. Secondary hemorrhage in the ward in the 24 hour of the stay. Okay, beta, fine. Number 3 is the secondary hemorrhage. After 24 hours, mostly after 5th day of surgery, it is home, beta. Ghar pe. After 24 hours, you go home, beta. Okay. Okay. Cause infection of tonsillar fossa. But put an arrow. It is mild bleeding. Spelling correction, beta. Mild bleeding, not too much. Treatment is intravenous antibiotic. OT में होगा बेटा, OT. Treatment is intravenous antibiotics. Intravenous antibiotics. Primary hemorrhage, secondary hemorrhage. अच्छा, in OT under GA मतलब general anesthesia. Okay, OT मतलब OT. Okay, call the anesthetist again from home. It's a very urgent thing. Patient can die of hypovolemic shock. Dr. Dhawan, patient is vomiting blood. It's a severe bleeding. Why? The stitch came out, beta. But this is mild bleeding. Dr. Dhawan, when patient spits, there is a red color, beta. Reactionary hemorrhage is severe bleeding. Secondary hemorrhage is mild bleeding. Reactionary means too much of bleeding. Patient is vomiting blood. There's a serious emergency. Patient might aspirate the blood, can die immediately. It's a child only. Patient is going to hypovolemic shock. And the secondary hemorrhage is mild bleeding due to infection, and treatment is intravenous antibiotics. Beta. Okay, fine. RE reactionary, RE re-explore matlab, it's a way to remember, beta. RE, please see, RE reactionary, RE re-explore, beta. Reactionary, re-explore. That's why. How to remember this question for the paper? Okay, beta, fine. Now, let me record this. The main blood supply of tonsil is tonsillar branch of facial artery. Venous range of tonsil is paratonsillar vein, and paratonsillar vein is the main source of bleeding during tonsillectomy. There are 3 types of hemorrhage in tonsillectomy. if it is in the operation theater during surgery, it's called primary hemorrhage. And number two, reactionary hemorrhage is within 24 hours of surgery in the ward. The cause is slippage of ligature. It's a serious emergency because patient is having severe bleeding. Patient might die of aspiration of blood. So shift the patient to operation theater immediately, arrange general anesthesia, and do the re-exploration urgently. Third is secondary hemorrhage, occurs in the home after 24 hours, mostly after 5th day of surgery. And the cause is infection of the tonsillar fossa. And generally it's a mild bleeding. So admit the patient back to the ward and start intravenous antibiotics. This is a summary of the hemorrhage and tonsillectomy. Okay. Okay, fine. Now, everybody, let me show you the question. Tonsil now splice, glossopharyngeal now, beta. Now splice, glossopharyngeal now. Okay, beta. Now please see on the screen, beta. Now this is your tonsil will be bleeding. Now see this question, beta. Now splice tonsil is the glossopharyngeal now. Question number 41, what's the answer? Very good, beta. Why? Very good. Please see, on Monday, surgery was done. Bleeding started on Sunday, after 5 days, beta. Mild bleeding. It is a secondary hemorrhage. Treatment is admission and antibiotics. Okay? मेरे से लड़ना मत डॉक्टर देवन, आपने आईवी एंटीबायोटिक लिखवाया, आपने एडमिशन क्यों नहीं लिखवाया? एडमिशन क्यों नहीं लिखवाया, है ना? ऐसे यू आर डॉक्टर्स बेटा, यू आर नॉट मेडिकल स्टूडेंट्स एनीमोर, यू आर डॉक्टर्स. इंट्रावीनस एंटीबायोटिक घर पे देंगे क्या? एडमिट तो करेंगे, है ना? छोटी छोटी बातें सोचनी है बेटा, है ना? ऐसे नहीं लकीर के फकीर नहीं बनना. ओके, नाउ नेक्स्ट वन बेटा. नहीं कहीं लड़ पड़ते डॉक्टर दफन, एडमिशन क्यों लिखवाया आपने? जी बेटा 42. Shefali, why would mark C, beta? Did he say severe bleeding? Overthinking will always create problems, Shefali. Yes, 42. The answer is C. Surgery done in the morning, bleeding started in the evening. There is a profuse bleeding. It's a reactionary hemorrhage. RE reactionary. RE re-explore, beta. C. है ना? This is a clinical question, beta. चलो वापस आओ. Let's go further now, everybody. Now, just write on line, beta. Write down, beta. Most common and conventional method. Most common and conventional method of tonsillectomy. Why not we give antibiotic for home? Because patient bleeding from mouth, better. He has a lot of pain, infection, he can't eat. You have to monitor the patient. He is dissection and snare method. Dissection and snare method. Most common and conventional method of tonsillectomy is dissection and snare method. Anybody? Most common conventional method of adenoidectomy. Most common conventional method of adenoidectomy. Nitya Ghosh, it's only mild bleeding. Only mild bleeding means when patient spits, there is red color in that. It's not like too much of bleeding. Very good, beta. Very good. Very good. It is snare, beta, snare, S-N-A-R-E. For adenoid, it was curettage, na? Curettage? Curettage, yes, very good. This is dissection and snare method. S-N-A, snare means wire, that wire. Chalo. Next page, beta. Whitish membranous tonsil, this you have to remember, beta. Let me read with you. Acute membranous tonsillitis. This is a whitish membrane, beta, very common clinical thing in OPD. Number one is acute membranous tonsillitis is most common cause caused by strep pyogenes. Streptococcus pyogenes. Streptococcus pyogenes. Snare matlab wire, beta. Snare is that wire with which we cut the tonsil. Dissection kare, dissection and snare method. Number two, infectious mononucleosis caused by Epstein-Barr virus. Number three is diphtheria, is a star topic for every exam. Number four, candida is white membrane. Number five, Vincent angina must be remembered by you. How to remember Vincent is for tonsil. Vincent last letter T. T for T is tonsil, beta. Vincent last letter T. T for T is tonsil, beta. Because there is another angina of heart. Heart angina is angina pectoris. Angina pectoris. Chin angina is Ludwig. We'll discuss next topic, beta. But Vincent is T for tonsil. T for tonsil, beta. Malignancy of tonsil and leukemia. Let's revise once again all the top causes. But number one is the acute streptococcus tonsillitis, acute membranous tonsillitis caused by it's the most common cause caused by strep pyogenes. Number two, infectious mononucleosis caused by Epstein-Barr virus. Number three, diphtheria, candidiasis. Vincent angina should not be forgotten is MCQ, beta. Malignancy and leukemia. Diphtheria membrane, write 3 points, beta. Put 3 arrow. It's a pseudo membrane. Extends beyond tonsil. You can see in the picture also, it's going beyond tonsil to the palate. Number three, it bleeds on touch, bleeds on removal. The membrane bleeds on removal. 3 points about the membrane are pseudomembrane, it extends beyond tonsil, and it bleeds on removal. This is the question of your paper, beta. Diphtheria membrane, describe diphtheria membrane. Diphtheria membrane is pseudomembrane. It extends beyond tonsil and it bleeds on removal. It bleeds on removal. Once again, it is pseudomembrane. It extends beyond tonsil. It bleeds on removal. Now, right now, diphtheria, 3 points about the patient. Right now, 3 points about the patient. How the patient will be in the exam. It's a sick child with fever and bull neck. That's a classical word for bull neck. What is bull neck? Bull neck is equal to cervical lymphadenopathy. What does bull neck mean? Cervical lymphadenopathy. Cervical lymphadenopathy. So 3 points about membrane. Let's divide. Diphtheria membrane is pseudomembrane. It extends beyond tonsil. It bleeds on removal. About patient, 3 points. Sick child with fever, with bull neck. What is bull neck? Cervical lymphadenopathy. Now, Walder ring is just for your knowledge, beta. That's all. It doesn't. But you should know there's something called Walder ring. Right now, it is a ring of lymphoid tissue in pharynx. You have seen that there is a lot of lymphoid tissue in the pharynx. It's a ring of lymphoid tissue in pharynx. It's a ring of lymphoid tissue in pharynx. Okay, now the name of ring is Walder ring. The 6 parts are: number one, adenoid. Number 2, tubal tonsil around the eustachian tube. Number 3, palatine tonsil, the real tonsil. Number 4, lingual tonsil on the tongue. Number 5, lateral pharyngeal band and lymphoid follicles on the posterior pharyngeal wall. Number 1, adenoid, tubal tonsil. The single adenoid around the 2 eustachian tube are there. Around eustachian tube there are tubal tonsil, then main tonsil, palatine tonsil, then on the tongue lingual tonsil, then some small part like number 5 and number 6. Do remember the name of the ring, beta, the Walder ring, beta. Now, next one is quinsy, beta. Quinsy. This is again commonly asked topic in NEET PG and FMG both. Quinsy is peritonsillar abscess, outside tonsil. It's not intratonsillar, peritonsillar. It's collection of pus between tonsil and its bed. The basic word is peritonsillar, outside tonsil. It's collection of pus between tonsil and its bed. It's more common in adults, mostly unilateral. This is the FMG question 2 time beta. Examination. Tonsil is pushed medially and uvula is pushed beta. S word is missing. Uvula is pushed to other side. 2 findings you are shown on the exam. Tonsil is pushed medially and uvula is pushed to the other side. भूख नहीं लगी, मैं थोड़ा मतलब मैं आज ब्रेकफास्ट कम किया मैंने, तो इसलिए मेरे को लग रहा है. बट I'm eating some walnuts. कुछ खाते भी तो रहा करो तुम लोग भी, सिर्फ कार्बोहाइड्रेट मत खाया करो, कुछ थोड़ा प्रोटीन फैट कुछ लेना चाहिए, थोड़ा सा दिमाग तेज चलता है. नहीं, वॉलनट्स, आलमंड्स, काले चने जो होते हैं, भुजे हुए चने होते हैं, बहुत बढ़िया होता है. उबले अंडे, बॉइल्ड एग्स, अगर आप नहीं खाते तो यू कैन टेक, जो काले चने भिगोए होते हैं वो ले लो. खाते ना बीच में, वो भी आते हैं, रोस्टेड चने आते हैं, वो अच्छे होते हैं. दिस इज अ पस बिटर. Collection of pus between tonsil and its bed, and it has pushed everything on the other side. Number 1, tonsil is pushed medially. Number 2, uvula is pushed to other side. Tonsil is pushed medially, uvula is pushed to other side. Tonsil pushed medially, beta. Number 1 is tonsil pushed medially, uvula is pushed to other side. But the main important thing is this one, beta. There is no outer neck swelling in quinsy. And this is star visual question of your paper, beta. This image is there, beta. Okay. So tonsil is pushed medially, uvula is pushed to other side. जब भी uvula टेढ़ा है पर मेरा है, uvula टेढ़ा है तो पहला आंसर क्विंजी दिमाग में आना चाहिए. अगर uvula टेढ़ा है तो पहला आंसर क्विंजी दिमाग में आना चाहिए भाई. But only one thing to please to you. If uvula is angulated, think of quinsy as first diagnosis. Only one thing to remember and check is there is no outer neck swelling in quinsy. Okay, fine. Now, chief complaint, beta. Number 1, trismus. Trismus is difficulty in mouth. Trismus is difficulty in mouth opening due to spasm of medial pterygoid muscle. Medial pterygoid muscle, you know, this muscle is masticatory muscle. Done anatomy already. It muscle closes mouth, beta, and the mouth remain closed only. After closing mouth, it went into spasm, and now patient is not able to open the mouth. Okay. Difficulty in mouth opening is trismus due to spasm of medial pterygoid muscle. Number 2, hot potato voice, also called plummy voice, also called muffled voice. हॉट पोटैटो वॉइस और प्लमी वॉइस और मफल्ड वॉइस. पेशेंट ऐसे बोलता है, डॉक्टर मुंह नहीं खुल रहा, ऐसे पेशेंट ही इज नॉट एबल टू ओपन माउथ. डॉक्टर मेरे गले में बहुत दर्द हो रहा है, यू नो, डॉक्टर मैं खाना नहीं खा पा रहा हूँ, लाइक दैट. ओके, फाइन. हॉट पोटैटो वॉइस और प्लमी वॉइस और मफल्ड वॉइस. ओके, नाउ everybody. Number 3, there will be, of course, dysphagia. Break is after the pharynx, beta, and dysphagia. Throat pain also. Of course, you can't eat properly. Patient voice is very much typical of hot potato. Beta. I'm not able to open the mouth. I'm not able to eat properly. I'm not able to speak properly. There's something in my throat which leads to pain in throat also. Beta. Okay, but fine. Now, if you ever get a question of hot potato voice, the best answer is Quincy. Beta. By chance, the question comes, the old question, hot potato voice in number 1, Quincy, number 2, acute epiglottitis. It's written both in the notes actually, but the best answer for hot potato voice will be Quincy. Beta. Mark it. This word was first used in Quincy actually. Okay, fine. Now, treatment is per oral IND, incident drainage, and remove tonsil after 6 weeks. Beta. 6 word is missing. Beta. After 6 weeks, 6 weeks. After 6 weeks, you remove the tonsil. This is called interval tonsillectomy. Interval tonsillectomy. Okay, interval tonsillectomy. Why you remove tonsil? Because the Quincy can happen again. Okay, that's why. Interval tonsillectomy. Now, old concept, right? This is the old concept, right? Okay, old concept is this one. Old concept is some surgeons remove tonsil at the time of abscess drainage. This is called abscess or hot tonsillectomy. They used to do what? They were very daring surgeon, but a lot of bleeding was occurring, no problem. They'll remove the abscess, remove the tonsil at the same time. It will abscess or hot tonsillectomy. Why hot? Tissue are inflamed, bleeding is more. So interval tonsillectomy is a new concept now. It's a new concept. Okay, now let's look at differential diagnosis. IND, incision and drainage. IND is incision and drainage. Give a cut and drain the abscess. Incision and drainage. You can see everybody, no problem. Please see the screen. You give a cut over here with the blade and put a suction over there and just suck the pus out. This is IND, incision and drainage. Let the pus drain from that cut. Okay, fine. This is called interval tonsillectomy. Why interval? Because interval. Why? Because you are doing it after 6 weeks of interval. Interval. Okay. Now read the note. But this is for NEET PG actually. Differential diagnosis. If same history and examination finding as of Quincy are given in the question, along with that, there is outer neck swelling close to sternocleidomastoid muscle, then the answer will be parapharyngeal abscess. Look at screen. The internal picture is same. Uvula teda has maybe. Internal picture is same, but there is a swelling in the neck. In Quincy, there is no outer neck swelling, but a same question as of Quincy come with her. Along with that, there is outer neck swelling close to the angle of mandible. Then the answer will be parapharyngeal abscess. Look at me. All of you touch your bed of tonsil. This is your bed of tonsil, but below the angle of mandible, parapharyngeal space. This is pharynx. This is the parapharyngeal space. It's a big abscess here. Don't you think that this abscess will push the tonsil also on the other side? That's why internal picture is same. Uvula agar teda hai, the most common answer is Quincy. Only one thing to check is, in Quincy, there should be no outer neck swelling. If the question has got all the things of Quincy, heart, potato voice, trismus, uvula pushed to the other side, along with that, he has mentioned a swelling close to angle of mandible, then the answer will be parapharyngeal abscess. Parapharyngeal abscess. Parapharyngeal abscess. Very good. Parapharyngeal abscess. Wonderful. Okay. Now, let me show you a question of your paper. How paper they... yes. One second. Yeah. Quincy's infection, Ria. Cause will it's infection like a tonsillitis, no? Now please see the answer. Other symptom is same. Meet Absolutely same. Every symptom of quinsy and paraphrenia is same. What is the answer, beta? है ना? There is no neck swelling given. Plummy voice, trismus, dysphagia, uvula is pushed to other side. You can see over there, beta, na? That is over there. The answer is quinsy, beta. But just be careful about one thing, beta. Look at the choice A. है ना? Choice. Can you see choice A, beta? Choice A is also having QUI, beta. It'll be QUI. है ना? It's pretty common, madam. Same type of spellings on the exam day. In the hurry, please don't mark A, beta. है ना? जल्दी में, क्योंकि क्विंके इज डिफरेंट, क्विंजी इज डिफरेंट, स्पेलिंग बट बहुत सिमिलर होते हैं, इसलिए हाउस एवर सिंपल द क्वेश्चन में भी जितना मर्जी कॉन्फिडेंट हो कि ये तो आता ही है, कोई बात नहीं, एटलीस्ट रीड वन, गो ऑल द 4 चॉइसेस वन टाइम, बेटा, ऑल द 4 चॉइसेस वन टाइम, पढ़ना ही पढ़ना है, चारों चॉइस, ओके, क्विंजी, क्विंके, और लुक एट मी बेटा, ओके, ये हो जाता है पेपर में, जल्दबाजी में हो जाता है बेटा, पेपर में जल्दबाजी में हो जाता है, आपसे नहीं, सबसे हो जाता है बेटा, बिलीव मी, सबसे हो जाता है, और हम सब गलतियां करते हैं, ब्रेन बना ही कैजुअली काम करने के लिए है, उसको QUI दिख गया वो ये लगा देगा बेटा, लेकिन हमें ऐसी गलतियां नहीं करनी, लेकिन ब्रेन का तरीका ये काम करने का बेटा, मैं सही बता रहा हूं, मैं खुद भी ऐसी गलतियां करता हूं, जब मैं थोड़ा केयरफ्री, जब मोस्टली लोग केयरफ्री तरीके से काम करते हैं ना, हमेशा थोड़ी होते हैं, मैं बात बता रहा था एक बार पहले भी, कि मैं और अनुराधा, योर ऑप्थेल्मोलॉजी फैकल्टी, हम लोग गए हुए थे जयपुर, मेरी क्लास थी मिस्ड की, और अनुराधा ऑल्सो साथ में आ गई कि चलो मैं भी चलती घूमने, मैंने पूरा दिन क्लास ली मिस की, रात को मैं वापस आया होटल में, तो शीर कि हमें बाहर खाना खाने जाना है, मैंने बोला कहाँ जाना है, कह रहे मैंने एक रेस्टोरेंट पता किया है जोडानी करके, मैं वो क्या है, कहते वो इटालियन रेस्टोरेंट है, मैं बोला राजस्थान में कौन इटालियन खाना खाता है, बोले नहीं खाना है, ट्राई करना है, चलो चलते हैं, कहाँ है, मैंने बोला, बोले कह रहे कि ये है, यहाँ पे एक जय महल करके जगह है, वहां पे है बेटा, एंड जय महल जो है वो मैंने आया, मैंने शॉवर लिया, कैब बुक करी, उबर, और कैब उबर आई, और उबर आने के बाद हम जाते जा रहे हैं, 30-35-40 मिनट के बाद बंदे ने कैब खड़ी कर दी वहां पे अंधेरे में, और बोला कि सर उतर जाइए, आपका आ गया डेस्टिनेशन, मैं बोला ये कहाँ ले आया तो अंधेरे में मेरे को, कह रहा आपने जहां का कैब बुक किया मैं वहीं लेके आया हूँ, मेरा मतलब दिखा रहा है ट्रिप एंड हो गया है, मैं बोला कहाँ आए हम लोग, बोला आप आए हैं सर जल महल में, ये जगह का नाम था जल महल, मैंने जाना था जय महल, हुआ क्या कि जब मैंने JA टाइप किया तो उबर ने जो फर्स्ट ऑप्शन शो किया होगा नीचे जो सजेशन का, वो जल महल था, मैंने बिना सोचे समझे जल को टिक, जय जो था वो नेक्स्ट लेवल पे था बेटा, मैं वहां तक पहुंचा ही नहीं, इधर कर दिया है, और यहाँ पे पहुंच गए हम लोग, बहुत दूर अंधेरे में एकदम से, अनुराधा ने मुझे बोला कि तुम पढ़ाते कैसे हो यार, तुम क्या करते रहते हो उल्टा सीधे काम, मैं बोला हो जाता है भाई, कभी कभी हो जाता है, कभी ध्यान नहीं चाहता, फिर उसको मैंने रिक्वेस्ट करा भाई कहाँ पे था ये जय महल कहाँ पे, कहता वो तो सर वहीं था जहां आपका होटल उसके बगल में ही था वो, तो मैं उसको हाथ पे जोड़े 10 बज के रात के, अब ले जा, वरना मैडम मेरे को छोड़ेंगे नहीं कि कहाँ ले आओ रात को, सो ये हो जाता है बेटा, दिस हैपेंस एट नाइट, यू नो, एंड नॉट एट नाइट, एवरी टाइम एक्चुअली, सो क्विंके क्विंजी अलग अलग चीजें, व्हाट इज क्विंके, क्विंके इज एंजियोन्यूरोटिक एडीमा ऑफ द यूवुला, नेक्स्ट बेटा, क्विंके, जाना था जय महल, पहुंच गए जल महल, होते कांड बेटा, अभी किया है मैंने थोड़ी देर पहले, ओके, फाइन, क्विंके डिजीज बेटा, क्विंके डिजीज इज इडियोपैथिक एडीमा ऑफ यूवुला, क्विंके इडियोपैथिक एडीमा ऑफ यूवुला, इडियोपैथिक एडीमा ऑफ यूवुला, idiopathic edema of uvula, only uvular edema is there beta, only uvular edema is there, okay, now retropharyngeal space behind the pharynx, retropharyngeal behind the pharynx, this space is divided into 2 halves by midline band, okay, हाँ गए ना कीर्ति, हम गए, उसके बाद भैया वो कैब वाला लेके गया वहां तक दोबारा से, इट्स अ गुड ऑप्शन, अच्छा हाँ मैं बता दूं, इट्स अ गुड इटालियन फूड, अगर आपको शौक है, बिकॉज मैं और अनुराधा रुके हुए इटली में 3 महीने के लिए, मिलान में, अनुराधा कोई फेलोशिप था, मैं फेवेल्ला घूमने चला गया था 1 महीने के लिए, तो शी हैज स्टेड इन इटली, तो शी नोज इटालियन फूड बेटर, मैं पंजाब से हूँ यार, मुझे तो परांठे कुलचे समझ आते हैं, दाल बाटी समझ आती है, लेकिन मैं भी खा लेता हूँ, ऐसी बात नहीं मुझे बुरा लगता है, बट लेकिन मुझे पता नहीं होता, लेकिन जो बताया जाता है मैं उसको अच्छे से कर लेता हूँ और बहुत एंजॉय आराम से। लेट्स रिवाइज क्विंजी बेटा। क्विंजी इज ऑल्सो कॉल्ड, चलो इस पे रिकॉर्ड कर ले क्विंजी का, चलो मैं बोलता हूँ बेटा। Quinsy is also called peritonsillar abscess. It's collection of pus between tonsil and its bed. Mostly seen in adult, generally unilateral. In the exam question, visual question will be there, and uvula will be pushed to the other side. Tonsil will be pushed medially, but there's no outer neck swelling in quinsy. Patient got throat pain, dysphagia. Most importantly, trismus is there due to spasm of medial pterygoid muscle, and patient got hot potato voice called plummy voice or muffled voice. Treatment is IND and remove tonsil after 6 weeks. It's called interval tonsillectomy. But old surgeon used to remove tonsil at the same time with IND. It's called abscess or hot tonsillectomy. If Quinsy-like question come along with that, there's outer neck swelling close to angle of mandible, then you mark answer as parapharyngeal abscess. And do not confuse Quinsy with Quincke disease. Quincke disease is idiopathic edema of uvula. Okay, to fine. Now, just please save this audio with Quinsy beta. Now, retropharyngeal space beta. Retropharyngeal space behind the pharynx. This space has got two halves beta. This space has got two halves. These two halves are called spaces of Gillette. Right now. Gillette beta. G-I-L-E-T-T. These spaces have retropharyngeal lymph nodes, also called as lymph node of Rubier. In Quinsy, uvula is pushed to other side. Tonsil is pushed medially. Lymph node of Rubier. Okay. Now, everybody, let me show you where is the pharyngeal space. The retropharyngeal space. Everybody, please see. Now, everybody focus on this one. Now, you have to tell me what is this. Everybody answer. I'm waiting. Everybody answer. What is this? Anybody? What is the yellow arrow indicating? PPW. What is PPW? Posterior pharyngeal wall. Okay. Right behind this is what beta? Anybody would tell me. I will be very happy if I cut this open. If I cut this open, give a cut over here, open the mucosa, what will you see behind it? Anybody? If I cut it open and see it behind it, what will you see over there beta? Anybody? अगर मैं यहाँ कट करके खोलूं और पीछे क्या दिखेगा आपको बेटा? जो स्पेस छोड़ दो बेटा, स्पेस छोड़ दो, क्या दिखेगा वहां पे? मेन स्ट्रक्चर. यस, मेन स्ट्रक्चर व्हाट बेटा? वर्टिब्रा. वर्टिब्रा, नॉट किडनी. हो किडनी तो नहीं आएगी यहाँ पे ना, पीछे पीछे किडनी थोड़ी आएगी कि किडनी आएगी, वर्टिब्रा आएगा ना. वेरी गुड, वर्टिब्रा, वेरी गुड, है ना, वेरी गुड. ये देखो देखो, आपने बिल्कुल सही बोला. This is PPW. What is PPW? Posterior pharyngeal wall. Behind that is vertebra. And now between the two, this space is the retropharyngeal space. Retropharyngeal space. Okay, that is good. Now, everyone, draw the space with me. Now, draw the space with me here. Right on pharynx. This is PPW. Draw two black lines. And this is your vertebra. Now, this is the retropharyngeal space, RPS. Okay. This is done in two halves by midline band. And these two halves have got the lymph nodes. These lymph nodes are called the retropharyngeal lymph node. These lymph nodes are called lymph node of Rouvier. Retropharyngeal space has got two halves, and those two halves are called spaces of Gillett. And these two halves contain the lymph node called retropharyngeal lymph node, and these are also called lymph node of Rouvier. Check everyone, is the video okay? Guys, we'll take break after pharynx, beta. We'll take break after pharynx. You can take the break now and see the, if you are hungry, you can take the break now and see it in the lunch hour. Is the video lagging? Check once again. It's absolutely going fine from my end, actually. We have not done anything, but only drawn the diagram, beta. That's all. All okay, na, beta? Let's do some. Otherwise, we'll not be able to finish ENT in 5 days, even, beta. This is vertebra, beta. This circle thing is vertebra, beta. Vertebra. Okay, beta. Video is okay. Okay. If you want to eat, you can bring and eat something, and or in the when we take the lunch break, you can see in that time, beta. Okay, but let's take a break after the pharynx over, beta. Okay, fine. Now, midline. I repeat now. Everybody, I think now this link is okay. Behind the pharynx is the space called the retropharyngeal space. This RPS means the retropharyngeal space, beta. It has got two halves. Can you see? There's a blue color band between the two halves. And these two halves are called spaces of Gillett. And these spaces have got retropharyngeal lymph node. These purple lymph node are called lymph node of Rouvier. I'm waiting for everyone. Please, record it. Okay, to fine. Chalo, मैं wait करो बेटा, no problem. आराम से. 2 to 3 is lunch break, beta. 2 to 3 is lunch break. Lunch break will be 1 hour complete. Okay, 2 to 3 will be lunch break. जिन्होंने क्रिकेट के लिए जाना ना, मुझे लग रहा है उनको उनका लैग होना शुरू हो गया है. Okay, 2 to 3 lunch break, 3 to 5 nose first session, beta. Let's be systematic. Infection of this lymph node will lead to acute retropharyngeal abscess. Acute retropharyngeal abscess. 2 to 3 lunch break, 3 to 5 first session of nose. Everybody. Okay. Now, acute retropharyngeal abscess. Please see the screen. Please see. By chance, these lymph node get pus. This abscess is called acute retropharyngeal abscess. Okay. Now, acute retropharyngeal abscess, put an arrow. Clinical presentation, put a box. Very sick child. 2-year child presenting with inspiratory stridor, spelling with O. Inspiratory stridor, very sick child. Respiratory distress, severe. It is pediatric airway emergency. Pediatric airway emergency, beta. The abscess will form in 2-3 hours only, maybe maximum 1 day. It's a pediatric airway emergency, just like acute epiglottitis. Yesterday class, would I remember? 2 to 7 year, severe respiratory distress, inspiratory stridor, drooling of saliva, hot red of voice, beta. Okay, fine. 2-year child presenting with inspiratory stridor, severe respiratory distress, drooling of saliva, hot potato voice. Okay, what a fine. Now, please see beta. It's a very sick child. Imagine the patient, just like yesterday class, if you remember, we said, anybody, which two parts problem will cause inspiratory stridor? I'm waiting. Which two area blockage will lead to inspiratory stridor? Everybody. Which two area blockage will lead to inspiratory stridor? Second part, beta. One is supraglottis. Very good, Govind. Very good. Second one, beta. Very good, beta. Supraglottis and pharynx also. Pharynx also. Upper part problem. Pharynx and supraglottis called inspiratory stridor. Yesterday, acute epiglottitis, supraglottic infection was inspiratory stridor. Today, pharynx abscess is also inspiratory stridor. Beta. Okay, very good. Beta. So once again, it's a very sick child. It's a pediatric airway emergency, just like acute epiglottitis. Anybody? What was the name of X-ray sign for acute epiglottitis? What was the name for X-ray sign for epiglottitis, beta? X-ray neck sign on lateral view. What is the name of sign? Thumb sign. But here, X-ray neck show widening of prevertebral shadow. Widening of prevertebral shadow. In front of vertebra, you see a white shadow. Widening of prevertebral shadow. My dear friend, please see on the screen, everyone. There's a big abscess in this area. Please see on the screen, everybody. Oh, within few hours, this is the acute retropharyngeal abscess. Big pus collection here. Think like a doctor, not like a student. Can you imagine this child, this patient? Can the air go inside the patient? No. Rarely, very big problem. Respiratory difficulty severe. Now, that's why this stridor, inspiratory stridor. Can the saliva go down? No, that's why drooling of saliva. Child cannot drink milk. That's why hot potato voice. But if you do X-ray of this patient, lateral view, you will see pus in front of the vertebra. What is the color of pus on the X-ray? Anybody? What is the color of pus on the X-ray? What is the color of pus on the X-ray? Is it X-ray only two color, black and white? That's why I never like radiology. Anybody? What is the color of pus on X-ray? Yellow. Pus has no yellow color. Boring X-ray. No yellow. White color. Very good. Let me show you. Let us do the X-ray of this child. Can you see over there? In front of vertebra, you have got a very big swelling. This one. This is the abscess. In front of vertebra, you see a big pus. But unfortunately, we don't have colored X-ray. It's only white color over there. Can you see a beautiful white shadow in front of vertebra? Tell me yes or no. Can you see a beautiful white shadow in front of the X-ray? In front of the spine, cervical vertebra? Can you see it over there? Yes or no? Can you see it over there? This white shadow in front of the vertebra, this star, that's abscess. Can you make it out, beta? Widening of prevertebral shadow, beta. This shadow is widening of prevertebral shadow. Okay. Now, treatment of this patient will be number one, airway management. JL, just like acute, the number one is airway. After that, you manage the abscess, IND, antibiotic. But my concern is it's a pediatric airway emergency. Can we connect this thought with this thought? This thought. When airway is a problem, first treatment is airway, airway, airway. Okay. Fine. Now, the next topic, Ludwig angina. Ludwig angina. Ludwig nahi spelling correction. Ludwig. Ludwig. Ludwig's. Ludwig. Ludwig G, S. Ludwig's angina. Angina. What are the black dots? Air. Air makes air in the abscess because there are, aerobic bacteria, anaerobic bacteria. Ludwig's angina. What is angina? Angina means pain. Okay. Now, its infection of floor of mouth is equal to submandibular space. Somebody please put all the larynx audios now after the lunch start. But everybody, no pictures. First of all, you put all the audios of the larynx topic wise. Topic wise, it should be labeled audio for everyone. Okay, fine. Infection of floor of mouth, submandibular space. Beta. Floor of mouth is made by mylohyoid muscle. Beta. This is anatomy question. Beta. Mylo मतलब mandible, mylohyoid, MYLOHYOD. Mylohyoid muscle. Beta. Source of infection is dental caries. Beta. Dental caries, teeth infection. Now, please see the screen below. Very simple question to crack in the exam, beta. This is mandible. This is hyoid, beta. The muscle is called mylohyoid. Mylohyoid. There are two mylohyoid, beta. Mylo to hyoid, mylo mandible to hyoid. This is muscle, beta. Look at me, beta. One mylohyoid here, one mylohyoid here, beta. Now look at screen, everybody. The mandible has got teeth also, beta. You know teeth? Molar, premolar, one of the teeth got caries. And that infection came over here. Okay, fine? Okay, fine? Now, bacteria. Streptococci. Oral, no, beta, oral plus anaerobes. Oral bacteria is mixed bacteria, no? Oral is streptococci, very dense and all that streptococci. Mixed bacteria. This is a neat PG question of bacteriology, microbiology, ENT combined. Beta. Okay. Very simple question to crack. Beta. After dental infection, patient develop chin swelling, trismus, plus minus respiratory distress. Beta. Sometimes there's so much of swelling that breathing is also a problem. Beta. Plus minus respiratory distress. Beta. All eye on the screen. Bache. Please see on the screen. Beta. This much swelling, so bad swelling. Look at the patient, beta. Pura tongue ऊपर lift हो गया. So much of swelling, beta. आप खुद सोचो that can the patient breathe normally now? No. You tell me the patient is dying because of breathing problem. Will you do intubation or will you do tracheostomy? Intubation is number one choice, beta. In this patient, will you do intubation or number two tracheostomy, beta? Think like a doctor. Think like a doctor, number one. Think beyond notes. This is 2 steps to pass the Fmge paper. Very good. You can't intubate, beta. Why? Swelling is there, mouth is not open, trismus is there. Very good. This is what I want, beta. This is what I want. I just want that हम जल्दी मिलें और तुम्हारे हाथ में सर्टिफिकेट हो कि भाई पास हो गए. That's my dream for you guys. Okay. So 2 mantra to pass the paper are think beyond notes. TBN. Think beyond notes. Beta. And TLC. Beta. Think like clinicians. Beta. TBN. Think beyond notes. Number 1. Beta. पढ़ाई के साथ साथ ये practice करना. Number 2. Think like clinician. And most importantly, don't become neurosurgeons. Don't become neurosurgeon. Beta. Okay. That's very, very important. Plus minus tracheostomy. बड़ा सही सोचा आपने. Tracheostomy करेंगे, intubate नहीं कर पाएंगे. Tracheostomy. Simple question, beta. Dental infection के बाद, after dental infection, chin swelling, trismus. I know the answer, beta. Let me show you neat PG question, beta. Let me show you neat PG question. "23-year-old female suffering from dental caries of lower molar. She has developed trismus, dysphagia." 51 question, beta. What is the answer? And clinical picture is shown. Don't say, Dr. Dhawan, dysphagia क्यों नहीं है notes में? ऐसे नहीं करना है. Think like a doctor, beta. खाना खाने में दिक्कत हो रही है उसको. ज़्यादा नहीं सोचना. Think like a clinician. TLC. TLC. Think like clinician. है ना? मतलब थोड़े बहुत दाएं बाएं क्वेश्चन होते ही होते. आंसर चेंजिंग. लकीर के फकीर नहीं बनना. Okay, fine. What is the answer? Ludwig angina. Ludwig angina है ना? अब देखो जैसे अब 2 एंजाइना, विंसेंट और लुडविग. हमने क्या बोला था? विंसेंट क्यों नहीं लगाना बेटा? क्योंकि विंसेंट में क्या था? लास्ट लेटर टी. टी फॉर टी वर्ड. एनीबॉडी? टी फॉर व्हाट? T for what? T for tonsil. याद है Vincent involved tonsil. The answer of this question is not Vincent. Answer of this question is D. Ludwig angina. है ना? Vincent. अब देखो ऐसी गलतियां नहीं होंगी हमारे से. Vincent tonsil. Ludwig इसमें. Chin swelling after a dental infection. Trismus. Ludwig angina. Now, the last part, beta. The one-liner things. Have you done dermatology, beta? Dermatology have you done? Dermatology done? No. Okay, they will show you in that. Pre-malignant lesion of oral cavity are leukoplakia, erythroplakia, oral semi. OSMF is very important. So cause chewing of tobacco and betel nut. Betel nut मतलब सुपारी. Betel nut ना सुपारी. सुपारी is also carcinogenic. तो ड्राई सुपारी खाते रहे, ये भी carcinogenic है. Chewing of tobacco, betel nut. Leukoplakia मतलब white patch. Erythroplakia red patch. OSM is very common. Oral submucous fibrosis. बेटा ये चीजें कैंसर में कन्वर्ट हो जाती है. नहीं मैं मीत में वैसे कोई नंबर डाल देता हूं. ऐसे कोई नंबर नहीं है, कोई टैग वैग नहीं कर रहे. सुपारी भी कार्सिनोजेनिक है भाई. नहीं खानी सुपारी वारी. चलो अब दिखाता हूं बेटा पहली फोटो. ल्यूकोप्लेकिया फोटो खींचो. ल्यूकोप्लेकिया व्हाइट ल्यूकोप्लेकिया इट्स कार्सिनोजेनिक. प्रीमलिग्नेंट व्हाइट पैच. ल्यूको मतलब व्हाइट पैच. इट कैन कन्वर्ट टू कैंसर. ओके. ल्यूकोप्लेकिया कैंसर व्हाइट पैच. तीनों का कॉज है बेटा. शिवाली तीनों में एक ही कॉज है. किसी को ल्यूकोप्लेकिया, किसी को एरिथ्रोप्लेकिया. कैन यू क्लिक द पिक्चर बेटा? ल्यूकोप्लेकिया व्हाइट पैच. नंबर 2 बेटा एरिथ्रोप्लेकिया रेड पैच in the oral cavity, very common to chewing out tobacco, pan masala, etc. So leukoplakia, erythroplakia. Okay, take the picture. Number 3, OSMF, very common. OSMF, oral submucous fibrosis. This is very important. If you see whitish patch over there, this is actually OSMF. It is chewing out tobacco, pan masala, this Rajnigandha, Shikhar, Vimal, whatever. 0% tobacco matlab still carcinogenic because betel nut is also carcinogenic. ये सब ठीक नहीं है भाई. शिखर, विमल, केसर नहीं है भाई. ये खराब चीजें हैं. रजनीगंधा, इसका नाम ही गंदा है बेटा. रजनीगंधा का तो नाम ही गंदा है. अच्छा कैसे हो सकता है वो? 100% डेंजरस है बेटा. डेंजरस है. It is 100% dangerous. Carcinogenic है. ओके. जुमा केसरी, तीनों लोगों ने इसको प्रमोट किया. फोर्डिस स्पॉट बेटा आपका क्वेश्चन ऑफ योर डर्मेटोलॉजी बेटा. फोर्डिस स्पॉट इज एक्टोपिक सेबेशियस ग्लैंड इन मिकोजा ऑफ लिप्स. एक्टोपिक सेबेशियस ग्लैंड. बाबा इलायची ठीक है. एक्टोपिक सेबेशियस ग्लैंड इन मिकोजा ऑफ लिप बेटा. Sebaceous gland are part of skin beta. ध्यान दो बेटा. Forehead spot. This is a visual question of your paper. Forehead spot. This is the right now. Let me write down beta. It is ectopic sebaceous gland. Ectopic sebaceous gland. In lips. Now click the picture below. Ectopic sebaceous gland in the lip. Can you see the yellow spot below? Okay. For this spot below. Okay. Fine. Now. This is not carcinogenic, कोई रिलेशन नहीं कैंसर का. दिस इज जस्ट लाइक दैट बेटा. कई लोग यहाँ पे सेबेशियस ग्लैंड बन जाती है अपर लिप पे, लोअर लिप पे. कोई प्रॉब्लम नहीं, इट हैज गॉट नो रिलेशन विद कैंसर बेटा. नाउ नेक्स्ट वन बेटा, नेक्स्ट वन, रिवर्स स्मोकिंग. रिवर्स स्मोकिंग इज रिस्क फैक्टर हार्ड पैलेट कैंसर बेटा. प्लीज सी, रिवर्स स्मोकिंग तो और ज्यादा नेक्स्ट लेवल की टॉक्सिटी बेटा. देखो जरा, बर्निंग साइड ऑफ सिगरेट इन द माउथ. क्या बात है बेटा, लेवल किक, लेवल का अंत नहीं है कोई भाई. किक के ऊपर किक, महा किक, सुपर किक. जलती हुई सिगरेट मुंह के अंदर डाल लो उल्टा तरफ से. बर्निंग साइड ऑफ सिगरेट इन द माउथ इज अ रिस्क फैक्टर ऑफ हार्ड पैलेट कैंसर बेटा. ओके, हार्ड पैलेट कैंसर, रिवर्स स्मोकिंग. ओके, नाउ नेक्स्ट वन बेटा. Most common site of oral cavity cancer in the world actually is lateral border of tongue. ऐसे बनाओ बेटा. Any ulcer on the lateral border of tongue is to be considered suspicious. Okay, fine. Most common head and neck cancer in India is oral cavity cancer. India में oral cavity cancer very common. Oral cavity cancer. Most common site of oral cavity cancer in India is buccal mucosa. पूरे वर्ल्ड में lateral border of tongue. इंडिया में buccal mucosa. Buccal mucosa in the bracket. Gingivo buccal sulcus. Gingivo buccal sulcus. Gingivo buccal sulcus. जिंजीवो बक्कल सर्कस. जिंजीवो बक्कल सर्कस. जिंजीवो मतलब गम. जिंजीवो मतलब गम. जिंजीवो बक्कल सर्कस. जिंजीवो बक्कल सर्कस. लुक एट मी एवरीबॉडी, लुक एट मी. जिंजीवो बक्कल मतलब क्या, ये दिस सर्कस. आपने कभी देखा है ये जो पुड़िया खा रहे होते हैं टोबैको वाली, वो जब डाल के देखा अपने हाथ पे डाल के अगले 2 मिनट के लिए ऐसे ऐसे चुनते रहेंगे और कुछ ऐसे फेंकते रहेंगे कि जैसे कोई गलत चीज मुंह में ना चली जाए. जैसे जो बाकी बचा है वो बड़ा अमृत है जैसे ना. हाँ, फिर थोड़ा चूना उना डाल के उसको रगड़ते रहेंगे ऐसे 15 मिनट के लिए. क्यों? हीट प्रोड्यूस कर रहे हैं ताकि जो कार्सिनोजन छुपे हुए अंदर वो बाहर निकल आए. हाँ, पूरा कार्सिनोजन इज आउट नाउ विद द हीट ऑफ द लाइम एंड दे जस्ट रब इट. आफ्टर दैट पता करते हैं ऐसे, देखा तुमने? पता क्यों करते हैं? क्यों? जो साइडों पे लगा हुआ है मामला मसाला वो भी हाथ के अंदर इकट्ठा हो जाए, 1 भी मिलीग्राम वेस्ट ना हो जाए कहीं. हाँ, एक बार हाथ में आ गया, फिर उसके बाद पूरी टेक्निक से ऐसे ट्रांसफर करते हैं बेटा. तुम देखना कभी, ये हाथ जादू की तरह साफ हो जाता है, 1 मिलीग्राम भी यहां नहीं होता. और फिर ज्ञान डालते हैं इधर, भैया क्या हाल है भैया, इधर यहाँ पे ऐसे बना के बैठे रहते हैं. यही तो है जिंजीवो बक्कल सल्कस विच इज पार्ट ऑफ बक्कल मिकोजा. सल्कस का बेस क्या, कौन सी बोन है? मैंडिबल. मैंडिबल बेटा, मैंडिबल इज द बेस. Within few days this will enter the mandible also, and you need a surgery. You need a surgery called big surgery beta. The name of surgery is big surgery, commandos operation. Look at the next line. Commandos operation. Commandos operation is combined oromandibular resection with reconstruction. Combined oromandibular resection with reconstruction. Combined oromandibular resection with reconstruction. This surgery is done for oral cavity cancer. Look at the oral cavity, this mostly this area, and this is mandible also involved. So you have to remove the oral mucosa with the mandible also. Combined oromandibular resection with the reconstruction. Okay. So this is a summary, but let's revise. There are 3 pre-malignant conditions of oral cavity: leukoplakia, erythroplakia, and oral submucous fibrosis, whitish patch in the mouth. Tobacco and betel nut, supari, both are carcinogenic. The reverse smoking causes hard palate cancer. Foddy spot is not related to cancer. It's a yellow spot over here that are ectopic sebaceous gland in the mucosa of the lips. Most common site of oral cavity cancer in the world is lateral border of tongue, here. But in India, it is gingivo-buccal sulcus or buccal mucosa. The name of surgery for oral cavity cancer is commandos operation, combined oromandibular resection with reconstruction. Chalo. Now, let's take a break. It's 2 o'clock exactly the way I planned it. So now, please be here by 2:55 p.m. Everybody, 2:55 p.m. will start the nose and sinus assessment. Thank you very much. Take a break. And in the break, now everybody, please put the audios of larynx and pharynx now one time. एक बार सारे फाइल ऑडियो डाल देते हैं. It will be really great. अब कोई मैसेज में डालना, वो ऑडियो रहने देना थोड़े सबके लिए. I'll let everybody be on the see the audio bit. Okay, fine. Let the audio be there. Okay, and 2:55 we start again. Thank you very much. So let's start the class now further. Everybody, inform the friends. Let's start nose and sinuses. In this session, let us do the first part of nose and sinuses. Everyone, are you there? Very good. Let's start the third topic now. Last time, four question came out of nose and sinuses. Last paper, July paper, 4 questions came out of this topic. Refresh your link. Can we start now? Chalo. So the first topic of nose and sinuses is the January question. Design of external nose. External nose, okay. Please see on the screen, brother. Please see. This external nose, brother. That's the look of the nose, outside the framework of the nose, and people are very, 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 very touchy about it. This Snapchat ke chakkar mein na, because of Snapchat, people take the selfies and see what kind of nose, straight nose, broad nose, sharp nose. But people forget one thing. एक चीज भूल जाते हैं, स्किन के 5 मिलीमीटर नीचे सब बराबर है बेटा. थोड़ा नीचे जाओ, स्किन के नीचे सब एक जैसे लगते हैं अंदर से हम लोग, है ना? When everybody is like that. Now, the external nose is made of 4 paired structure. External nose is made of 4 paired structures. Number 1, nasal bones. Number 1, nasal bones. The first page of nose and sinuses. Number 1, nasal bones. Number 2, upper lateral cartilages. This is nasal bone. Remaining is cartilage. Upper lateral cartilages. This is lower lateral cartilages. And this is what is the lesser alar or sesamoid cartilages. So the 4 paired structure. This was the MCQ of January paper. The external nose is made of 4 paired structures. Let us see 4 paired. Number 1, nasal bones. Number 2, upper lateral cartilages. Number 3, lower lateral, also called alar cartilages. Alar, the lowermost, this one, put an arrow. They form external nasal opening. All of you draw like this, they are the entry point of the nose. This entry point, they form the external nasal opening. And number 4, lesser alar or sesamoid cartilage. Sesamoid cartilages. These are small cartilages between upper lateral and lower lateral cartilages. Okay. Now, everybody, let us revise. What are the 4 components of the external nose? Nose is made by 4 paired structures. Number 1, nasal bones. Number 2, upper lateral cartilages. Number 3, lower lateral or the alar cartilages. Number 4, lower lateral alar cartilages. Number 4, lesser alar or sesamoid cartilages. Okay, fine. Now, the next concept is the question of January. Question of January paper was what? The January paper question was the external nose is made by which of the following correct pattern? Upper 1/3. So what was the January question, beta? Okay, the January question was that which of the following is true, beta? The upper half bone, lower half cartilage, upper half cartilage, lower half bone, upper 1/3 bone, lower 2/3 cartilage, or upper 1/3 cartilage, lower 2/3 bone. What is the answer, beta? What is true about external nose design, beta? Upper half nose, upper half cartilage, lower half bone, upper half bone, no, bone, lower half cartilage, upper 1/3 bone, lower 2/3 cartilage, or upper 1/3 cartilage, lower 2/3 bone. What is the answer? Upper 1/3 bone, lower 2/3 cartilage. This was January question, है ना? They don't ask straightforward thing. They will just twist the things with like that. Very good. Upper 1/3 bone, lower 2/3 cartilage. Now, next concept is nasal valve. Nasal valve is the junction of upper lateral and lower lateral cartilage. So you are correct, beta. It's upper 1/3 bone, lower 2/3 cartilage is there. Very good. And there are 4 paired structure. Okay, now everybody, this is nasal valve, beta. Nasal valve. Nasal valve is the junction of upper lateral and lower lateral cartilages. Okay, fine. Now, so sometimes this valve can be collapsed in some people. Look at screen, everybody. The valve collapse can be issued like this. Can you see over there? This is a nasal valve collapse. To test the nasal valve collapse, we have a special test called Cottel's test. Now, Cottel's test is done to check the blockage of nasal valve. Cottel's test is done to check the blockage of nasal valve. How we do it? We could keep 2 fingers on the cheek and lift it upward. This is a NEET PG visual question also. Cottel's test is done for what? Cottel's test is done to check, write down. Cottel's test is done to check blockage of nasal valve. One line question, visual question. Cottel's test is done to check the blockage of nasal valve. Cottel's test is done to check the blockage of nasal valve. Okay, right now we have Cottel's test. This is a visual question of NEET PG. Cottel's test. Put 2 fingers on the cheek, lift it upward. That is the NEET PG question also. NEET PG question also. Now, next one. Next page. Saddle nose with depressed nose. You can see there is a depression on the dorsum of the nose, and that is a saddle nose. And this is the saddle I'm talking about. Saddle matlab horse's saddle. You know horse's saddle, घोड़े की काठी. You know घोड़े की काठी होती है ना, horse's saddle. ऐसे depression होता है, saddle nose. In which case we see, what are the causes? Number 1 is trauma. Number 2, leprosy. Tertiary syphilis is very important. Septal surgery. Tuberculosis. And Wegener's granulomatosis. Last time we had a question of saddle nose, septal perforation, and vaginal granulomatosis. Okay, vaginal granulomatosis. Okay. Let's once again revise, beta. What are various causes? Trauma is the cause. Don't forget, beta. Leprosy. Tertiary syphilis is very important. Vaginal granulomatosis is very important. Tuberculosis, leprosy, all these causes to be kept in mind. Saddle nose depression. Okay. Just don't forget tertiary syphilis. Put a star here to be remembered. And don't forget vaginal granulomatosis. Please do read this topic from pathology book also. Pathology, Wegener's rheumatology also. Treatment is surgery. SX. What is SX, beta? Surgical. What is SX? Surgical treatment, beta. No E between S and X, बेटा है ना. पढ़ाई सिर्फ पढ़ाई, कोई क्रिकेट मैच नहीं, कोई पाकिस्तान नहीं, कोई इंडिया नहीं. थोड़ा सा सेक्रीफाइस कर लो, काम आएगा. हम पास हो गए, घर वाले भी हमारे इज्जत मान से हमें, you know what, like they will treat us that we have really done something which has brought, you know, pride for the family also. So मन मार के पढ़ाई होती है, मन से कभी पढ़ाई नहीं होती. तो तुम्हारा पढ़ने का मन कर रहा है बिना एग्जाम के, तुम्हारा सच में दिमाग ठीक नहीं है, और तुम्हारा कोई एग्जाम नहीं है दुनिया में, और तुम 26-27 साल के हो और ठीक ठाक काम कर रहे हो, और फिर तुम बैठ के बायोकेमिस्ट्री पढ़ रहे हो, तो तुम्हें अपना दिमाग का एमआरआई कराना चाहिए कि क्या प्रॉब्लम है भैया, तुम्हें क्या दिक्कत क्या है, क्यों पढ़ रहे हो भाई बैठ के, है ना। पढ़ने का मन कभी नहीं करता, एग्जाम के लिए पढ़ना पड़ता है, लेकिन पढ़ाई के लिए मन मार के पढ़ना पड़ता है। यू टू ऑलवेज गो अगेंस्ट द विंड टू स्टडी बेटा, ऐसे नहीं पढ़ाई होती, है ना बेटा। फाइन। सो इसलिए दैट्स व्हाई आई एम सेइंग दैट यू नो व्हाट, we cannot expect that you know we'll feel like studying. We have to always force ourselves to study. नींद आ रही है, लंच किया है, कोई बात नहीं, मैंने क्या पकड़ा हुआ, देखो चाय पकड़ी हुई है, नहीं है, कुछ ना कुछ जुगाड़ करके मुंह पे छींटे मार के अभी बैठ के फिट करना है ना बेटा। क्योंकि क्या होता है, बॉडी की फिजियोलॉजी और इस दुनिया के तौर तरीके आपस में मैच नहीं कर रहे बेटा। बॉडी की फिजियोलॉजी और दुनिया में रहन सहन के तौर तरीके, जो जीने की प्रक्रिया बन गई है, वो आपस में मैच नहीं कर पा रही है बेटा। और इसलिए हम सोचते हैं हम गलत है। हम गलत नहीं है। दुनिया में कोई भी इस पृथ्वी पे कोई भी ऐसा जानवर नहीं है जिसको अच्छे लंच के बाद नींद ना आती हो बेटा। कोई भी ऐसा जानवर नहीं है बेटा जिसको, देयर इज नो एनिमल ऑन द प्लैनेट हु डज नॉट फील लेथार्जिक आफ्टर अ गुड मील। एक्चुअली हर लंच के बाद सिर्फ इंसान ऐसा प्राणी है जिसने गिल्ट का आविष्कार किया बेटा। गिल्ट मतलब हर बात में हमें गिल्ट होता है कि गिल्ट मतलब मुझे नींद क्यों आ रही है भाई खाने के बाद, क्योंकि तुम नॉर्मल इंसान हो इसलिए नींद आ रही है भाई। लेकिन हमारी फिजियोलॉजी और हमारे जीने के तौर तरीके आपस में मैच नहीं कर पाते। हमें अपनी फिजियोलॉजी के अगेंस्ट जाना पड़ता है। कभी देखा है हमारे गली में कितने सारे कुत्ते होते हैं, खाना वाना खा लेते हैं लंच के बाद, फिर पेड़ की छांव के नीचे ऐसे दोनों हाथ पे हाथ रख के पड़े सो रहे होते हैं मस्त। कभी भी तो उनसे भी जेलसी फील होती है कि भाई इनका कोई पेपर थोड़ी है, कोई नीट पीजी ना एफएमजी ना या आईसीटी, कुछ भी नहीं, मस्ती मार रहे हैं ये लोग तो। लेकिन इंसान एक इवॉल्व्ड स्पीशीज है और ये एवोल्यूशन ही हमारे अगेंस्ट काम कर रहा है। ऊपर से हमने ये पढ़ाई वढ़ाई का आविष्कार कर लिया। हमारी पढ़ाई ये जो सारा कुछ है फिजियोलॉजी इज नॉट फिजियोलॉजिकल। रातें पढ़ने के लिए बनी हुई, तुम सोचता ब्रेन डजंट वांट टू स्टडी, ब्रेन वांट्स टू बी बेबीज ओनली। लेकिन अब दुनिया तो बदल नहीं पाएंगे भाई। दुनिया में कुछ अपना हिसाब किताब बनाने के लिए हमें अपनी फिजियोलॉजी अगेंस्ट का काम करना पड़ेगा। इसलिए प्लीज बी स्ट्रिक्ट विद योर सेल्फ, रिमेंबर, क्योंकि थोड़ी देर के लिए काम कर लो, ये काम आएगा बेटा। We came like a monkey, will die like a monkey for sure. No need to change yourself. Just launch a limited time disciplined version of yourself, which is strict with your own self. And actually you are programmed to study in an intense, consistent manner for a couple of months. Okay, fine. Now, okay. Treatment is augmentation rhinoplasty by using iliac crest graft, hip bone. Hip se, we take a hip bone graft and iliac crest graft leke, we put a graft over there. Please see on the screen beta. This is before surgery, but you see after surgery such a wonderful nose beta. Why very nice nose hai na? Because why we put a graft here beta, na? We put a graft, the surgery, please see. So before surgery, after surgery, this is augmentation rhinoplasty beta. Okay, now next one is this is important topic, but a star question is this time done. Don't forget to revise this. Rhinophyma is a visual question, is a potato nose dermatology question also. It is hypertrophy of sebaceous glands of skin of external nose. It is hypertrophy of sebaceous glands of the skin of external nose. It is hypertrophy of sebaceous glands of the skin or external nose beta. Kabhi bhi, you know, if your nose is little granular, irregular, it's not tumor beta. You must have seen Om Puri beta. Om Puri had smallpox spots also. Om Puri had one nose problem also, rhinophyma beta. Om Puri has died beta. People from Telangana must be knowing actually. Andhra also, KCR beta. Your Chief Minister KCR also has same kind of nose beta. KCR nose. You know, the Chief Minister of Telangana has also got the same kind of nose. It's rhinophymatous nose. It is more common in male. KCR Chief Minister, okay, of Telangana. Okay, it is not a tumor. Not a tumor. It's a type of acne rosacea. A type of acne rosacea. A type of acne rosacea. Treatment is surgery. If you want it. KCR never got surgery. Om Puri, nobody got surgery. Nobody. It's more than males, na? Males. हमें देखता कौन है भाई? हमें देखता कौन है? You know what? We are not, male and female are two different species altogether. You know it now. हमें कोई देख कोई ना केसीआर ने सर्जरी कराई ना ओमपुरी ने करवाई बेटा है ना. If you want surgery, we can do laser. And skin graft. Male are dull part of creation. Female are fine part of creation. But अगर तुम सर्जरी कराना चाहो, we can do the laser excision and we can put the skin graft over there. Aruz Ashraf has written, honestly, if you had started a little earlier, we could be in a better position preparation wise. अभी भी time है बेटा. अभी भी Aruz बहुत time है. अभी डट जाओ, जुट जाओ. Forgive yourself for the mistakes you did till now. Forgive yourself for the time you wasted till now. Forgive yourself for the days you slept earlier when you promised yourself to be sleeping little later. It's okay, no problem. I have expertise of wasting 19 months. So I know that there's a guilt also and all that. अब होगा कि नहीं होगा, होगा. पढ़ाई करो, ऊपर आने चाल सब सही होगा. Okay. KCR Arman, KCR उसका Chief Minister तेलंगाना का. Okay. One patient came to I think Lady Harding or Ames. He wanted this surgery. He must be 45, 50 years. I told him, don't get operated. He said, no, I want to get operated. And I posted him. I told one of the juniors to operate. He did laser excision over here and he put the skin graft. It was his first skin grafting probably. Now, after 3-4 weeks, this guy came back and he started fighting with me. He said, what have you done? I said, what happened? You know what mistake was done? The skin graft should have been taken from this area, non-hair bearing area from there. This guy took the skin graft from his thigh. उसने thigh से skin graft लेके उसके यहाँ लगा दिया. अब बाल यहाँ भी आ रहे हैं. अगर मैं कहाँ शेव करूँ मैं? कहाँ शेव करूँ? You know, that is what. So you have to take a graft from that area of the skin where there is no hair actually. Okay. Now, next one, beta. This is a visual question, beta. Most common malignancy of skin axonnosis, basal cell carcinoma, or rodent ulcer. Okay, this is a visual question. Okay, the same, right down, beta. Any ulcer on nose or pinna skin is BCC. Any ulcer on the nose or pinna skin is BCC, basal cell carcinoma. Any ulcer on the nose or pinna skin is basal cell carcinoma. Now, so this is an important question, but a visual question, small topic. Rhinolith, stone in the nasal cavity. Only the word should be known to you. How the stone made? This is a stone, beta. From where the stone came? From the air. Air has got dust particle, impurities. Look at me, beta. The dust particle and impurity of the nose, of the air, settle in the nose and they make a big mass in the nose. So patient will be having nasal pain, headache, nasal blockage, foul smell, beta, not small, foul smell, 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 foul smell, beta. And epistaxis, bleeding. Treatment is endoscopic removal. Treatment is endoscopic removal. Endoscopic removal. Okay, fine. So rhinolith is a word you should be knowing actually. It's stone in the nasal cavity. How the stone formed, beta? From the air, beta. From the air. Chalo. From the air, that dust particle impurity come in the nose and settle as a big mass. Patient got blockage of the nose, smell from the nose, pain in the nose, and treatment is endoscopic removal. Beta. Okay, fine. Now, everybody, chalo, focus on study, beta. Foreign body in the nose. Everybody, foreign body in nose. This is a very important. Whenever you see a foreign body, it's a possible question, beta. It's more common in school age children, beta. School age children, beta. More common in school age children, beta. No, rhinolith is not able to tonsillitis, beta. Okay. Now, Foreign body nose is very common in school age children. I hope you people are not putting anything in the nose nowadays, beta. Okay, तुम तो नहीं नाक में डालते रहते. School age is a fantastic time, beta. You know, you remember your school bag. In the school bag, you have the pencil box. उस pencil box में there was a world, complete world, beta. What in the pencil box we had got pencil, eraser, sharpener, colors, wax color, crayons, and all. Everything was there in the pencil box only. है ना? School, 5th class, 6th class, 4th class, 3rd class student, teacher is teaching. You know, remember that we use a pencil, beta. That pencil with inbuilt eraser, beta. Pencil with inbuilt eraser at the back. बड़ा अच्छा लगता था कि यार तेरे पास है, नहीं है मेरे पास है. Inbuilt eraser वाली pencil. You know, that was a big thing in those days, beta. है ना? Teacher is teaching, not my problem, beta. Some kids are rotating eraser in the nose, beta. This is almost orgasmic pleasure for the children, beta. Huh? Teacher is teaching. Taking round in the class, he slap on the face. What are you doing? And this kid removes the pencil and he says, "Oh, eraser still in the nose only." Do you think he will tell his father or mother at home that I have eraser in my nose? मेरे नाक में eraser रह गया. कभी नहीं बताएगा. He will never tell to his father or mother. Within 1 week, 10 days, the foreign body gets infected. From the infected foreign body, smell will start coming. Beta. Smell comes. You know, blood also comes, pus also comes, and that same question also comes in the paper. Read the question, beta. Now, 7-year-old child presenting with unilateral foul-smelling nasal discharge and epistaxis. The key word in this question is unilateral. 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 Okay. And 7-year-old child presenting with unilateral foul-smelling nasal discharge and epistaxis. The answer is foreign body in nose. Foreign body nose. Foreign body. Treatment is endoscopic removal. Endoscopic removal. Everybody look at screen, please see. This one, this is foreign. Okay. Put on scope, remove it quick. It's a very easy thing, beta. Very easy thing. Lot of things they put in the naak. क्या क्या नहीं डालते नाक में ये लोग. राजमा, मम्मी राजमा बनाई तो राजमा डाल देंगे. काले चने बने घर पे तो काले चने डाल देंगे. किसने इमली खाई तो इमली का दाना डाल देंगे. मटर बन रहे हैं, पुलाव मटर डाल देंगे. भगवान जाने क्या नाक में बीजना चाहते हैं, क्या उगाना चाहते हैं, ये बच्चे ही जानते हैं. I don't know what they want to harvest in the nose. Every seed they put in the nose actually, huh? And it's very common, very common. Foreign body is very, very common, but it's a very quick case for us. One kid wasted 10 minutes of the OT time actually. Why? He had put a lot of paper, but a folded laminated paper in the nose. 1 paper, 2 paper, 3 paper, 4 paper, 5 paper, 6 paper. पूरी library खोल रखी अंदर. I asked that kid at the discharge, come here, Atul, come here, tell me what was that paper. He said, uncle, उसने देखा मम्मी पापा तो नहीं है मेरे पास. अंकल मेरी मार्कशीट थी. उसकी मार्कशीट थी, नंबर अच्छे नहीं आए थे. टीचर मस्ट हैव टोल्ड गेट इट सेंट फ्रॉम योर फादर. उसने एविडेंस खत्म कर दिया, फाड़ के डस्टबिन में नहीं फेंका बेटा, नाक में डाल दी सारे कागज बेटा. सो इट्स वेरी 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 कॉमन फॉरेन बॉडी. ओके फाइन. नाउ फॉरेन बॉडी इन द नोज. नाउ बट डिस्क बैक्टीरी इन द नोज, esophagus, ear, treatment is urgent removal because we know battery is alkali which causes necrosis. Fine. Chalo. Now, myiasis, beta, maggots. Myiasis presence of maggot in the nose, beta. नाक में कीड़े पड़ गए तुम्हारे. Patient के तुम्हारे sorry तुम्हारे नहीं sorry. Patient has this kind of crawly things in the nose. The maggots are larvae of the housefly. Larvae of the housefly. Okay. Now, maggot or larva housefly chrysomia. Family name is chrysomia. You must be remember that the housefly scientific name is Musca domestica. I hope you remember. There are many houseflies, but the group name is chrysomia. Family name. Foul smelling condition lead to myiasis. Can you imagine some foreign body in the nose, rhinolith in the nose, foul smell attract the flies. If you're from village, kids are lying with the nose is flowing with the pus. Flies are sitting on the face. They enter the nose. In the nose, they lay egg. Inside the nose, flies lay the egg. From the egg, larvae come out. Those larvae are called maggots. And presence of maggot, a disease called myiasis. Myiasis. Treatment. ट्रीटमेंट ऑफ कोर्स किल देम बेटा, यू कैन अडॉप्ट देम ना, मारना ही पड़ेगा, अडॉप्ट तो नहीं कर सकते, है ना। मारने के लिए ऐसा नहीं कि मार्केट जाके काले वाला हिट ले आए बेटा, डोंट पुट ब्लैक हिट स्प्रे इन द नोज बेटा, है ना, पुट ब्लैक मैगेट ऑयल नेजल ड्रॉप, maggot oil nasal drop. Maggot oil contain chloroform. Chloroform plus turpentine. Turpentine oil. No Martin. Chloroform is the main thing, is chloroform plus turpentine oil. Chloroform is the main thing. Turpentine oil we have to put to dissolve the chloroform. Actually, we cannot use pure chloroform. Chloroform is an anesthetic agent also. In the overdose of chloroform, it can kill the patient also. To kill the maggot, आपने नाक में 10 ml chloroform, सीधा chloroform डाल दिया बेटा. You put direct chloroform in the nose, direct only chloroform 10 ml in the nose. Believe me, it can kill the patient also. आपने डाल दिया chloroform. Attendant ने पूछा सर maggot मर गए, patient हाँ वो भी मर गया, तो क्या बोलोगे? हाँ थोड़े side effects तो हैं इसके, ऐसा नहीं बोल सकते है ना. So overdose can kill the patient also. So you dissolve the chloroform in the turpentine oil, then you use it. But the main thing is chloroform. Okay, chalo. Next one. Next is trauma. I told you trauma is very important nowadays. Nasal bone fracture. It is most commonly fractured bone of face. Write down. Clinical picture. After trauma, number one, nasal deformity. Moment you see this question, after trauma, nasal deformity, this is about the nasal bone fracture. The main story will start after trauma, nasal deformity. The main and the diagnosis in your mind should be nasal deformity. It should be fracture. Number two, there can be crepitus. When you move the bone, click, 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 the sound comes, crepitus. Number three, plus minus swelling. Plus minus swelling. So after trauma, whenever you see the question nasal deformity, think of nasal bone fracture. There can be crepitus swelling also. Okay, which you find now, everybody. This is a patient. This is nasal bone, a very delicate bone, a very thin bone. It's a cosmetic bone, it's a very thin bone. It's a mainly cosmetic bone, and this decides the shape of your nose. And by chance get fractured. Can you see deformity of the nose? The nose got deformed. Okay, and the investigation. Write down investigation. You go for X-ray. Write down investigation. X-ray nasal bone right and left lateral view. X-ray nasal bone right and left lateral view. Okay, चलो थोड़ा पढ़ाई करो. Okay, X-ray nasal bone right and left lateral view. Can you see what over there? The bone is fractured over this point. Can you see yellow arrow? The bone is fractured at this point. Okay, so you have this patient who has a history of trauma, deformity, crepitus, maybe swelling there or not there. You get the X-ray done, and you take a special forceps to bring the bone back. How we do it? We do it under anesthesia in the operation theater. We don't waste time. We take it, a little urgently before swelling start. It is close reduction. Close reduction means without giving a cut on the skin. You hold the nasal bone with the special forceps called Walsham forceps, and you bring the bone back to its original place like this. Wow. So you keep doing it. It's a cosmetic bone and people want perfect nose actually. लोगों को perfect nose correction चाहिए. This is only possible if you do it without wasting time before swelling starts, beta. Okay, and people keep doing it. Surgeon will keep ask everybody on the operation theater, is it a good one or not? Fine. And this one, beta, fine. Well, after that, once everything is okay, then you put the, can you see light in the center now? Then you put the POP cast over there. Beta. Okay, that will really do. Okay, fine. So the treatment is immediate close reduction before edema. Next page, beta, next page. Treatment is question number 1, beta. 2 question. Treatment is immediate close reduction before edema start using Walsham forceps. Patient is under general anesthesia, beta, not marni kya wo. General anesthesia, Walsham forceps, beta. Walsham forceps, beta. Walsham forceps. Now, problem is question number 2. If edema is already there, then wait for 7 days. Why? Put an arrow to let edema subside. And then reduce the fracture. If question says edema is not there, then immediate. If question says edema is there, then wait for 7 days. Procedure is same, beta. You have to do close reduction with Walsham forceps. But if no edema is mentioned, then answer is immediate. And if you see the question with edema there, then wait for 7 days and then reduce the fracture. This is an important topic. Beta. Why edema is so important, beta? Because people want perfect correction of nose, and if there is swelling around the nose, you can't have a judgment of the case whether you did a good job or not, because people really want perfect noses, beta. लोगों को परफेक्ट नाक चाहिए अपना सर्जरी के बाद. कई लोग तो ये बोलते हैं पहले से बेटर चाहिए, जो टूटा था उससे पहले जो नाक था उससे भी बड़े. कहते हैं डॉक्टर साहब टूटा तो वो या बड़ा बढ़िया बना दो बा. वो बिल्कुल वैसे जैसे कि एक वो राजू श्रीवास्तव एक करेक्टर बनाए घूम रहे होते थे, जो फर्स्ट कॉमेडियन थे राजू श्रीवास्तव, एंड वो एक दीपक चौरसिया नामक ये बन के घूम रहे होते थे अपना रिपोर्टर, प्रेस रिपोर्टर. और मुझे याद है बिहार का सीन बनाया था, बिहार में बाढ़ आ गई, बहुत ज्यादा नुकसान हो गया, 4-5 औरतें खड़ी थी झुंड बना के. तो रिपोर्टर जाता है उनके पास दीपक चौरसिया की, आपको कोई नुकसान तो नहीं हुआ? तो एक औरत बोलती मेरा तो पति बह गया. तो कहता बताओ हम मदद करेंगे आपकी ढूंढने में, आप बताइए हुलिया. कह रही मेरा पति 6 फुट लंबा, एकदम घुंघराले बाल, चौड़ा सीना, एकदम मूछे बड़ी बड़ी. एंड साथ में उसकी बोलती तेरा पति तो नाटा था, गंजा था. हाँ, तो वो उसको बोलती तू चुप कर, अगर ये लोग ढूंढ रहे हैं इनको अच्छा ढूंढने दे, तुझे क्या प्रॉब्लम है? सो पीपल वांट बेटर देन बिफोर. एक्चुअली इस केस में उनकी एक्सपेक्टेशन इज वेरी वेरी हाई. सो दैट्स पॉसिबल ओनली इफ देयर इज नो swelling, beta. Swelling. Okay, fine. Now, nasal septum fracture. Septum fracture, beta. Look at me. Nasal septum fracture. This is septum, beta. Nasal septum fracture is of 2 type. Septum 2 type. ये डिपेंड करता है आप कैसे मार खाना पसंद करेंगे, आप कैसे, how you want to get hit, beta. If somebody hits from the front like this, beta, from front, it's a horizontal fracture. From below, vertical fracture. From front, horizontal fracture. From below, vertical fracture. Okay, fine. Now, draw a line, beta. If force is from front, it's called horizontal fracture or Zardaway fracture. If force is from below, vertical fracture or Chevalier fracture. Treatment is fracture reduction using Ash forceps. ASCH, but Ash. That was Walsham forceps, this is Ash forceps. So point to be remembered, if force is from front, look at me, beta, from front, horizontal fracture. From below, like this, from below, vertical fracture. Horizontal is called Zardaway, and below wala vertical is called Chevalier. Forceps is same, Ash forceps. ASCH, Ash forceps. Now, then zygomatic fracture or tripod fracture. This is second most commonly fractured bone of the face. Look at everybody. This is your zygomatic bone. Everybody touch you. It's the second. The first prominence is nasal prominence that get fractured. You're driving a motorcycle, fell down. this hits the ground like this, and this get depressed inside. Beta. Zygomatic bone has got 3 processes. That is why it's also called the tripod fracture. So 2 point to remember that the zygomatic fracture or tripod fracture, it's second most commonly fractured phase, and just write with your hand here, beta. It is called tripod fracture. Is equal to tripod fracture because it has got 3 processes. Okay. Okay. Right. There is no difference in clinical picture. It's examination finding. Nasal bone and nasal retinal fracture can be coexisting. No? It can exist in same patient. You have to always examine, always think clinically. Beta. First use history taking, then examine. Examination will tell you is one is fracture, both are fracture. Beta. Now, injury to infraorbital nerve is seen in. Now, infraorbital nerve is important. Beta. This is a very important question. This is your foramen called infraorbital foramen. From there, a nerve comes out. That nerve is called infraorbital nerve. All of touch your cheek, beta. All of look at me, beta. Touch your cheek. Apni cheek ko aise karo, aise. And not your neighbor's one. Pass beta, usko mat kar dena library mein baithe aise. Like this. Find this cheek sensation. The skin of the cheek is supplied by infraorbital nerve. If this nerve is damaged, you will have a chief complaint of cheek anesthesia. Now, injury to infraorbital nerve is seen in number 1, zygomatic fracture, maxilla fracture, and cardiomyopathy sinus. And chief complaint, very important question of applied anatomy. Cheek anesthesia. Due to injury to which nerve? Infraorbital nerve. This is an important applied anatomy question. Applied anatomy question. Okay, fine. So once again, beta, injury to infraorbital nerve is seen in 3 situations. Bolo beta, number 1, zygomatic fracture. Number 2, maxilla fracture. And number 3, the cardiomyopathy sinus. And the chief complaint is cheek anesthesia. And due to injury to which nerve? Infraorbital nerve. One more question, beta. Most commonly fractured part of mandible. Most commonly fractured part of mandible is condyle or subcondylar fracture. One line question. Most commonly fractured part of mandible is condyle or subcondylar fracture. Now, mid-face fracture or the leaf foot fracture. Leaf foot. It's a fracture of maxilla. There are 3 types of middle part of face fractures: leaf foot 1, leaf foot 2, leaf foot 3. Now, leaf foot 1, put a box for leaf foot 1 is equal to transverse fracture. Leaf foot 1 is equal to transverse fracture. Okay. Now, yes, there is sensory loss. Only sensory loss will be there. Okay. Now, it passes along the palate. This leads to number 1, floating palate. Floating palate, because palate got separated, floating palate. And number 2, ecchymosis on palate, which is called Guerin sign. This passes along the palate. There are 2 features of palate: floating palate and ecchymosis on palate. What is ecchymosis? Anybody? Anybody? What is ecchymosis? Now reply in the group. What is ecchymosis? What is ecchymosis? Beta? Yes, blue spots. Beta. Very good. Blue spot, right? On blue spot. Very good. Blue spots. Guerin sign. Beta. Yes. Blue color spot. Beta, like, है ना? Ecchymosis. Guerin sign. Beta. Guerin मतलब गिरने से क्या होता है? गिरने से फ्रैक्चर होता है. हिंदी बेटा, इफ यू नो लिटिल बिट हिंदी, गिरन मतलब गिरना, गिरने से फ्रैक्चर. गिरन साइन गिरने फ्रैक्चर में होता है. गिरन साइन एटलीस्ट फ्रैक्चर में होता है, याद आ जाएगा. एट इज 2 चॉइस रूल आउट. गिरन साइन गिरने से फ्रैक्चर तो होता है. तो लीफ फुट 1 फ्रैक्चर होता है. नाउ एवरी लुक एट स्क्रीन बेटा. दिस इज योर लीफ फुट 1 फ्रैक्चर बेटा. प्लीज सी. दिस इज passes along the palate like this. This is leaf foot 1. It passes along the palate. It leads to number 1, floating palate. Number 2, accumoson palate, which is called which sign? Girin sign. Beta. Now, LeFO2. First of all, don't forget, the roof of nose is base of brain. Beta. This is brain. And brain contains which fluid? Beta? CSF. And you know, roof of nose is base of brain. Beta. Okay? Look at me, beta. Roof of nose is base of brain. Now, everyone, please see over here. LeFO2 is called pyramidal fracture. LeFO2 is called pyramidal fracture. Pyramidal fracture. Okay, pyramidal. And LeFO3 is very dangerous, but LeFO3 is like that. It's a craniofacial disjunction. Craniofacial disjunction. Look at it. This is cranium, cap, skull cap. And craniofacial disjunction. Cranium or face, alag ho gaya, disjunction. High velocity accident, roadside highway accidents and all that. Big trauma, high velocity accidents. And पूरा ये खुल गया बेटा ब्रेन. पेशेंट कह रहा है डॉक्टर दमन, ओहो ये लो मेरी खोपड़ी, ब्रेन खुल गया यहाँ से बेटा. क्रेनियोफेशियल disjunctional disengagement. In LeFO2 and LeFO3, there is a chance of CSF rhinorrhea. CSF start coming in the nose. LeFO2 and LeFO3. Now read your notes. LeFO2 is also called pyramidal fracture. LeFO3 called craniofacial disjunction. LeFO2 and LeFO3 passing through base of skull. So there is possibility of CSF rhinorrhea. Girin sign is a blue spot on the palate. Purva, green, okay. Girin sign, Girin sign is bluish spots. Accumoson blue spots. Neel padjana. You know, neel padjana on the palate. This is called traumatic CSF leak, which is blood mixed CSF. Okay. Right. This is called traumatic CSF leak. Highlight the word traumatic CSF leak, which is blood mixed CSF. Let's revise. LeFO 1, 2, 3. Chalo, let's revise. These are mid-phase fracture, also called LeFO fracture. Everybody focus, revise with me. LeFO 1 is a transverse fracture. It passes along the palate. It gives two finding. Number 1, floating palate. Number 2, accumoson palate, which is called Girin sign. LeFO 2 is pyramidal fracture and LeFO 3 is craniofacial disjunction, and both of them got CSF rhinorrhea. And this type of leak is called traumatic CSF leak, and it's blood mixed CSF. Sure. Now, guys, have you done in ophthalmology the blowout fracture of orbit, teardrop sign? I'm waiting for everyone, beta. Do you know teardrop sign, beta? Okay, you know teardrop here, beta. This is a teardrop sign, beta. This is a very famous question of ophthalmology, radiology, ENT. You should be knowing about it. Beta. Fine. This is important, beta. Teardrop sign. Okay. Sure. So, very good. That's good. Now, next one, beta. Now come very important, but let's go inside the nose, lateral wall of nose. Let's understand first of all lateral wall. Everybody? Yes. Lateral wall of nose. Sure. Now, this is your lateral wall. First of all, my dear friends, all of you focus on the screen for next 1 minute. Let's understand lateral wall. It's a very easy wall. It has 3 projections called turbinates. Number 1, inferior turbinate, middle turbinate, superior turbinate. Okay, so, say it again. Number 1, inferior turbinate. Bolo beta number 1, inferior turbinate. Number 2, middle turbinate. Number 3, superior turbinate. Now, every turbinate has a bone inside that called concha. The bony part of turbinate is called concha. Okay. Inferior concha, middle concha, superior concha. Now repeat. Inferior concha, middle concha, superior concha. Okay. Now every turbinate has a space below that. That space is called meatus. Inferior meatus, middle meatus, superior meatus. Please read inferior meatus, middle meatus, superior meatus. And this is called sphenoethmoidal recess. This is called the sphenoethmoidal recess. Sphenoethmoidal recess. Anybody, you can take a picture and post in the group. Beta. Treatment of leaf foot fracture depending on the fracture. Beta. Leaf foot 2 and 3 would need, we'll discuss CSR rhinorrhea later. Beta. Full topic is coming. Okay. Have you taken the picture? Beta? Post in the group. Okay. Chalo. Very good. Let's go further now. Now, lateral wall of nose, number 1. Put number 1, beta. This is very easy topic, beta. Turbinate is a projection on lateral wall. Everybody read with me, beta. Turbinate is a projection on the lateral wall of the nose. The 3 turbinate: inferior, middle, superior. IT, MT, ST, beta. Okay. Now, concha is the bony part of turbinate. There are 3 concha. Inferior concha, write down. It is an independent bone. It's not a part of any bone. It's a complete bone in itself, beta. It's an independent bone, beta. It's an independent bone. It's not a part of any bone. Like femur is not a part of tibia, beta. Tibia is not a part of femur. Tibia is a different bone. Femur is a different bone, independent bone. Similarly, inferior concha is an independent bone, beta. Okay. Then, next page, beta. Middle concha, superior concha are part of, put an arrow, part of ethmoid bone. Remember, beta, middle turbinate, superior turbinate are part of which bone? Ethmoid bone, but inferior concha is an independent bone. Meatus, number 3, beta. Meatus is space below turbinate, beta. So number 1 was turbinate, number 2 concha, beta. Number 1 turbinate, number 2 concha. Very easy topic. Number 3 meatus. Space below turbinate got meatus. The 3 meatus: inferior meatus, middle meatus, superior meatus. And number 4 is sphenoethmoidal recess. It is area above the superior turbinate. Sphenoethmoidal recess. It is area above the superior turbinate. My dear friends, please allow me to show you the inferior concha. All of you, please see. This is your lateral wall of nose, red color wall. Huh? Now, can you see this 14 number bone? This is inferior concha. Can you see inferior concha? Beta? Inferior concha. Now, if I cover this with the mucosa, it becomes the inferior turbinate. Beta. This is inferior concha. This is inferior turbinate. Inferior concha, inferior turbinate. And this space below that, anybody, what is the name of this space? Beta? Right now, what is the name of this white arrow? Beta? Can you tell me? What is the name of this white arrow? I'm waiting for everyone to respond. This white arrow is in which area, beta? Everyone, please comment. Inferior meatus. Very good. Inferior meatus. Okay, very good. Inferior meatus. Okay, wonderful. Guys, you have a space here, na? Close to meatus, beta. You have a space there. Let us draw a diagram close to meatus area. Draw a diagram so that you are able to easily revise it. Chalo. Ji, beta, draw, bro. Have you drawn it, beta? Please write a chat yes in the chat box. Have you drawn it? Done? Very good. Let's stop putting JF. Sure. Now, everyone, sure. Koina, next topic, beta. This topic is over here, beta. Koina, no, not conca, beta. This Koina. This was the first question of out of nose in your paper of July, beta. Koina is the posterior opening of nasal cavity. End of the nose, beta. Koina is the posterior opening of nasal cavity, beta. Okay, Koina is the posterior opening of nasal cavity. All of you look at screen, beta. This is the, all you see, that's the inferior turbinate. The bone inside that, what you're feeling over there is inferior concha. If I put my endoscope right now, I'm entering where, beta? Inferior meatus. Once again, bache, this is inferior turbinate on the lateral wall of nose. The bone you feel inside that is called inferior concha. And now I'm putting the endoscope in the inferior meatus, which is below the inferior turbinate. Now, very good. This is the, let us see the cadaver, dead body. Okay. Now, please see, this is the lateral wall of nose. See the turbinate, beta? Again. Now, this is the skin side is the lateral wall, beta. Skin side. The skin side is lateral wall. Let's go on the lateral wall. Right now, we enter the lateral wall. This you are seeing on the top of the nose, something coming, hanging down. This is middle turbinate, beta. It's a middle turbinate. And this is the inferior turbinate, beta. That's the inferior turbinate, beta. Okay. Now, you can see the inferior turbinate along the lower part of picture on the lateral wall. From the upper part, this one which is hanging, this one which is hanging here is middle turbinate. Now, let us see below. This is the inferior turbinate. Now, if you go all along the length of the nose till the end of the, let us go, turbinate go till the end of the nose, beta. And let us go in the nose. We're going like this, and the end of the nose come, beta. Turbinate go till the end of the nose. This opening is called coena. Okay, the coena. Okay, fine. Okay, fine. Coena. Now, coena, not concha. Concha is bony part turbinate. Coena is this opening of the nose, and that's called coena. So again, not concha. Coena is the posterior opening of the nasal cavity. Now, what the purpose is turbinate? They create currents of the air for proper ventilation. Beta. Coenal atresia. It's a congenital disease. Beta. Atresia, it's closed. Due to persistence of bucco-nasal membrane, that's an embryology question. Beta. Some children will have this problem. Beta. That they can have the problem. Coena, different coena is this one. Beta. Coena is the posterior opening nasal cavity, and you're breathing very comfortably. But imagine coena is blocked. Beta. This side, it is blocked, it is open, it is coenal atresia, but it is unilateral, still no problem, not a big serious affair after the birth of the baby. Problem is now 3 MCQ of MCA paper now coming for you, beta. First is this one, beta. Both closed, beta. Both coenal, bilateral complete coenal atresia is a neonatal airway emergency. Right after the birth, the baby will get cyanosis. Right after birth, baby gets cyanosis. Why? This is the first question of your paper. Bilateral complete coenal atresia is a neonatal airway emergency. Why? Because neonates are obligatory nasal breathers. Neonates are obligatory nasal breathers. Neonates are obligatory nasal breathers means they only know that only one way to breathe is nose, beta. They don't know that mouth can also be used for breathing, beta. Look at me, beta. If I close your nose like this, beta, if I pinch your nose, will you die? No. You will open the mouth. You survive. Baby does not know this trick. Baby only knows one way to breathe is nose. Baby does not know there is another way to breathe is through mouth also. Mouth breathing we learn with the age actually. Okay. But newborn baby, 1 minute old baby does not know this. So that's why chief complaint, cyanosis at birth. Cyanosis at birth. Immediately after birth, they get cyanosis. Cyanosis at birth. Cyanosis, beta. Okay, fine. Put an arrow, beta. Arrow dalo. Put an arrow. That's so therefore cyanosis at birth, beta. You know the baby is being delivered. Now baby is handed over to the pediatrician, and it's a labor room scene. Now, what is the first job of pediatrician, beta? In every normal child also, in any child also, first of all, they pass the suction catheter through the nose to suck the amniotic fluid out to clear the pharynx and nose so the baby is able to breathe comfortably. In this patient, do you tell me, will the pediatrician be able to pass suction catheter to the nose? Tell me, in this child, will the pediatrician be able to pass suction catheter to the nose? Yes or no, beta? Yes or no? No. Next line, next page, beta, first line, highlight, beta. The pediatrician is unable to pass suction catheter through the nose, beta. Next page, beta, first line. Pediatrician is unable to pass suction catheter through the nose, beta. Now, clinical picture. That is the question number 2. Blue baby turns pink on crying, beta. Crying, beta. It's a very magical thing, beta. It's a very magical thing. Baby is cynosed at birth, beta. Okay, but the moment baby cries, blue baby turns pink on crying. You know, please see, for crying, the baby has to open the mouth, beta. For crying, the baby has to open the mouth. Hai? That's why. Write down, cry is equal to deep inspiration with open mouth. Cry is equal to deep inspiration with open mouth. Cry is equal to deep inspiration with open mouth. Guys, can you cry with closed mouth? Tell me. Can you cry with closed mouth? All of you. Try this, beta. करके दिखाओ, रिकॉर्ड करके भेजो, अपनी वीडियो बना के भेजो, अपनी वीडियो बना के भेजो. रोना है लेकिन मुंह नहीं खोलना बेटा. रो के दिखाओ बेटा. रोने की आवाज निकालो लेकिन मुंह नहीं खोलना. कर सकते हो तो बेटा वीडियो बना के डालो ग्रुप में. इतने सारे जीआईएफ, अपना जीआईएफ डालो जरा. जो लोग इतने जीआईएफ डाल रहे हैं, एक अपना जीआईएफ करके दिखाओ जरा. और इतना, कैन यू क्राई विदाउट ओपनिंग माउथ बेटा? डीप इंस्पिरेशन विद ओपन माउथ बेटा. डोंट कमेंट ऑन गर्ल्स, बॉयज एंड ऑल दैट. Dry inspiration, deep inspiration with open mouth. Okay, fine. रोने की आवाज निकालनी है भाई. बच्चे को रोना, टीयर वाला रोना नहीं आता. Deep inspiration with open mouth. Okay. Now, this is a baby who has got cyanosis. Blue baby turns pink on crying is a definite clue for coronary atresia. Now, immediately the call goes to ENT doctor. ENT doctor are not found in the labor room. It's a labor room scene going on right now. It's a newborn baby. Right now, the call goes to ENT doctor. Come fast, there's a baby of coronary atresia. ENT doctor are not found in the labor room. They're not found in the hospital also. ENT doctor found in the Starbucks, Costa Coffee, Cafe Coffee Day, having some more interesting thing in life actually. Hai na? So when the call comes, I tell the pediatrician, see, I'm out of hospital. It will take me 15-20 minutes to reach. Till that time, you have to survive the baby. It's your responsibility. Now, problem is, pediatrician knows if the baby will close the mouth, he will die. The pediatrician ये तो नहीं कर सकता ना कि बच्चे को बोले बेटा मुंह मत बंद करना, मरा मर जाएगा, मुंह खोल के रख, जीना तो ऐसा तो नहीं कर सकता. Pediatrician has a brain, है ना? He's a very sharp doctor, very intelligent doctor. So what he will do, he put a wide bore nipple in child mouth and tie it so that child is not able to close the mouth. And this technique is called McGovern technique. Third question of your paper. Right on. Immediate treatment is put wide bore nipple in child mouth. In the bracket, it is called McGovern's technique. So this is the third question of your topic. Star question. McGovern technique. McGovern technique. Put an arrow. This is done by, this is pediatrician beta. अब ENT doctor की entry होती है बेटा. ENT doctor now enter the scene. 15 minutes late. Now, then he do tracheostomy. Tracheostomy. Then surgery at 1 year. You have to wait for 1 year to make the hole. You have to make a drill the hole in the behind the nose. For that, you have to grow, let the child grow up better. Surgery at 1 year of age. Surgery at 1 year of age. Tracheostomies and surgery. Let us revise the topic. Choana is the posterior opening of the nasal cavity. Choana should be open better. Choana, somebody asked, can it be unilateral, bilateral? Corneal atresia can be unilateral also, bilateral also. This is unilateral, number one picture. Number two is bilateral. Bilateral is very dangerous, beta. Why? Because neonates are obligatory nasal breather is the first question, beta. The baby has cyanosis at birth, but the important thing is blue baby turns pink on crying, beta. The immediate treatment is put wide bore nipple in child's mouth, and this is called which technique? McGowan technique. Then the ENT doctor will do the tracheostomy, then proper surgery at 1 year of age. Now, it's a recanalization surgery. Drilling, we do drilling better. Okay, chalo. Next topic, paranasal sinuses. Around the nose, sinuses better. Write down sinuses, put an arrow. Mucosa-lined hollow cavity in skull bone. The skull bones have got hollow cavity which are lined by mucosa called sinuses. They are ventilated during expiration. In the bracket, air-filled. Air-filled, they are air-filled. Yes, till 1 year, tracheostomy is required. Okay, fine. Okay. They secrete mucus which drain to the nose, ostium, is sinus opening in nose. It is standard tracheostomy, but not permanent. It is standard tracheostomy. Every case you do standard tracheostomy. Only in laryngectomy you do a permanent bit. Sinus opening in the nose. So sinuses are nothing but hollow cavity in the skull bone. Look at the name of the bone is name of sinus. For example, maxilla contain maxillary sinus, frontal bone contain frontal sinus, ethmoid bone ethmoid sinus, and sphenoid bone sphenoid sinus. Every sinus is lined by the mucosa. It's a hollow cavity lined by mucosa, and the air enters during the expiratory phase of respiration. It's air-filled bit, okay? And they secrete mucus, and the mucus is drained into the nose. Every sinus has an opening in the nose, which is called ostium. Ostium bit, okay? So let's divide bit. Sinuses are mucosa-lined hollow cavities in skull bone, which are filled with the air. Air is entering during expiration, and the sinuses produce mucus, which is drained into the nose, and the ostium is the sinus opening in the nose. Okay, now, next one. There are 4 pairs of sinuses. Number one, maxillary sinus, also called antrum of Hymore. Antrum of Hymore, beta. Hymore. Wherever you see the word antrum, think of maxillary sinus, beta. Like antral polyp, antral wash, antral endoscopy. Antrum in nose means maxillary sinus. It is larger sinus. Its volume is 15 ml air, beta. Mucus is very less, beta. Mucus is continuously going out of the sinus. Beta. Main is air. Mucus only layer. Main is air. Mucus is only layer. Okay, man, kya baat hai. Number 2, frontal sinus, beta. Frontal bone, frontal sinus. Okay. Sphenoid bone, sphenoid. Spelling correction, beta. Spheroid means sphenoid. Sphenoid. Okay. Sphenoid bone, sphenoid sinus. And ethmoid bone is ethmoid sinus, also called ethmoid air cell, beta. Ethmoid bone is ethmoid air cell. Everybody look at me, beta. This is name of bone is name of sinus, beta. Look at me, beta. Look at me. This is, of course, everybody knows this is M, beta. What is M? M is maxillary sinus. F is frontal sinus. Now, please look at me, beta. Below the orbit is maxillary sinus. Above the orbit is frontal sinus. Behind the orbit is sphenoid sinus. And between the orbit is the ethmoid sinus, beta. So this is your maxillary sinus, beta. This is your frontal sinus. Air-filled hollow cavities, beta. Okay, in the nose, beta. Okay, now everybody, let me show you the CT scan over there. Now, please see. Now, everybody, this is orbit, orbit. This is M, beta. Below the orbit is N, beta, maxillary sinus. Now, please see, between the 2 orbit, can you see this bone? This bone is ethmoid bone, beta. This between the 2 orbit, a single bone is there. A single bone is there, ethmoid bone. And can you see ethmoid bone has got many small hollow spaces called ethmoid air cell, and they are called collectively ethmoid sinus. Please see, please compare maxillary sinus with the ethmoid sinus. This is ethmoid. Ethmoid is a collection of small air cell, where maxillary is single sinus. Okay, fine. Okay. Can you see what ethmoid is small air cell like that? Okay, that's a difference. Now, everybody, ethmoid sinus, that's why we call it ethmoid air cell. Now write down. Ethmoid bone is single bone between two orbits. Ethmoid bone is single bone between two orbits. There's only one ethmoid bone in your body. Ethmoid bone is a single bone between two orbits. Please understand this one. Please see. This is your ethmoid bone. This red is ethmoid bone. And in this, you got many air cell called ethmoid air cell. Brain is here. Brain is here. Okay. So this red bone is the ethmoid bone. On the next page, please come with me. Let us draw the ethmoid. Next page, draw the ethmoid bone. Draw it up. These are ethmoid air cells. This is brain. There are some ready-made holes over here. Which are called cribriform plate. From cribriform plate, we have some neurons going to brain. They are olfactory neurons. Smell neurons. Cribriform plate and the smell neuron pass to that. Okay. Now, these ethmoid air cells, please join this with this, ethmoid air cells. So these are the ethmoid air cell. Please label them like this, so that you know what you're studying further. Now, ethmoid air cells has two groups. Draw a line like this. Put a box, put the anterior group cells, posterior group cells. Number on CT scan. How we count them? You saw a CT scan. Number on CT scan. Number is 2 to 8. If you count on CT scan, minimum 2, maximum 8. Posterior is 1 to 8. Put a circle of 2. Circle around the 2. Put an arrow like that. These two ethmoid air cells are constant. Everybody will have that for sure on CT scan. All of us will be having these two anterior ethmoid air cells for sure. And they are named as following. Both are MCQ. Now, number 1 is bulla ethmoidalis and number 2, agar-nazi. Bulla ethmoidalis was the question of July paper. Second question of the July paper was about bulla ethmoidalis. But I'll tell you what question came with. So, bulla ethmoidalis is the second question. Bulla ethmoidalis is largest anterior ethmoid cell. Bulla ethmodalis is largest anterior ethmoid cell. Agarnazi is anterior-most anterior ethmoid cell. Anterior-most anterior ethmoid cell. How to remember? B for bulla, B for biggest. B for bulla, B for biggest, B for bada. B for English, B for bulla, B for biggest. Agarnazi, A-double-G-E-R. If you read in A-double-G-E in Hindi, it becomes Aage. If you read a bit of Hindi, Agarnazi is Aage. Aage means सबसे आगे. Very easy to define the question. Agarnazi is Aage. Aage beta. Swaroop, ethmoid bone is a single bone with knee between two orbits. Swaroop, ethmoid bone is a single bone between two orbits. Beta. Okay. How to remember? B for bulla, B for biggest, B for bada. Largest anterior ethmoid cell is bulla ethmodalis, and Agarnazi is most anterior cell. Beta. Agar, A-double-G, Aage. In English, A-double-G, A for agar, A for anterior most. Beta. Okay. If you know Hindi a little bit, Aage, you know the answer already. Beta. Both are MCQs of your paper. Beta. Star question. Beta. Star question. Okay, bache, fine. Now, next page. Beta. Next page. This is very, very, very important. So this whole thing is very important. Beta. In some people, ethmoid air cell can grow at 3 unusual area. Beta. Unusual area. Yes, we have seen the CT scan. Beta. Jeevan, this is lateral wall of nose only. Na, beta. Let me show you. Please see. Beta. Now, Jeevan is asking what is the lateral wall. Beta. This is the lateral wall. Beta. This is the lateral wall. Can you see inferior turbinate here? Beta? That's the inferior turbinate. That's the inferior meatus. So this is lateral wall. Na? Fine. Now, guys, please see. In some people, ethmoid air cell can grow into unusual area. कुछ लोगों को आदत होती है neighbors के घर में घुसने की. Some people try to enter the neighbors' houses. You know, some people have that habit. है ना? Now, please see. By chance, it grows into the floor of the orbit. Or it will go close to a nerve. You know, there is a nerve called optic nerve here. Okay. Or it will grow into the middle turbinate. But if you remember, which concha is independent bone? But everybody tell me. Which concha is independent bone? Anyone? Which concha is independent bone? Inferior. But middle concha, superior concha are part of which bone? Beta? Middle concha is the part of which bone? Beta? Is the part of which bone? Beta? The part of which bone? Middle concha, superior concha are part of which bone? Ethmoid bone. Ethmoid bone. So can you see what 3 variation? Number 1 is the floor of the orbit. Number 2, optic nerve. Number 3, inside middle turbinate. So these are 3 variation we see on the CT scan. Very good, Beta. Very good. In some people, ethmoid air cell can grow at 3 unusual area. Right, Beta, on CT scan. We cannot dissect the patient. Beta. All these are CT scan finding. Beta. Put 3 arrow in orbital floor to optic nerve. Orbital floor, they're called Heller cell. H-A-L-L-E-R. Optic nerve called O-node cell. O or O-node. O for optic, N for nerve. O for O-node, N for nerve. O-node. Inside middle turbinate. Inside middle turbinate is called concha bullosa. Concha bullosa. O-node, O for optic, N for nerve. Optic nerve. Optic nerve. Okay, Heller cell, O-node cell, concha bullosa. Let's revise these 5 cells. Let me record this for you. It's fine. Very good. Now I'm just saying and you recording and you repeat. Revise. 2 ethmoid air cells are constant. Number 1, bulla ethmodalis. B for bulla, B for biggest. So bulla is the largest anterior ethmoid air cell. Number 2 is agar nazi. A for agar, A for anterior most anterior ethmoid air cell. Agar nazi, A double G, aage. In some people, there can be 3 unusual ethmoid air cell. If ethmoid air cell is found in the orbital floor, it is called Heller cell. If it is found close to optic nerve, it is called Onodi cell. If it grows inside middle turbinate, it is called concha bullosa. All these cells are seen on the CT scan. So this is about the ethmoid air cell summary. Okay, chalo. Very good. Now, the next one. Structures draining in nasal cavity. Number 1, nasolacrimal duct. Drain into inferior meatus. Nasolacrimal duct drain into inferior meatus. Now, number 2, maxillary frontal anterior ethmoid drain into middle meatus. Number 3, posterior ethmoid air cell drain into superior meatus. And number 4 is the sphenoid sinus drain into the sphenoethmoidal recess. Can we put a bracket here, beta? This is one group, beta. Let's revise, beta. What opens into inferior meatus? Nasolacrimal duct, in the bracket tear duct. Maxillary frontal anterior ethmoid air cells drain into middle meatus. Posterior ethmoid air cell drain into superior meatus. And sphenoid sinus drain into sphenoethmoidal recess. Okay. Once again, beta, what drains into, all of you beta tell me. Now it is your turn to answer, beta. Everybody, what drains here? Question number 1, beta. July mein question aaya tha, I'll tell you. No. I'll tell you, beta. Wait. It will be coming. What drains into the arrow, pink arrow, beta? Pura likho, beta, pura. Shivendra, review your answer. Yes, posterior ethmoid air cell, beta. Very good. What drains here, beta? Second arrow, beta. Second arrow. What drains in this area, beta? Yes, sphenoid sinus drain into the sphenoethmoidal recess. What drains here? The arrow number 3. Nasolacrimal duct. Finally, most important meatus is maxillary frontal anterior ethmoid air cell open into the middle meatus. Fine? Very good. Chalo. This is very important. In ophtha, you would have done a topic, chronic dacryocystitis, lacrimal sac infection. The surgery is called DCR, dacryocystorhinostomy. DCR opening is made in the middle meatus. Do you know better this question, beta? DCR opening, so the name of surgery, lacrimal sac surgery, that's the opening is made in the middle meatus. Beta. Nasolacrimal duct opening in the inferior meatus. But DCR opening is made, this is surgery, beta, in the middle meatus. Okay, fine. Chalo. Everybody. This is clear, beta. What is NLD? Nasolacrimal duct in the inferior meatus. The surgery of ophthalmology called DCR, dacryocystoreinostomy. This opening is made in the middle meatus. Middle meatus. Okay, fine. Now, let me show you one of this opening, beta. Anybody, what is this turbinate, beta? Anybody, what is this turbinate? Anybody? This turbinate is which turbinate, beta? Inferior turbinate, beta. Now, please see where I am putting my endoscope right now. Where I am putting my endoscope right now, beta. Right now, my endoscope is in which meatus, beta? Inferior meatus. Very good. I should be seeing the opening of which structure in this area? I should be seeing the opening of which structure in the area I'm seeing with the endoscope right now. Yes, yes. Nasolacrimal duct opening. Okay. Let us see. Right now, my endoscope in the inferior meatus area, and I'm trying to find out the opening of nasolacrimal duct. This is right now inferior meatus area, and this is the opening of nasolacrimal duct. Can you see it up? Nasolacrimal duct. Okay, बच्चे fine, fine. ये सब कुछ सच में होता है बेटा, मैं कहानियां नहीं बना रहा बैठ के. ये सब कुछ सच सच होता है, जो मैं बता रहा हूँ वही मतलब वो होता है, कहानियां नहीं है बेटा. ऐसा नहीं कि लेट अस सपोज देयर इज किडनी, देयर इज किडनी. फिजिक्स थोड़ी है, फिजिक्स में लेट अस सपोज x इक्वल टू y, है ना. Fine. This is right now from tears come from here, beta. When you cry, you don't wipe your eyes, beta. When you cry, you wipe your nose. Okay, beta, fine. Okay, beta, fine. Now, so when this duct is blocked, you got lacrimal sac infection, and the name of disease is chronic dacryocystitis. Name of surgery is DCR, full form dacryocystorhinostomy, and that hole is made in the middle meatus because this hole is useless, beta. Okay, beta, fine. Now. Okay, fine. I have one NEET PG question to show you. Actually, DCR surgery is being done by ophtha people also, ENT people also, because right close to nose is the lacrimal sac is here, na? Fine. So we are also doing this surgery in ENT department. For that, we use a special instrument. Please click the picture. DCR is being done by both departments. Now, ophtha also, ENT also. Click the picture and post in the group and save the picture also. Save the picture also. This is a special instrument we use for endoscopic DCR. We are doing endoscopic DCR. Ophtha people do open DCR. They give scar. We never give scar. Ophtha wale scar dete beta, जख्म देते, हम नहीं जख्म देते बेटा. ENT वाले scarless surgery बेटा, हम लोग किसी को जख्म नहीं देते. Okay, fine. DCR surgery हम लोग की तरफ भी आ गई है थोड़ी. DCR is being done by ophtha people also, ENT people also. That's why ophtha people do not like us much. इसलिए ophtha के लोगों हमारे ENT वाले अच्छे नहीं लगते. कहते हैं हमारी सर्जरी उधर ले गए यार, है ना? Fine, fine. Endoscopic DCR. आज रात को खाना नहीं मिलेगा बेटा. For chronic dacryocystitis. Okay. So please remember this instrument. The name of instrument is Carison's endoscopic DCR bone punch. It's an ENT instrument, but a special instrument we use to break that bone to open the sac in the nose. And the name of instrument is Carison's endoscopic DCR bone punch. Okay. And this is endoscopic DCR surgery done by ENT people. And the indication is same, but a chronic dacryocystitis. Fine. हमारा घर पक्का है भाई, बड़े सालों से पक्का है. Middle meatus. Middle meatus. Me and Anuradha, we are batchmates since MBBS first year, so we know each other very well for last many years now. So we have studied together in MBBS. चलो, middle meatus is very important. वीडियो बना लिया, बस भेज दो मैडम को. मैडम को बताऊं, पता ही बोलेंगे ये कुछ बोलते रहते हैं. Middle meatus. It is the most important area of sinus drainage. It is most important area of sinus drainage. You already said that anybody, which three sinus open into middle meatus? Which three sinus open to middle meatus? Into middle meatus. Anybody? Okay, maxillary, frontal, anterior spine. So this is the most important area of sinus drainage. It has three landmarks right now. It has three landmarks. Number one, bulla ethmodalis. Number one, bulla ethmodalis. Okay, bulla ethmodalis, largest cell of the ethmoid. Uncinate process, better. Draw it like this. It's a sickle-shaped bone which covers bulla ethmodalis. It's a sickle-shaped bone which covers bulla ethmodalis. Which partially, not fully, but partially. It's a sickle-shaped bone which partially covers bulla ethmoidalis. And number 3, ethmoidal infundibulum. It is spaced between BE and UP. It is spaced between BE and UP, beta. Okay, look at my hand, beta. This hand is bulla ethmoidalis, largest cell of the ethmoid. This hand is uncinate process, beta. Please see, beta. This hand is bulla ethmoidalis. This hand is uncinate process, beta. Uncinate process partially covers the bulla ethmoidalis, beta. Okay. Now look at space, beta. There's some space between the bulla and the uncinate. This space is called the ethmoidal infundibulum. Bulla and uncinate are not attached to each other, but a little away from each other. This space between the two is called the ethmoidal infundibulum. So highlight 3 words, beta. Number 1, bulla ethmoidalis. Number 2, uncinate process. And number 3 is ethmoidal infundibulum. Ethmoidal infundibulum is spaced between BE and UP, beta. Now let me show you. This is middle terminal. When I label it, then you take a picture. Huh? This is middle meatus. Okay. This is middle terminal. My friend, this is middle turbinate, huh? Middle turbinate. I'm going to remove it. The middle meatus. Middle meatus. Now, this cell is bulla ethmoidalis. And this sickle-shaped bone, this sickle-shaped bone, this one sickle-shaped bone is uncinate process. So, everybody, take a picture, madam. Take a picture. 1 second, madam. Sure. So this is middle turbinate. This is your middle meatus. This cell is bulla ethmoidalis. On that, we have an uncinate process. And the space between the two is called ethmoidal infundibulum. What was the July paper question? Which part of nose you will find bulla ethmoidalis? Inferior meatus, middle meatus, superior meatus, phenotmonal recess. The answer is middle meatus. Can you see the level of question? Simple, straightforward question. With a choanal again, blue baby turns pink on crying, McGowan technique. Simple question, beta. ऐसा नहीं कि सारे question are difficult, beta. Straightforward questions. Choanal question came. Where is bulla ethmoidalis? Middle meatus also came, beta. Okay, fine. Chalo. Everybody, 3 sinus drain into middle meatus, beta. Maxillary, frontal, anterior ethmoid. But which part of middle meatus, beta? Now, next page, beta. 3 sinuses drain into the ethmoidal infundibulum area of middle meatus. Which part of middle meatus? Middle meatus is very long meatus. Beta. Which part of middle meatus? Into ethmoidal infundibulum area of middle meatus. This whole unit is called osteomeatal complex. OMC, beta. Osteomeatal complex, beta. Osteomeatal complex. If OMC is blocked due to mucosal edema, it will lead to blockage of sinus drainage. That will lead to sinusitis. Sinus produce mucus, and if the mucus cannot come down because the blockage of drainage, and if it is more than 3 months, it is called chronic rhinosinusitis, CRS. Chronic rhinosinusitis. Why is rhinosinusitis, beta? Because the main problem, main culprit is nose, beta. Now, neat PG question. Basic pathology in sinusitis is OMC blockage. That's the answer. OMC is a very important word, beta. OMC is osteomeatal complex, beta. OMC is the word. So basic sinusitis की problem की जड़ कहाँ पे है? There is a root of the problem called sinusitis is nose. Which part of nose? Osteomeatal complex. What happens there? Infection. What did infection lead to? Edema. If OMC has edema, the sinus cannot drain over there. Sinus produce mucus. Mucus cannot drain, and that mucus get infected, called sinusitis. And if the problem stays there for 3 months, it is called chronic rhinosinusitis. Okay, fine. Now, next one, beta. Chief put an arrow, beta. Chief complaint, nasal blockage. Why? Because of edema. Don't you say there's congestion, beta? Congestion. Okay. Now, number 2, purulent discharge. Main problem is nose, beta. Right down, beta. Because nose problem is the main thing, beta. Nose is the main problem, beta. 99% of nose symptom are there, beta. Lot of pus is coming from the nose, beta. Post-nasal discharge. Number 3, post-nasal drip. Dr. Dhawan, when I do like this, some yellow pus comes in my throat. Post-nasal drip. Pus is falling in my throat. Number 4, decreased sense of smell. Hyposmia. Why? How we smell, beta? Through air. Through air, beta. Look at me. How I smell my tea? Through air, beta. Because less air go because of edema, so less smell will be there, beta. Now, what is the symptom of sinuses, beta? This sinus symptom is from here, beta. These all are nose symptoms, beta. Chronic rhinosinusitis, main is nose, beta. Sinus symptoms start from here, beta. Number 1, office headache. Matlab periodic headache. Only in the daytime headache when you're working in the office, this area is full of pain actually. It's a feature of frontal sinusitis. Number 2, cheek pain. Cheek pain is maxillary sinusitis. That's a common sense, but cheek pain is maxillary sinusitis. Number 3, beta. Medial canthus. Or bridge of nose pain. Any idea? Either pain. Look at me, beta. Either medial canthus or bridge of the nose pain. Beta. Anybody? Is which one, beta? Anybody? Ethmoid sinusitis. Very good. Ethmoid. Very good. Number 4, beta. Pain at occiput or vertex. Vertex is top of skull. Beta. Pain at occiput or vertex. What is vertex? The highest point of skull is a feature of sphenoid sinusitis. This is important, beta. You can see, beta, you develop an eye of the examiner. Let's crack the examiner brain. They find these kind of things interesting, beta. Hai? Let's revise. Office headache is a feature of frontal sinusitis. Office headache is a feature of frontal sinusitis. Periodic headache. Cheek pain for maxillary sinusitis. Medial canthus or bridge of the nose pain, ethmoid. Pain at occiput or vertex, sphenoid. What is vertex? Top of the skull, beta. Top of the skull. This is important to design the MCQs of NEET PG, beta. They use that. They give you a history of sinusitis, but little specific pain in this area, that area. Which sinusitis expect, beta? Okay. The answer is as per the pain area. Now, investigation, beta. Imagine me and my chief surgeon. I forget the name of that chief surgeon. What was the name of chief surgeon? मैं भूल गया. Nishant? No. Some Sharma ji. Anyway, me and my chief surgeon are today in the OPD. We saw a patient, Nitesh, yes, Nitesh. Me and Nitesh are working in the OPD and we saw in the OPD a patient of sinusitis. How will we investigate it? Number 1. Number 1 is nasal endoscopy. Best investigation. We check 3 areas, beta. Number 1, number 2, number 3. First of all, we check the inferior turbinate. Along the inferior turbinate, we check and come out Second pass we do above the middle turbinate in the upper part of nose. And third pass we check in the middle meatus. Every part we check one by one and we make notes of that. Any edema, any pulse, any congestion, any polyp, anything we note, we make a note. Once again, let's revise. First pass is the long inferior turbinate. Second pass is above middle turbinate. Third pass is inside middle meatus. Third pass inside middle meatus. And this is NEET PG question. Fine. Now, then we ask for X-ray. Now, X-ray is a 5-star question. Till January, every exam we're getting 1 or 2 questions on X-ray only. The best X-ray analysis is water fluid. Pass with the endoscope pass. Look at me, meet. We go like this. One pass, we come out. We clean the endoscope. Second pass. Everyone pass. We pass the endoscope like this. Fine. Every time we come out. Yes. It shows all the sinuses except posterior point. MCQ. MCQ. Best X-ray is the water view. It shows all the sinus except posterior point. Next one. Water view shows maxillary sinus most clearly. If any X-ray in the exam is showing maxillary sinus very clearly, it's actually water view. Most clearly with sinus. Water view shows maxillary sinus most clearly. Please see the maxillary. This is water view. This is water view. And this is your orbit and orbit. This is your M. What is M? Maxillary sinus. Can you see? Beautifully visible. If I ask you frontal, not that great, but maxillary is very nicely visible. Now see everybody, can you see maxillary sinus over here? This arrow shows maxillary sinus very nicely. Full outline is very nice. If any X-ray shows maxillary sinus very clearly, the answer is only water view. Now next point. It can be done with open mouth. Not always, it can be done with open mouth to see sphenoid sinus. To see sphenoid sinus. So why we open the mouth sometimes to see the sinus? Sphenoid sinus. In this X-ray, the mouth is open. Can you see? The mouth is open. This is mouth is open. Which sinus you are seeing through that? The sinus you're seeing through open mouth, this sinus is S. What is S? Sphenoid. This is M. What is M? Maxillary. Now see, sometimes you do it with open mouth to include which sinus? S. What is S? Sphenoid. Now, next one. Water view plus open mouth is equal to Pires view. Water view plus open mouth is equal to Pires view. But if that is not given the choice, it is water view only. In India, we never use the word Pires view. In one of the MCQs of NEET PG, it is asked, what is Pires view? Pires view is nothing but water view with open mouth. But in India, we use both water view with open mouth, without open mouth also, we call it water view only. So water view with open mouth is the also called as Pires view. But if not the choice, then we see the water view. In your exam, Pires view word has never come. Okay, so very simple. If any X-ray shows maxillary sinus very clearly, it has to be the water view. Okay, the best X-ray view for the sinuses. Individual sinuses. Write down. Number 1, maxillary sinus is water view. Somebody, how we do it? We do it. Water view is actually occipitomental view. Occipitomental view. Like this, like this. Occipitomental chin. Like this. We keep an angle like that. Occipitomental view. Okay. Number 2 is frontal ethmoid cardival view. This is a NEET PG question. Cardival view is occipitofrontal view. Please don't write anything confusing, beta. Everything being checked, verified, and put, beta. Okay, right. In your exam, peer review has never come. Peer review is a standalone question of NEET PG. What is peer review? It is water review with open mouth, beta. Okay. Number 3, beta. Number 3 is sphenoid. For sphenoid, we do X-ray skull lateral build. Very crystal clear concept in your head that will make you do less silly mistake. But too much of confusion, paper will also have confusion otherwise. X-ray skull lateral view, beta. Everybody, now I want to show you one image and you will see what to mark where, beta. Click the picture and keep it. Now please see, beta. Can you mark this as a water view? Can you see any Fmge sinus clearly in this one, beta? Not at all, beta. This cannot be water view. Forget about this. If Fmge is not clearly visible, then you mark the answer cardable view, beta. If Fmge is clearly visible, you mark the answer water view, beta. Click the picture, post the picture, beta. Keep it with you. Don't get confused. Forget about peer review. First of all, peer review is nothing but a specific question. Peer review means water with open mouth is also called as peer review. Okay, forget about it. You check if peer review not a choice, delete that from mind, beta. The fight between water view and cardable view. If maxillary is clearly visible, be the mouth open, be the mouth not open, it is actually water's view. If frontal maxillary is not clearly visible, it's what cardable view. Am I clear, beta? Fine. Don't confuse yourself, beta. First of all, scan the choices. If peer review not an answer, delete from your thought. The fight is between the two answers, beta. Water view, cardable view. If maxillary is clearly visible, be it mouth open, be it mouth closed, you mark water view. If maxillary is not clearly visible, you mark cardable view. That's all about it. Don't overbug and lose the marks over there. Okay, fine. Chalo. Now, next one, beta. Have you taken this is a very important picture to be reserved and revised, beta. When I'm saying save the picture, these are must to be revised in the last part of the preparation, beta. Everybody go to the next page and cut this one, beta. Sphenoid written over there. Now, CT scan is best radiological investigation for sinuses, and I'm sure you already know it now, beta. CT scan is the best radiological investigation. Beta. Please see. Let me show you CT scan, and you can really comment yourself also, beta. Now, please see on the screen, everybody. Now you tell me, beta, I'll mark an arrow and you tell me what is the structure. What is this structure? What is the structure, beta? Inferior turbinate. Okay. Inferior turbinate. What is this area? Inferior meatus. Orbit. Orbit. Maxillary sinus is very nicely visible, beta. You know? This is the ethmoid sinus. Full of air cell. Ethmoid is a single bone between two orbit, beta. This is IT. This is IM. Inferior meatus. This is MT, beta. What is MT? Middle turbinate. Take a picture, beta. Take a picture. Right now, the CT scan sinuses in nose. Okay. Now click a picture. Ask yourself, do you know it, beta? Okay, beta, fine. Okay. So this is very easy to, below the orbit, you see maxillary sinus very nicely, beta. No? Fine. So X-ray, somebody is asking to repeat the X-ray, no problem, beta. Look at screen, everybody. If any X-ray is showing maxillary sinus very clearly, you mark water view, be it open mouth or closed mouth. If the X-ray is not showing maxillary very clearly, you please mark cardable view for that question, beta. This is what I'm saying. Okay, maxillary sinus, the best sinus visible on water view is maxillary sinus, beta. Water view is the best view overall also. Water view shows all sinuses except the posterior ethmoid. Water views can be done with open mouth to see the sphenoid sinus, beta. Okay, fine. So sphenoid sinus. So next one, beta. Next one is the treatment, beta. We have done the endoscopy, X-ray, CT scan, beta. We've done the endoscopy, X-ray, CT scan. Now, how to proceed with that? Treatment is antibiotic, and why decongestant? For edema. For edema. You know, main thing is congestion. For edema of what beta? Anybody dash? Can anybody tell me? For edema of what beta? For edema of what? Anybody? Which area beta? I'll be very happy to answer this intelligent question beta. It's a high level question. For edema, which area beta? For edema of which area? Which area beta? Which area? Which area? What is the main pathology area in sinusitis? Yes, very good. Very good. Now you're reading that answer. Very good. OMC area. That's the main problem. Very good. Not the whole. We are mainly, the main culprit is what? OMC blockage. Okay. Edema OMC area. Fine. If it fails, then we do surgery. What is the name of surgery? FES. FES full form should be known to you. FES is functional endoscopic sinus surgery. FES is functional endoscopic sinus surgery. FES is functional endoscopic sinus surgery. Complication of sinusitis. If you don't get surgery done, orbital infection is most common with ethmoid sinusitis. I think this is common sense, beta. Ethmoid is between the two orbit, so the highest chance of eye infection. Orbital infection is most common with ethmoid sinusitis. Please see, beta. Orbital infection is most common with ethmoid sinusitis. Very easy to go. Ethmoid sinusitis. Very good. Number 2, beta. Number 2 is mucocele. Mucocele matlab right now put narrow large sinus. Anybody, what is laryngocele? Large what beta? What is laryngocele? Yesterday class beta. Large what? Anybody? Large what? Large saccule. Very good beta. Large saccule is laryngocele. Large sinus is mucocele. It is sinus expansion due to mucus collection. Sinus became bigger in size, beta. Most common in frontal sinus. Mucocele are mostly seen in which sinus? Frontal sinus. The sinus became bigger in size, beta. Most commonly, it is seen in frontal sinus, beta. Please see. Because the mucus cannot go down, beta. Please see. This is your normal side, beta. This is your mucocele side. Huh? What happened, beta? There's so much of mucus inside the sinus. Because the drainage is blocked, that pure pressure of mucus has made the sinus size bigger actually. So sinus expansion due to mucus collection, that is actually called mucocele, and mucocele are most common in frontal sinus. The third one is a 5-star question of your paper and NEET PG paper also. Osteomyelitis of frontal bone. It lead to, look at me, sinusitis is sinus infection, but by chance this bone got infected. Bone contain the sinus. Sinus get infected, sinusitis, but if the bone haddi got infected, osteomyelitis. It lead to subperiosteal frontal bone abscess. Frontal bone problem abscess. It is called Pott's puffy tumor. This is the MCQ. Pott's puffy tumor. Pott's puffy tumor. Pott's puffy tumor. MCQ. Star. It's not a tumor. It's not a tumor, beta. Basically, it's a frontal bone infection. Okay, Pott's puffy tumor, beta. Chief complaint: painful, red forehead swelling. Painful red forehead swelling, beta. Pott's puffy tumor is painful red forehead swelling. Painful red forehead swelling. Painful red forehead swelling. Okay, which is fine. Painful red forehead swelling. It's not a tumor, beta. But tumor naam, that's why it's an important question, because they can confuse you. Pott's puffy tumor is not a tumor, beta. So let's divide by 3 complications. Orbital infection are most common in ethmoid sinusitis. Mucocele with large sinus, expansion of sinus more common in frontal sinus. And subperiosteal frontal bone abscess is called Pott's puffy tumor, beta. Pott's puffy tumor. It's not a tumor. It presents as painful red forehead swelling. Okay. Okay, fine. Now, Pott's puffy tumor is a very mandatory to be remembered. Now, sinuses appear in this sequence radiologically. Right, MESF, put an arrow. MESF, 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 MESF. First to develop is M and last to develop is F. MESF is MCI question. Now, some point to remember, M and E are present at birth. They develop during pregnancy. Then number two, the E is most developed at birth. E is most developed at birth, beta. Sphenoid appear at 4 years of age and frontal at 6 years of age. MESF na, MESF, because sphenoid at 4 years and frontal at the 6 years of age. Beta. Okay, for instance. Okay. Sphenoid at 4 years, frontal at 6 years. Beta. Okay. Now look at Vida. F is the sixth alphabet. Beta. We'll finish the class at 5 o'clock. Don't worry about it. I know you have to have a break before surgery. Don't worry. Please see, beta. Learn that. There is a question over there. MESF is the sequence, beta. Maxillary, ethmoid, sphenoid, frontal. M and E are present at birth. Then number two, E is most developed at birth. Sphenoid at 4 year, frontal at 6 year. Beta. Please see, F is sixth alphabet. Beta. A, B, C, D, E, F. F is sixth alphabet. F for 6. Sphenoid before that 4 years. Beta. This is MCQ. Okay. Now, some general points of sinuses. Most common benign type of sinus is osteoma. If you know sinuses are bony cavities, better. What is the most common benign tumor of bone? Osteoma. Same here also osteoma. But osteoma are most common in frontal sinus. Osteoma are most common in frontal sinus. Better. Most common fungus to cause sinusitis is Aspergillus fumigatus. Better. Fumigatus. Okay. Most common site of aspergilloma or fungal ball is maxillary sinus. Most common site of aspergilloma or fungal ball is the maxillary sinus. Okay. Now draw a line, beta. Just draw a line. In frontal sinus, we get the mucoceles and osteoma most common. In medicines, we get the aspergilloma and malignancy most commonly. So most common sinus develop malignancy and aspergilloma is maxillary sinus, and most common sinus develop mucocele and osteoma is frontal sinus. Is frontal sinus. Am I clear? Fine. Okay. Somebody said audio file for this thing. Let me say the audio file beta. The first for the complication. Complication of sinusitis. Orbital infection is most common with ethmoid sinusitis. Number two, mucocele, the expansion of sinus is most common in the frontal sinus. And Pott's puffy tumor is the other name of subperiosteal frontal bone abscess, which is a complication of frontal sinusitis. In general, sinuses appear in this sequence, MESF. Maxillary and ethmoid are present at birth. Ethmoid is most developed at birth, sphenoid at 4 years, and the frontal at 6 years of age. And osteoma and mucocele are most common in frontal sinus, and malignancy and aspergilloma or fungal ball are most common in the maxillary sinus. Okay. So that's the end of the day today. I don't want to keep you, blocked for more time. I know तुम्हारा class भी अगला. Take a break, and you have a test today. Every test we cannot do fully. I know that the full syllabus cannot be done, but whatever you do it concrete. Like at least few chapters of that subject should be finished if possible, because you have the time. You have 3 hour, 4 hour, 2 hour, 2.5 hour, whatever time you have. At least finish a concrete part of that subject before you go for the test. It doesn't matter how much you score, believe me, but when you finish the test, review the test. Did you do any silly mistake? Think beyond notes. You're practicing or not? Are you overthinking, changing answer? Learn from that mistake. And whichever question you had read the topic, but still you could not recall that, open up the topic and see that. Learn from this test. Don't assess from this test. We are not here to assess you, beta. We are here to assist you. These tests are not for your assessment. These tests are for your assistance to learn the procedure of attempting the paper in a correct manner. So every day to feel negative and low, mere number nahi aa rahe, mera kuch nahi hona, and all that, that's not a right idea. If we did in the morning also, we will have a version 2 in which we learn from our mistakes and try to do well. Okay, fine. Thank you very much, guys. And the end of day 2, take a break, take some tea, coffee, wash your face, and get ready to learn the next one, actually. Thank you very much. Anyone any question, you can put in the group if you have any question. Why coronary artery surgery is 1 year late, beta? Because the reason is that child has to grow to, undergo that surgery. You have to put endoscope, drill system, everything in the nose. That's why 1 year he has to be in tracheostomy, beta. Motivation is doglapan, beta. Don't trust motivation. Motivation is a big fraud, actually. Believe me, it's the biggest fraud, actually, is motivation. YouTube has really done that in a very good manner. Nobody has changed themselves after seeing the YouTube. There's no need to change. I'm saying you are wonderful people. You should be naughty people. You should be doing something like that also. You should be very much, but for some time, make the monkey sleep within you. For some time, please behave in a different way. Please launch a limited time different version of yourself. On the exam day at 5 p.m., please be a monkey again. There's no need to change. Motivation means you need to change to become a different person. You are a wonderful person. Stay like this forever. We came like a monkey. Let's die like a monkey. In between, behave like a pet dog. Okay, when we are actually monkeys, actually pretending to be humans. Let me tell you my understanding. Males, I'm not even female, but we are monkeys pretending to be humans. But to create this life worthwhile, we have to launch a different time version of, limited time version of yourself. That's all. But with age, you'll become mature. Yes, that will be not a change, that's maturity. But that is from your experiences, which you will adopt on your own. That doesn't need any motivation. So look within. This exam is very important for my life. This exam will give meaning to my life. This exam will give meaning to last 6 years of my life. This exam will give some happiness to my parent, my family, my siblings. So I don't know hota ki nahi hota, mujhe nahi pata, lekin I can always put my best foot forward. So from today onward, हम ये नहीं बोलेंगे, हम पास होके दिखाएंगे, हम ये बोलेंगे, हम अपनी पूरी मेहनत करके दिखाएंगे, ऊपर वाला करे, मेहनत सफल होगी. That's all about it. Okay, thank you very much. Bye.
white on CT. Stones, they appear white on CT if they have calcium, right? So bones will appear white. So if you see bones is white, it is a CT scan. Right. So wonderful. Good evening to the lovely, great doctors of this country. I hope you are keeping yourself safe and sound, and you are enjoying your ENT classes as well. Right. So what we discussed yesterday in surgery, we started with pediatric surgery and we talked from face, the cleft lip and palate, the cyst in the neck, the thyroglossal cyst, the branchial cyst, and the cystic hygromas, esophageal atresia and dysphageal lusoria, in the epigastrium, duodenal atresia, annular pancreas, and hypertrophic pyloric stenosis. Right hypochondrium, we talked about biliary atresia and choledochal cyst. Right? So, my dear lovely friends, there is another one story in the right hypochondrium, and that is intussusception. Intussusception is basically, let me just check if everything is sound. Hypochondria, that is intussusception. Intussusception is basically, let me just check. Right, so my dear lovely friends, today India versus Pakistan is going on, the World Cup match at Ahmedabad, and the good news is that Pakistan has been bowled out for 191 in 42.5 overs. Right, so all the cricket lovers, I hope this is another thing which gives you a positive pump as well. Right. So let us talk something about intussusception. Intussusception, as we can see here, beta, this is invagination of some part of intestine into the adjacent part. Why some part of the intestine will go into the adjacent part? Conceptually, if you try to think, whenever some part of the intestine becomes heavy, the peristalsis forces this heavy part of intestine to ride into the adjacent part. Like here, we are able to see some tubular structure in this area, and this tubular structure here looks to be appendix. Can you appreciate this tubular structure here? So this is appendix, and if this is appendix, that means this is cecum and this is ileum. That means ileum is going into the cecum, so we call it as ileocecal or ileocolic intussusception. This is actually the commonest type of intussusception. I repeat the concept in Hindi also. बेटा जब भी इंटेस्टाइन का कोई भी हिस्सा भारी हो जाएगा तो जो पेरिस्टाल्सिस है वो इस भारी हिस्से को बाजू वाली इंटेस्टाइन के अंदर धकेल देगी और इसको अपन इंटुससेप्शन बोलते हैं. The commonest type of intussusception is ileocolic and it is commonly seen at around 6 months of age. Why at around 6 months? Because first 6 months of life, the baby is on exclusive mother's milk. At 6 months of age, when top feeding is given to the baby, जब बच्चे को ऊपर का खाना दिया जाता है या ऊपर का कुछ दूध दिया जाता है, because of this top feed, the baby's intestine may develop infections. And if infection occur, then there are lymphoid follicles in the wall of the terminal ileum, which are called as Pierce patches. These lymphoid follicles, Pierce patches, they engulf the bacteria and they swell up, which we call as hypertrophy of Pierce patches in the wall of terminal ileum. That means the terminal ileum becomes heavy and peristalsis forces this terminal ileum to go into the cecum. That is why ileocolic intussusception is the commonest intussusception. Right. Though the reason we say it is idiopathic, it can be anything, but yes, at 6 months we see this hypertrophy of Pierce patches. It may even be associated with rotavirus vaccine or maybe rotavirus infections. Even Meckel's diverticulum, which we'll be reading today in the later part, Meckel's diverticula is a diverticula hanging from the intestine. So that part of the intestine which is having this diverticula will become heavy and peristalsis will force this heavy part of intestine to ride into the adjacent part. But in case of adults, it is not this hypertrophy of Pierce patches or Meckel's diverticula or rotavirus. In adults, generally, as we grow old, we find that many people, they develop polyps inside the colon. And if there are polyps in the colon, that will make that part of the colon heavy. And peristalsis will force the heavy part of colon to ride into the adjacent part. That is why, beta G, in case of adults, it is not the ileocecal, but it is the colocolic intussusception which is more common. Right? And the reason is polyps in the colon. Now, if we try to take a look, what is intussusception all about? Suppose beta ileocolic intussusception we are talking about, then this purple color story what you are seeing, this is the inner tube or the entering tube. We call this as intussusceptum. This inner tube is intussusceptum. The outer tube or the receiving tube, the brown color tube, this is the receiving tube. So this is intussuscipiens, recipients, intussuscipiens. So this is intussusceptum. Outer tube is intussuscipiens. This middle area, which is having both inner tube as well as the outer tube. So this segment is middle tube. The point of entry of intussusception is the neck, and the terminal part of the inner tube, this is the apex of intussusception. Right? Now, if suppose we say ileocolic intussusception at 6 months of age, how these 6 months old babies can present to us? Look at the screen, beta. Herein, we should know that ileum, the terminal ileum would be in the right iliac fossa, and here should be the cecum. That means this ileocecal region is located in the right iliac fossa. Now what we are saying is, because of infections in the intestine, the wall of the terminal ileum is going to become heavy. And if this part becomes heavy, the peristalsis can force this heavy part of intestine to ride into the adjacent part. And then this whole area, this will form a thick mass. The peristalsis is moving in this direction. So this peristalsis will force that mass to move sometimes into the right hypochondrial area. And March 24, beta, where are you in March 24? Very good, hospital. And you are wearing that lovely white coat and the stethoscope, right? Now, majority of these babies, you will find a sausage type of lump, not in the right iliac, but actually in the right hypochondrial area, because peristalsis has forced this jumbled mass to move upwards into the right hypochondrium. Sometimes, beta, this sausage lump may even move in the left paraumbilical region, and you can find a lump in the left paraumbilical region as well. A common story is the concavity of the lump. The concavity of the lump that is facing the umbilicus, right? Because the inner tube has gone into the outer tube, there is a possibility of injury by the inner tube here. So this may bleed, and this blood will travel in the colon, get mixed with mucus, and this baby may even present with something like this. Just like the jam on the bread. Bread jam होता है ना बेटा, jam लगाते bread के ऊपर. तो this is what we call as red currant jelly stools. Blood and mucus in stools. When we do the clinical examination in these babies, many a times what you will find, because the ileocecal region has moved upwards. So on clinical examination, when you palpate this area, you find an emptiness in the right iliac fossa. And this is what we call a sign of dance, as if the ileocecal region is dancing inside the abdomen. जब हम पेट को एग्जामिन करते ना बेटा, तो राइट आइलिक फोसा में ऐसा लगता है कि एक अजीब सा खालीपन महसूस हो रहा है. शायद इस इलाके में पहले कोई रहा करता था, लेकिन अब अपना घर छोड़ के कहीं और चला गया है. इसको अपन एम्प्टीनेस, जो एक खालीपन है, इसको साइन ऑफ डांस बोलते हैं. इफ you do the digital rectal examination, that means if you put your finger into the rectum of this baby, when you take your finger out, obviously the gloved finger, you will find blood staining on the finger, beta. So these are 4 keywords for intussusception, and intussusception is a hot area for the examiners. Okay, let us try to summarize the 4 key words. A sausage lump in the right hypochondrium, red currant jelly stools, empty right iliac fossa or sign of dance, and examiner's finger stained with blood. So in 6-month-old baby, something like this can be intussusception. Whenever a patient presents to us with abdominal mass or abdominal lump, you know, beta, what is the first investigation? Very good. Ultrasound of the abdomen. When we do ultrasound in these babies, we find a donut sign. Donut is because there is inner tube and surrounded by the outer tube. We can also call it as target sign, beta. When you are playing the game of dart, you know, there is a board like thing which you hang on the wall, and there are circles in that. So the inner circle, the outer circle, right? Like the Connaught Place in Delhi, there is an inner circle and an outer circle all round. So that is what is a donut sign or a target sign. When we take a X-ray in intussusception babies, because of this sharp edge here, we might find a gas shadow in this area, and this is called as meniscus sign or crescent sign. However, a hot MCQ with a potential in December 23 is what we find on barium enema. something like this. Look at the screen, beta. This can be a hot image based question. If you are giving the contrast from below, the contrast is going into the colon like this, and here you can see the holding of the contrast in the cecal area. Actually, the ileum would be lying here and the cecum would be lying here. But in intussusception, the ileum has gone here and the cecum is here. Okay. So now, beta, when you are giving the contrast from below, if suppose the ileum is tightly fitted within the cecum, right? Look here. If suppose I say my right hand is the ileum and my left hand is the cecum. If the ileum is tightly fitted inside the cecum, now whatever contrast is going in the cecum, the contrast will not be able to flow down. So nothing below this will be visible, and this appears like a claw. But if suppose, beta, the ileum is not tightly fitted in the cecum, there is some gap between the ileum and the cecum. So now what will happen? Whatever contrast is coming in the cecum, that will flow around the ileum and form rings around the ileum. Just like that ball pen, that khatke wala ball pen, it has got a spring around the refill, right? So coils in that spring. So that is called as a coiled spring sign. So in intussusception, beta, on barium enema, we can find two signs. Either it's a claw sign or it's a coiled spring sign. Claw is when the ileum is tightly fitted, so no contrast is flowing down from the cecum. And coiled spring is when the ileum is not tightly fitted inside. The contrast is forming rings around the ileum. That is a coiled spring sign. However, best investigation for the intestines is CECT of the abdomen. Now, what you, the great doctor of this country, is supposed to do in intussusception, our aim is whatever tube has gone inside, that should come out. That means if you try to give something with pressure in the colon from below, from the anus, if you give something with pressure, that pressure may force the inner tube to move out. So one option what we can do, beta, is we can take this baby on the petrol pump, right? And at the petrol pump, you must have seen how the air is put in the tires, right? So that pipe, air pipe, you can put that air pipe into the anal canal of the baby and then release air with pressure. So air is coming with pressure in the colon. That may force the inner tube to move out. This is hydrostatic reduction. We can use air, saline, barium, anything with pressure from the anal canal which can force the ileum to move out of the cecum. Obviously not at the petrol pump, beta, but we can do this inside the operation theatre. And if by chance, suppose this hydrostatic reduction is not able to reduce the intussusception, then definitely we have to do the operation. And when you are doing the operation, beta, one precaution what we have to take, like in this image, suppose I say that this is the inner tube and this is the outer tube, and this area is the intussusception area. Now you can hold the outer tube, assistant holds the inner tube, and you both can play a tug of war. But we never try to pull in intussusception, beta, because this is a edematous friable area. If you try to pull the inner tube may rupture. So we never pull in intussusception, but a better option is hold the outer tube and gently milk the inner tube out from the outer tube. This gentle milking, that means we are just trying to push the inner tube out. So in intussusception, in operative reduction, never pull, always push. If suppose you get the same image in the exam and the examiner marks an arrow in this area and tells you, doctor, this area is gangrenous, what should be the treatment? So we all know, beta, lovely. If this area is gangrenous, then we cannot keep this inside. That means we'll have to chop this portion of the ileum and then join whatever is remaining. So resection and anastomosis, that has to be done. This image, what you are seeing, beta, this is how hydrostatic reduction is successful in intussusception. Like in this image, if you see, you are giving the contrast from below, and the contrast will be going into the colon maybe like this, and with pressure the contrast is going here. Now when there is a pressure, this pressure will force the inner tube to move outwards. That is how the intussusception will reduce with hydrostatic reduction, which you can see here in this picture, how the inner tube has moved out from the outer tube. So you can compare that how hydrostatic reduction helps in reducing the intussusception. That is why hydrostatic reduction remains the treatment of choice out of air, saline, barium. Air causes minimal injury, so we prefer using air enemas for reducing the intussusception. Right, let's see what all is written here. Intussusception is basically invagination or telescoping of one part of intestine into the adjacent part. There is inner tube, entering tube or intussusceptum. There's a middle tube. There's an outer tube, receiving tube or intussuscipiens. The point of entry is the neck, and the terminal portion of the inner tube is the apex of intussusception. Most commonly, we find ileocolic intussusception at around 6 months of age, though the range is 5 to 10 months. Most common cause of intussusception is not known, idiopathic, but we commonly find hypertrophy of PS patches. It may even be associated with rota virus infection and even rotavirus vaccine. Even Meckel's diverticulum may cause this intussusception. Meckel's diverticulum may cause this intussusception. I'll just remove myself for better visibility. Yeah, so here you can see. However, in case of adults, the commonest type of intussusception is colocolic, and this is because of polyps in the colon beta. In case of adults, we do not expect the rotavirus or Pierce patches or Meckel's diverticular story, so it is the polyps in the colon. Right. Now, how these babies will present to you beta in March 24? They'll present to you in emergency, maybe with excessive cry and discomfort. And the 4 important keywords what we are talking about beta, these are used commonly by the MCQ people. That means this becomes a hot area for December 23. However, the hottest area for December 23 would be the image of barium enema. That is a claw sign. Okay. So instead of mentioning December 23 here, we'll mention this in the claw sign. So we just mark this that this is a hot area. There is a sausage lump in the right hypochondrium or sometimes in the left para-umbilical region. But a common feature for these lumps or masses, the concavity of the lump is directed towards the umbilicus. Baby presenting with blood and mucus in stool, this is called as red currant jelly stools. Empty right iliac fossa is called as sign of dance. And on digital rectal examination, this DRE beta, this is digital rectal examination or per rectal examination, the examiner's finger is stained with blood. Any patient who is presenting with a mass or lump, generally any patient who is presenting with a mass or a lump, the first investigation should always be ultrasound. And ultrasound shows us donut sign, which can also be written as target sign. On X-ray, we see a crescent sign or a meniscus sign. On barium enema, we see a claw sign. we can also see a coiled spring sign. So this becomes the hottest area for December 23 exam in intussusception, a image-based question of claw sign, right? So I hope beta you can have a look at this claw once again, and I hope all of you will be able to identify how this claw looks like, right? Okay. Even in this image, if you see, this is also looking like a claw. Can you appreciate this area? This is also looking like a claw. Okay. Best investigation for intussusception would be CECT of the abdomen. And the treatment for intussusception, generally treatment of choice is hydrostatic reduction, where we prefer using air enemas. Air causes minimal injury. So air enema is the treatment of choice. We can use saline, we can use barium enemas as well to reduce the intussusception. If this fails, then we have to do operative reduction, where we never pull, we always push. That is gentle milking of the outer tube to reduce the inner tube. And if the story is gangrenous, then we do resection and end-to-end anastomosis. Right. Okay. Fine, beta. So now from the right hypochondria, we move into the lumbar region. And just for a small information, you have got revision videos of surgery in the application itself. So what I'll be doing is I've already done the revision without the workbook with the eyes closed. So whenever you are a bit free, suppose you are in the washroom or you're just moving around, maybe you are going for a walk or something for 10 minutes, 15 minutes, you can just plug in the earphones and you can just switch on that revision video, okay? So that during these surgery classes only, instead of going through extensive learning maybe for 4 hours or 5 hours, I would suggest that because these are small sessions which we are having, so you can just go through the workbook first, maybe 45 minutes to 1 hour, try to understand the concepts, and then just plug in the earphones whenever you are free and just try to revise it as many times as possible. For pediatric surgery, I have also taken the revision along with the workbook. And for adult surgery, I'll be doing it with you during the course of our classes with the workbook as well, right? So that when you are watching it thoroughly on a table and chair, then you are having the images also screened in the workbook for revision, right? And the questions which are there in the workbook, they have also their videos are available, right? Though we'll be trying to discuss the different questions again, okay? Fine. Now we move into the lumbar region, and lumbar region is the region for the kidneys. So beta, how many kidneys you have? Wonderful, 2 kidneys. But if somebody has done bad deeds in his previous life, then God may give only 1 kidney, right? That is absent kidney. Another story is ectopic kidney. Here in beta, we should know that during intrauterine life, the kidneys and the testis, they both develop in the retroperitoneal area in the pelvis. The difference is that the kidneys, they ascend upwards like this, while the testis, they descend downwards like this into the scrotum. So if we focus on the kidneys only, if during intrauterine life, 1 kidney has normally ascended upwards, so it has reached into the normal location. But the other kidney, suppose the other kidney is lazy, and this kidney says, no, I am comfortable in the pelvic area only, don't take me anywhere. So this kidney may not move upwards. That means this kidney will be arrested in the pelvis, in the retroperitoneum only. And this will be called as ectopic kidney. Usually, left-sided anomalies are more common in the urinary system. So, left kidneys are usually ectopic. There is another story, beta, that is a polycystic kidney disease. Now, herein, if you see, there are two pathologies what we are discussing here, beta. One is a polycystic kidney disease and another is a horseshoe kidney. In polycystic, beta, there are multiple cysts which are located in the kidneys. And usually, beta, this pathology is bilateral story. We'll be discussing the details, but just for your understanding, this is polycystic kidney. And if suppose the two kidneys, they fuse in the midline, especially if the lower poles of the two kidneys fuse in the midline, then this appearance what you are seeing here, this looks like a horseshoe. So this is a horseshoe kidney. Horseshoe is something like this. As you can see here, this is what is a horseshoe. वो घोड़े के पैर में नाल ठोकते ना, so it is something like this. That means horseshoe kidney would look something like this. Okay. Nowadays, what the examiners are doing here, they are giving you a image either of polycystic kidney or of horseshoe kidney, and they are asking you to identify what is the pathology. They are also going a step ahead. They are asking whether it's a CT of horseshoe or MRI of horseshoe, CT of polycystic or MRI of polycystic. So beta, one thing which we all understand, that X-ray and CT scan are one and the same things as far as the density and the interpretation is concerned. So calcium appears white on CT. Stones, they appear white on CT if they have calcium, right? So bones will appear white. So if you see bones is white, it is a CT scan. But bones appear black on MRI. So beta, if you look at this particular image, now here you can identify that this vertebra is looking black. So this would be a MRI and this is a polycystic kidney disease. So the earlier image what we saw was CT of horseshoe kidney. This is MRI of polycystic kidney disease. Nowadays the MCQs are playing around these images. Okay. Earlier they used to ask some classical appearances. Like in polycystic kidney disease, we find spider leg appearance. In horseshoe kidney, we find a flower vase appearance. But these questions were common before 2020. Now the examiner has moved towards the images of these pathologies, right? So I hope, beta, that all of you will be able to identify whether it's a polycystic or horseshoe and whether it's a CT or MR, right? Okay. So now let's take a look about these polycystic kidneys. Herein, this polycystic kidney disease can be of two types, beta, congenital and infantile variety. Now, congenital variety is quite common. Infantile is very rare. Congenital is autosomal dominant. Infantile is autosomal recessive. Congenital usually presents in adult life. So, though the story is congenital, but by the time the cyst enlarges and causes any problem to the patient is already more than 30 years of age. So generally, we also call this congenital variety as adult polycystic kidney disease, right? Because infantile is very rare and it is associated with a very high mortality also. So March 24, you may not be finding infantile polycystic kidney. So December 23, you may not be getting a question related to infantile polycystic, but yes, you may get a question from congenital or adult polycystic kidney disease. This is autosomal dominant, bilateral, and it may be associated with cyst in other organs. For example, you may even find cyst inside the liver. You may even find cyst in the pancreas, or maybe in the spleen, or maybe in the ovaries. Sometimes these polycystic kidney disease may be associated with berry aneurysm of circle of Willis and sometimes even mitral valve prolapse. How these polycystic kidneys present to us: March 24, 35-40-year-old lady presenting in the OPD, hypertension seen in 75% of patients. Because of these cysts, the kidneys may enlarge and this may lead to swelling. Swelling will cause stretching of the renal capsule. So you may find swelling and pain. Pain is because of stretching of the renal capsule. Swelling and pain in both the lumbar region. Sometimes these cysts may cause injury and this may cause bleeding, and this blood may trickle down in urine, that is hematuria. And sometimes beta, when these cysts become too big in size, they are definitely going to compress the nephrons. And nephrons, we all know, they are supposed to filter, right? So the nephrons are getting compressed and it is a bilateral story. So nephrons may not be able to filter things out. That means whatever end products of metabolism in the body are urea, creatinine type of people, when they're going through this filter or the kidneys, because the nephrons are compressed, they may not come down, they may not be filtered, and they'll continue keep on moving in the blood, uremia. And a stage may come when both the kidneys are going to fail because the nephrons are permanently damaged. Right, so these can be the presentations. How we approach these 35-40-year-old patients. If the patient has come to us, suppose with a swelling, then we all know better from yesterday's session, any patient who is presenting with swelling in the abdomen or a mass in the abdomen, the first investigation will always be lovely. So let's have a big round of applause for all of you. So first investigation will be ultrasound. And ultrasound will show you enlargement of both the kidneys, plus there are multiple cysts in both the kidneys. Then to see whether the kidneys are working or not, you can do a contrast study, IVP or IVU. Nowadays, better than IVP, IVUs are CECTs. So when we are doing the contrast study, whether IVU or CT contrast, that is CECT, there is a possibility beta, because the nephrons are compressed, the calyceal system is compressed. The compressed calyceal system may look thinned out, something like this. And this is what we call as spider leg appearance. The pelvis may be okay, the ureters are okay here, but because of multiple cysts inside, there is compression of the calyces. That is why the calyces are thinned out here. And these are called as spider leg appearance. Can you make out? This is the spider leg appearance. Right. In the treatment for polycystic kidney beta, because there are multiple cysts and there is a pressure on the nephrons, initially we can try doing something wherein we try to remove the capsule over the cyst. Suppose I say that this is the cyst and around this is some capsule. So we just try to remove the capsule to cause some decompression in the kidneys. That is called as de-roofing of the cyst. But this does not help, because then what will happen, if you just remove the capsule around the cyst, then the cyst will get more space and the cyst will further enlarge. And a stage will come when the nephrons are going to get permanently damaged. And since it is a story involving both the kidneys beta, if both the kidneys fail, then we are left with no option but to put a new kidney. That is, we have to do a kidney transplant. So whenever we are doing a kidney transplant beta, here you see the transplanted kidney is not placed in the lumbar region. The transplanted kidney is placed in the right iliac fossa. This type of transplant, when we are putting the transplanted organ in some other anatomical location, is called as heterotopic transplant. I repeat this beta. When you are placing a transplanted organ not in the normal location but in some other location, this is heterotopic transplant. While when we are doing liver transplants beta, the liver is placed in the same anatomical location. Transplanted liver is placed in the same anatomical location. That is called as orthotopic transplant. So liver transplants usually orthotopic, same anatomical location, while kidney transplants, they are heterotopic when kidney is placed in a different anatomical location. When we are doing kidney transplant, then which kidney should be preferred from the donor? If you carefully look at the screen, beta, this is important both in anatomy as well in surgery. We are going to have this diagram at multiple places, right? If you look at your abdominal aorta and inferior vena cava is located slightly onto the right side. So right renal vein is short and the left renal vein is long. Whenever we are doing kidney transplants, beta, a renal vein thrombosis in the recipient is a common complication. So we are very careful about the renal vein. If you have got an option, beta, a small renal vein and a long renal vein, then which renal vein will give less tension in the anastomosis in the recipient? Perfect. So as you said, if we are using a long renal vein, then tension in the anastomosis will be less. Chances of leakage of renal vein anastomosis in the recipient will be less. So which kidney will you prefer from the donor, beta, if you have both the options? Very good. So we prefer using the left kidney from the donor. Anatomy, ma'am, has told us that because the left renal vein is long, the left gonadal vein and the left suprarenal vein, they open in the left renal vein, while right-sided gonadal vein is opening directly in the inferior vena cava and right suprarenal vein is also opening directly in the inferior vena cava, as you can see here. Right. Let me zoom it a bit. Right. So I hope this you will remember on 14 December as well as in your clinical practice. Left renal vein is long, so it receives the left gonadal vein, that means the testicular or the ovarian vein on the left side, and the left suprarenal vein. But right side gonadal vein is opening directly in the inferior vena cava and right side suprarenal vein is also opening directly in the inferior vena cava. Right. So let us see what all is written here before we move further. Few problems in the lumbar region. Absent kidney is due to renal agenesis. Ectopic kidney is when the kidney failed to ascend upwards, most commonly on the left side, generally located in the pelvis in the retroperitoneum. Polycystic kidney disease, beta G, it can be congenital or infantile. Congenital is also called as adult. Adult polycystic kidney disease, it is autosomal dominant. Infantile is autosomal recessive. It is rare and it is associated with high mortality. The congenital or adult polycystic kidney disease, this is bilateral, associated with cysts in other organs, most commonly liver, spleen, pancreas and ovaries. It is associated with Berry aneurysm of circle of Willis. It may be associated with mitral valve prolapse as well. This congenital or adult polycystic kidney disease presents after 30 years of age. That is why we call it as adult. Most commonly we find hypertension in 75%. Patient may present with swelling and pain in both the lumbar region. There may be hematuria and uremia story. How to approach these patients in March 24, beta? First investigation, because there was swelling in both the lumbar region, is ultrasound abdomen. Best investigation would be CCT of the abdomen. When we are doing a IVU or IVP or a CCT, on the contrast study, in polycystic, we find a spider leg appearance. Spider leg appearance. This is another IVP image here, which is showing thinning of the pelvic-calyceal system. Can you see how these calyces have thinned out? And this thinning of the calyces is what we are calling as spider leg appearance. And it is seen on both the sides. May not be that classical thinning what we drew here in this image, right? But yeah, there may be thinning of the calyces. Right. In the treatment for polycystic kidney disease, initially we can try doing a de-roofing of the cyst. But eventually we'll end up in doing a kidney transplant. The transplanted kidney is placed in the iliac fossa, and usually left kidney is preferred from the donor due to long left renal vein. When we are doing transplants, if the transplanted organ is placed in the same anatomical location, we call it as orthotopic, like for liver. But when we are keeping the transplanted organ in a different anatomical location, then we call it as heterotopic, like for kidney. Right. Since we talked something about IVU and IVP, so beta, though you have had your radiology classes, and I'm pretty confident that your radiology sir, who is one of the top 10 radiologists, I should say, especially when it comes to MRI, and especially MRI of musculoskeletal system, he would be amongst the top 10 radiologists of this country. And he would have given you the nice explanations about what are the various contrast studies. Right. So herein, let me also try to see if I am able to give you some idea about the different contrast studies used in the urinary tract. So beta G, let's have a look at this urinary tract. This is the upper urinary tract. That means the kidneys and the ureters. Okay, let me draw the ureter properly here. Suppose this is the ureter here, right? So once again, I would like to say, beta, this is the upper urinary tract, while this bladder and urethra, this is the lower urinary tract. Okay. If we have to study the upper urinary tract, kidney and the ureter with a contrast study, the best contrast study what we can use is a IVP or IVU. Look at me on the screen, beta. This is intravenous pyelography or intravenous urography. That means you are going to give the contrast in the vein. And this contrast will be traveling in the circulation. And through the circulation, the contrast will be reaching onto the kidney. If the kidney is working, if the nephrons are working nicely, this contrast will be getting filtered through the nephrons, and via their collecting ducts, this contrast will be coming in the minor calyces, and from there into the major calyces, into the renal pelvis, and then down into the ureter. And when you are taking the X-ray, you can see the pelvic calyceal system and the ureters nicely. So IVP or IVU, just giving the contrast in the vein and taking the X-rays of kidney, ureter, bladder will show you the nice contrast in the kidneys and the ureters. If suppose beta we are not able to do the IVP or IVU, maybe the patient has some allergic reaction to the contrast, so we cannot give the contrast in the vein. In such cases, if we have to see this kidney and ureter, a simple thing what we can do is we can pass a endoscope into the bladder. Suppose we are passing a endoscope into the bladder like this. Now through the side channel of this endoscope, we can pass a catheter through the endoscope. Look at the screen, beta. I am trying to pass a catheter through the endoscope, and I will take this catheter for this much distance in the ureter. And now I will push the contrast here. When I push the contrast in the catheter, what will happen? This contrast will be traveling from the ureter up towards the kidney, and you take the X-rays. When you are introducing the contrast from below and the contrast is traveling in upward direction like this, this is called as retrograde pyelography. Again, beta, we have put a endoscope in the bladder, catheter in the ureter only for this much distance, and you are introducing the contrast like this and taking the X-ray. So this is retrograde pyelography. If I say there is some traffic jam in the urethra, and if there is a traffic jam here, You are not able to pass the endoscope into the bladder, and now you want to study the kidney and the ureter. Another option which we have is, we can, under ultrasound or CT guidance beta, you can make a puncture into the pelvic calyceal system from the percutaneous route. You make a puncture into the pelvic calyceal system here, right? Put a catheter into this area and now start pushing the contrast from this catheter. The contrast will be traveling from above downwards and you take the X-ray. This type of procedure where you are pushing the contrast from above and taking the X-ray, this is called as antegrade pylography, right? So beta G, for upper urinary tract, kidney and ureter, the best contrast study would be IVP or IVU. If we cannot do IVP, IVU, first we try with a minimal invasive procedure. That is, we try to pass an endoscope in the bladder and a catheter in the ureter, and then we push the contrast from below and take the X-ray. This is retrograde pylography. If by chance we are not able to pass the catheter from below, then we try to pass a catheter from above and then push the contrast, take the X-ray. This is antegrade pylography. IVP, IVU, retrograde pylography, antegrade pylography. These are for the upper urinary tract. If we have to study the lower urinary tract beta, what lower urinary tract, that is for bladder and the urethra. If we have to study the bladder with a contrast study, there is no need to give a contrast in the vein. You can simply pass a Foley's catheter beta. You can simply put a Foley's catheter from below. Suppose we pass a Foley's catheter into the bladder from below and we push the contrast through this catheter into the bladder. So the contrast has gone into the bladder and now you just take the photograph of the bladder. This is called as cystogram or cystography, right? If you have to study the urethra beta, then for urethra, you don't even have to pass the contrast high up. You just put a catheter here and then introduce the contrast from below upwards. Look at the screen. Introduce the contrast from below upwards and take the X-ray. This is called as retrograde urethrogram, right beta? Yesterday when we were talking about biliary tract, ERCP, endoscopic retrograde cholangiopancreaticography. For upper urinary tract, retrograde pylography. For urethra, retrograde urethrogram, right? So I hope you will remember that for bladder we do a cystogram and for urethra we do a retrograde urethrogram, right? There is one more contrast study to see some specific problems, that is MCU, micturating cystourethrogram or avoiding cystogram. What is micturating beta? At the time of micturation, when the patient is passing urine, we have to take the X-ray at that point of time when the patient is passing urine. And that is because we want to see some pathologies which can be seen only when the bladder is contracting. For example, there is one pathology called as vesicoureteric reflux. Beta, can you just imagine what will be vesicoureteric reflux? Vesico is bladder. When bladder story is moving up into the ureter. Normally, all of us who are watching this session beta, we know that God has given us a wonderful ureteric opening. And this ureteric opening does not allow the bladder story, whatever has come inside the bladder, that does not go up in the ureter because this ureteric opening is working fine. But if suppose this ureteric opening is damaged, now there is a possibility that urine from the bladder may go up into the ureter. and that is what is vesico-ureteric reflux. Vesico-ureteric reflux. Right now when you are watching the session, beta, and if you are not in the washroom, suppose you are in the library, then obviously your bladder will be in a resting state right now. Okay? Even if there is vesico-ureteric reflux, because the bladder is relaxed, urine from the bladder is not going out anywhere. Neither it is going down nor it is going up. But when this patient will go in the washroom and when he tries to contract the bladder, when he has to pass susu, so what will happen? The bladder is going to contract, and when the bladder contracts, then whatever is there inside the bladder, that will try to move out from the bladder. So normally the story will be moving here. But if this ureteric opening is weak, then this bladder story may also move into the ureter. That means, beta, to demonstrate vesico-ureteric reflux, if we are just doing a cystogram, that means we have suppose pushed the contrast via a catheter into the bladder. And if you are taking a photograph when the bladder is relaxed, you will not find that this contrast from the bladder is moving anywhere. If you have to demonstrate vesico-ureteric reflux, you will have to make this bladder contract. When the bladder will contract, then the contrast from the bladder can go up into the ureter if there is a problem with the ureteric opening. That means, just imagine a 5-year-old boy with vesico-ureteric reflux. To demonstrate VUR, we put the contrast inside the bladder. Now take this child in the X-ray room, make him lie on the X-ray table and ask this baby to pass urine on the X-ray table. As soon as the baby starts passing urine on the X-ray table, you start taking his pictures. At that point of time, you can see that the contrast from the bladder will be moving down towards the urethra, plus you will also see that the contrast is moving up in the ureter. That is why to demonstrate vesico-ureteric reflux, it is not the cystogram, but it is the micturating cystourethrogram which will demonstrate this problem. Another story is posterior urethral valves. Now, beta, posterior urethral valves, they are seen only in boys, and these are valves present in the posterior urethra. These valves, if the direction of these valves is something wherein valve means, beta, which allows one direction. If the direction of the valve is something which can allow anything to pass from below upwards, but it will not allow anything to move from above downwards. Nothing is coming from above downwards. So this will be a traffic jam type of story. And we understand, beta, whenever there is a traffic jam, what happens to the proximal people? Very good. So the proximal people gets dilated, stasis, party, stones can form, right? UTI, stones, they can occur. Now, beta, depending whether these valves are complete or incomplete, the patient can present differently. If we have to demonstrate these valves on a contrast study, look at the screen. I repeat, the direction of valve is such that they can allow anything to pass from below upwards, but they will not allow anything to pass from above downwards. If we try to do a retrograde urethrogram, that means we put a catheter in the urethra here, and now we introduce the contrast. Taking the X-ray, the contrast is going down nicely till this area, and the direction of valve is such they will allow anything to pass from below upwards. So you will not be seeing any traffic jam, and you will be able to see the normal urethra. So you will not be able to demonstrate posterior urethral valves if you are doing a retrograde urethrogram. To see the traffic jam here, you will have to allow the contrast to move from bladder towards the urethra. And we know the bladder story will move towards the urethra only when the bladder will contract. So what we do to identify, we first put the contrast in the bladder, maybe by a suprapubic puncture, just puncture in the bladder and push the contrast in the bladder. Now take this baby in the X-ray room or boy in the X-ray room, make him lie on the X-ray table and ask him to pass susu on the X-ray table. When he start passing susu, you start taking pictures. So here you can see when the contrast is moving from above downwards, these valves may not allow the contrast to move down, and you will see the contrast getting holded up in this posterior urethra only. This will demonstrate the traffic jam in the urethra. Again, beta, this is micturating or voiding cystourethrogram, which can demonstrate the posterior urethral valves. Right. Because we talked about the contrast studies of the urethra, if we also talk something about the GI contrast studies, beta, suppose in the GIT we know it extends from mouth to the anus. If we have to look at the esophagus, then suppose you are doing a barium study. Now beta, barium is a liquid solution. So generally a small, very small Bisleri bottle you can imagine, that is the barium solution. We mix this barium solution maybe in normal saline or water, a 2-liter water bottle or a normal saline bottle, and mix the liquid barium in this. And then give this barium and ask the patient to swallow. Suppose patient has swallowed the contrast. Now you tell the patient, okay, have you taken the contrast? And the patient says, yes, I have taken the contrast. Okay, come gentlemen, let's go in the X-ray room. Now when you take the X-ray of this patient, we can understand that as soon as the patient has swallowed the contrast has moved from this area quickly into the stomach. And now when you are taking the X-ray, you will not be seeing the esophagus, but you will be seeing the stomach on the X-ray. If you have to study the esophagus on contrast study, what we have to do is, we give this barium solution to the patient, ask this patient to take this glass or the bottle in the X-ray room, and ask this patient to swallow the contrast in the X-ray room in front of the X-ray machine. And when the patient is swallowing the contrast, now when the patient is swallowing the contrast, you are taking the X-ray. That is how you see the esophagus. That is why to study the esophagus, we call it as barium swallow. Barium swallow, right? We know that food remains inside the stomach for 2 to 3 to 4 hours. So after giving the barium, we expect this barium to remain inside the stomach for maybe half an hour, 1 hour or 2 hours time. So after giving the contrast, if you take the X-ray, maybe within 1 hour, you can see this contrast inside the stomach. So we call this as barium meal. The small intestine, that is duodenum, jejunum, ileum, this is 6 meter long. If you have to study a pathology, suppose in the ileum, then patient is given the contrast suppose at 6 p.m. right now. This contrast is going to take a long time to reach the ileum or the jejunum area. We don't know at what time this contrast is going to reach into the ileum. So we have to keep on taking serial multiple X-rays. Multiple X-rays. That means we have to actually keep on following with the multiple X-rays where the contrast has reached. This is what we call as barium meal follow through. Barium meal follow through. That means beta G for duodenum, jejunum, ileum. We are doing a barium meal follow through. If you have to study the colon, right? Like here we know this is the cecum area. This would be the ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and the anal canal. If we have to study this colon and give the contrast from the mouth, then this contrast is going to take a long time. Maybe today 6 p.m. and maybe the contrast would be coming in the colon tomorrow at 6 a.m. or maybe 10 a.m. So we cannot wait till that time. If we have got another route, that means if we give the contrast from the anal canal here, it will immediately be going into the anal canal, rectum, sigmoid, descending, transverse, ascending, and the cecum. So within 5 minutes of giving the contrast, you will be able to see the entire colon, right? So why to give the contrast from the mouth if you have got a shorter route available from below? This is called as barium enema. Now beta, you might be having a question in your mind that to see the ileum also, why we don't use barium enema? So here we should know that God has given ileocecal valve in this area. There is a ileocecal valve, and the direction of this valve is such that we all know beta that how the peristalsis moves. From the ileum it will be going towards the cecum. That means this valve allows only one direction, ileum to cecum, not the opposite direction, cecum to ileum. So the contrast will be holded up in the cecum only and we will not be able to see the ileum, right? So for colon we are doing barium enema, right? Now beta, if we quickly see this, for studying the esophagus, barium swallow, stomach, barium meal, for duodenum, jejunum and ileum, barium meal follow through, and for the colon we are doing a barium enema, right? I hope beta that you will remember these contrast studies nicely. Okay, so this is just a summary of the contrast studies, though I know that radiology sir would have explained this nicely. So let's applaud our radiology sir for this. Contrast studies for the urinary tract, upper urinary tract and the lower urinary tract. Upper urinary tract we do IVU, IVP, retrograde pyelography and antegrade pyelography. Lower urinary tract, for the bladder we do cystogram, for urethra we do retrograde urethrogram. MCU or micturating cystourethrogram, which is also called as voiding cystogram, is a special contrast study which is usually done for identifying two pathologies, posterior urethral valve and vesico-ureteric reflux. The GI contrast studies, for esophagus we are doing a barium swallow, for stomach we are doing a barium meal, for duodenum, jejunum and ileum we are doing a barium meal follow through, while for colon we are doing a barium enema, right? Okay. Another contrast study, another pathology here is horseshoe kidney. The incidence of horseshoe kidney is 1 in 900. If we just try to understand that why this horseshoe kidney actually occurs, so beta, all of us, when we were during our intrauterine life, we were discussing that the kidneys, they start developing in the retroperitoneum, in the pelvic area, and during intrauterine life they have to ascend upwards to reach the lumbar region. Now when these two kidneys are ascending upwards, then there is a possibility both the kidneys, they look at each other and they find similarities between both of them. So they try to say hello to each other. Sometimes when the kidneys are ascending, the lower poles of the two kidneys, they may come close to each other, and sometimes they may come so close that they may even fuse in the midline. If the lower poles of the two kidneys fuse, then they will not be ascending upwards. That means both the kidneys will be arrested in the lower abdomen, and this is what is going to result in a horseshoe type of kidney. So it's a pair of ectopic kidney, and herein, as you are seeing, this is the abdominal aorta. And if you look at the blood supply of GIT from the abdominal aorta, foregut, midgut, hindgut, celiac, superior mesenteric, inferior mesenteric, T12, L1, L3, celiac trunk at T12 level, superior mesenteric artery L1, inferior mesenteric artery L3. Now beta, when both the kidneys, they are fused in the midline, here is the inferior mesenteric artery. Can you see this artery here? This is lying at L3 level. This artery does not allow the kidneys to ascend upwards. This also becomes the culprit to stop the ascent of the kidneys. That is why the MCQ people want to know what is the level of isthmus in horseshoe kidney, or what is the level of fusion in horseshoe kidney. So beta G, it becomes easy for us to remember that isthmus lies at L3, L4 vertebra. L3, L4 vertebra. If we have to choose one out of the two options, L4 is a better answer because inferior mesenteric artery is at L3. So generally the isthmus is seen below the L3. Now usually beta, it is 1 in 900. Suppose we are 900 people watching this session right now. Then one out of us might be having this horseshoe kidney. And you would be surprised to know that we will be passing our entire life and we might never ever come to know that we are having this horseshoe kidney. Usually patients do not have any problems. Both the kidneys, they are working fine. But rarely beta, what can happen? Here you are seeing that the ureters, they are falling away from the isthmus. But sometimes if I say that these ureters, they start dropping down like this, then the isthmus here, this is a bulky area. It might put pressure on the ureters from outside. And just imagine beta, if there is somebody who is pressing the ureters here, what is going to happen to the proximal people? Very good. So the proximal people are going to get dilated. That means the pelvic calyceal system is going to get dilated. And this is not only one side story. Again, it is a both-sided story. And you know, whenever there is hydronephrosis type of story or a traffic jam story, there is stasis. This stasis can lead to infection, UTIs, and this can even lead to stone formation. Yesterday we discussed the concept, whenever there is a traffic jam, proximal dilatation, high pressure in the proximal area, stasis, invitation, party, and in biliary, urinary and salivary tracts, this party can even lead to stones. That means usually horseshoe kidney patients, they are asymptomatic, but if rarely there is a traffic jam compressing the two ureters, we may find the proximal dilatations here, something like this, on both the sides. Stasis, party, and stone formation can occur. And when we do a IVP or IVU or CCT, then this appears like a bouquet of flowers, a flower vase ureters, and this is called as a hand joining sign. Look at me on the screen beta. This is hand joining sign. Hand joining sign here is not namaste, right? Hand joining sign is like this. These are the two ureters and these are the dilated pelvic calyceal systems. Okay, so this is what we call as flower vase ureters, or the hand joining sign, something like this, right? This is a image which is showing the dilated pelvic calyceal system on both the sides beta. Can you appreciate in this IVP picture that both the kidneys are not in the lumbar region beta? They are almost towards the midline, right? And they are in the lower abdomen. They are not in the lumbar region here. And herein, because of the dilated systems, this may appear like a bouquet of flowers. This is what is a flower vase appearance, right? Once again, you can see these dilated pelvic ileal system, and you can see that the calyces, the kidneys, they are facing towards the midline, right? Okay. The best investigation definitely would be CECT. This is a CT scan where you can nicely see the horseshoe kidney. This 30th of July 2023 also, beta, there was an image-based question which was related to polycystic kidney and which was related to horseshoe kidney. And in the upcoming test of MIST, there will be a lot of questions where you will be asked to identify what is a horseshoe kidney, what is a polycystic kidney, whether it's a CT scan or an MRI. Okay, so please be careful. This is a hot area for the images. But since this image has been there on 30th of July 2023, the chances of this being repeated looks bleak, but still it has the potential to be repeated. Okay, fine. Ideally, beta, if the patient is asymptomatic, nothing has to be done. You are doctors, beta. We never treat papers. We treat patients. We treat patient problems. Okay? If the patient does not have any problem, this patient will pass his entire life without any problems. So doctor should also enjoy his life and let patient also enjoy his life. However, if the patient is having some problems, maybe UTI, treat it with antibiotics. If there is a stone in the kidney, remove the stone from the kidney. You may have an argument that the reason for UTI in stone is a traffic jam in the ureters, probably by the isthmus. That is why the proximal story is getting dilated. So why you are just giving antibiotics and removing the stone? Why you don't chop the isthmus? Why you don't divide the isthmus? During intrauterine life, both the kidneys, they looked at each other. Something happened. They even fused. Now in adult life, they are not able to live together. So should we do a divorce for these two kidneys? I repeat this in Hindi, beta. इंट्रायूट्राइन लाइफ में क्या हुआ? दोनों ने एक दूसरे को देखा, कुछ हुआ, नजदीक आए, इतने नजदीक आ गए कि लोअर पोल फ्यूज हो गए. अब एडल्ट लाइफ में मान लो साथ में रहा नहीं जा रहा है, तो वैसे तो अपने को डाइवोर्स करा देना चाहिए. लेकिन डाइवोर्स इज ऑल्सो नॉट ईजी हियर, बिकॉज योर एब्डोमेन हैज गॉट 3 solid organs: liver, spleen, kidney. They are full of blood. Whenever there is any trauma to the abdomen, right? Any trauma to the abdomen, there are chances of injury to liver, spleen, kidney, and they can bleed profusely. Okay? When surgeons are doing surgeries on liver, spleen, kidney, they are very cautious because they know that if they incise the renal parenchyma, it is full of blood and there can be a profuse bleeding. And you would be surprised, beta, to know that operative textbooks of surgery, they write that sometimes when the surgeon is making an incision on the renal parenchyma, the bleeding is so profuse that surgeon is forced to think why he ever took up surgery. कभी कभी किडनी के ऑपरेशंस करते समय ब्लीडिंग इतनी खतरनाक हो जाती है कि सर्जन को वो काउंसलिंग वाला दिन याद आ जाता है, नीट पीजी का, जब काउंसलिंग में कहा था कि मुझे सर्जन बनना है. ऐसी खतरनाक ब्लीडिंग हो जाती है यहाँ पर. एंड समटाइम्स यू वुड बी सरप्राइज्ड टू सेव द लाइफ ऑफ दिस पेशेंट. द सर्जन्स माइट लैंड अप इन डूइंग अ नेफ्रेक्टमी ऑल्सो. Oh, then if the patient is just having some UTI, giving antibiotics is a safer option. Or if there is a stone, you just remove the stone. Right? So division of isthmus is not the treatment of choice in horseshoe kidney. This is what we will remember. Right. So now let's see what all is written here. In horseshoe kidney, the incidence is 1 in 900. It is a pair of ectopic kidney due to fusion of medial subdivision of lower poles of both the kidneys. The ascent of the kidney is impeded due to inferior mesenteric artery. The isthmus of horseshoe kidney is located at L3, L4 level. If you have to choose one, then it is the L4 level. Usually, patients are asymptomatic, but yes, there can be swelling and pain in the lower abdomen. यहाँ पे बेटा जी याद रखना, ये जो horseshoe kidney है ना, ये लंबर रीजन में नहीं गई है, लोअर एब्डोमेन में ही है. तो जो पेशेंट को स्वेलिंग और दर्द हो रहा है ये लंबर रीजन में नहीं हो रहा बेटा, पेट में नीचे हो रहा है. पॉलीसिस्टिक किडनी डिजीज में दोनों किडनी लंबर रीजन में थी, तो जो स्वेलिंग पेन था वो दोनों लंबर रीजन में था. प्लीज रिमेंबर बेटा, आई रिपीट दिस इन इंग्लिश. इन horseshoe kidney, since both the kidneys have not gone in the lumbar region, they are lying in the lower abdomen. So the swelling and pain what we are noticing is not in the lumbar region, it is in the lower abdomen. But in polycystic kidney beta, there were multiple cysts in both the kidneys and the kidneys have reached in the lumbar region. So swelling and pain was in the lumbar region, bilateral lumbar region in polycystic kidney disease, right? So यहाँ पे the examiner might play with you. So be careful यहाँ पे. Okay. Sometimes complications can occur like UTI and stones. First investigation, if there is a swelling, we'll do ultrasound. But the best would be doing a CECT of the abdomen. If we are doing IVP, IVU or CT contrast, then we can see flower vase ureters. Flower vase ureters. Or we also call it as hand joining sign. Hand joining sign. The treatment for horseshoe kidney, if the patient is asymptomatic, nothing. If there is UTI, antibiotics. If there is stone, then remove the stone. Division of isthmus is not the treatment of choice in horseshoe kidney. This is what we'll remember. And the reason is there can be profuse bleeding when we are making an incision on the renal parenchyma. So beta, this is about the lumbar region story. Absent kidney, ectopic kidney, polycystic kidney and horseshoe kidney. Okay. So before we move forward, let me quickly revise this for you. Today, what we have talked about intussusception and these kidney problems. Intussusception was invagination of one part of the intestine into the adjacent part, that is telescoping. Most commonly, ileocolic, 6 months, 5 to 10 months. Reason, idiopathic. However, hypertrophy of PS patches, rotavirus infection, rotavirus vaccine, Meckel's diverticulum. In adults, it is polyps in the colon, colocolic intussusception. In intussusception, how these babies will present at 6 months around? Emergency, excessive cry discomfort, sausage lump, right hypochondrium or left paraumbilical, concavity towards the umbilicus, blood mucus and stool, red currant jelly stool, empty right iliac fossa, sign of dance, digital rectal examination, examiner finger stained with blood. Lump in the abdomen, 6 months old baby, first ultrasound, donut sign, target sign, X-ray, meniscus crescent sign, barium enemas, claw sign, coiled spring sign, best CECT. Treatment, reduce the intussusception hydrostatically. Air enema, best. You can use saline or barium enemas to reduce the intussusception. If that area does not reduce with hydrostatic methods, operative reduction. During operation, never pull, always push. Gentle milking of the outer tube to reduce the inner tube. By chance, if the segment looks gangrenous, resection, anastomosis. Lumbar region, absent kidney due to renal agenesis, ectopic when the kidney fails to ascend upwards, usually left side, pelvis, retroperitoneum. Polycystic kidney disease, multiple cysts in the kidneys, congenital, infantile. Congenital, autosomal dominant, infantile, autosomal recessive. Congenital also called as adult because it presents in adult life, not in children. Infantile, very rare, high mortality. So generally congenital or adult polycystic kidney disease, bilateral, associated with cysts in other organs like liver, spleen, pancreas, ovaries, may be associated with berry-aneurysm of circle of Willis and mitral valve prolapse, can present after 30, 35, 40 years of age, hypertension, 75% of patients, swelling, pain in both the lumbar region, hematuria, uremia. First investigation, swelling in the abdomen, ultrasound will show multiple cysts in both the kidneys, best CECT, or we can do IVP, IVU whenever we are doing contrast studies. Because of cyst compressing the nephrons, we may find thinning of the calyces, spider leg appearance. Initially, In the treatment, try doing de-roofing of the cyst, but that doesn't help. Eventually land up in doing a kidney transplant. Transplanted kidney placed in the right iliac fossa, which is called as heterotopic transplant. Liver transplants, same anatomical location, so orthotopic transplants. When we have to choose the kidney from the donor, we prefer using left kidney because of long left renal vein. Various contrast studies of the urinary tract, upper tract for kidney and ureter, IVP IVU is the best contrast study. If not possible, retrograde pylography. If not possible, antegrade pylography. Lower urinary tract, bladder urethra for bladder cystogram. Urethra, retrograde urethrogram. MCU, that is micturating cystourethrogram, also called as voiding cystogram, is done for two pathologies: posterior urethral valves, vesico-ureteric reflux. GI contrast studies: esophagus, swallow, stomach, meal, duodenum jejunomyelium, meal follow-through, colon, enema. Horseshoe kidney, 1 in 900. It is a pair of ectopic kidney due to fusion of medial subdivisions of lower poles of the two kidneys in the midline. Inferior mesenteric artery arrest the ascent. So ascent does not occur, and this pair of ectopic kidney is lying in the lower abdomen. The isthmus or fusion is at the L3, L4 level. L4 better answer. Usually asymptomatic, rarely maybe symptomatic swelling and pain in the lower abdomen. Complications: UTI, stones. Patient presenting with swelling in the lower abdomen, ultrasound. Best CECT. When we are doing a CT contrast or IVP IVU, we find flower vase ureters or hand joining sign. In the treatment, if the patient is asymptomatic, nothing. If UTI, antibiotics. Stone, remove the stone. Division of isthmus is not the treatment of choice because it can cause profuse bleeding. Now, from the iliac fossas, we'll move towards the, from the lumbar region, we move towards the iliac fossa area. Right. So what we'll do, beta, we'll take a very short break out here, a 10 minutes break. So that we can continue nicely up to 8 o'clock. And we'll be back at 7. 7:03 p.m. Thank you very much. Don't go anywhere. Just I am not breaking the link. Same link will continue. Hello. Right. So, okay, good. Fine. So the update is that India is really doing good. And the last what I saw was 111 for 2 in 15 overs. That's great going. So let's just pray to God, all the cricket lovers, that India should do well today. Right. So now moving in the Ilek Fusavita. Herein, if we try to understand, just look at the screen and just revise what anatomy ma'am has told us in the anatomy classes. During intrauterine life, all of us, we were something like this. Suppose, beta, this is our everything looks okay. Suppose this is the umbilicus, this is the intestine, and this is the urinary bladder. During intrauterine life, all of us had connections of our umbilicus with the intestine, the vitellointestinal duct or the omphallo-mesenteric duct. Also, there was a connection of the umbilicus with the bladder, which is called as the allantois. So, beta, this is the allantois and this is the vitellointestinal duct. This is present during intrauterine life. But before birth, these connections, they completely obliterate, so that all of us right now, we are not having any connection of our intestine with the umbilicus or bladder with the umbilicus, right? But if somebody has done bad deeds in his previous life, then what can happen, beta? God may say that, okay, I am not going to close the connection of the intestine with the umbilicus. So there may be a patent vitellointestinal duct or the omphallo-mesenteric duct. And if the baby is born like this, then we can understand that whatever is coming in the intestine, suppose the baby is taking any meals, say milk, then this milk here, there will be digestive juices, the intestinal contents. So the baby may present with some greenish, yellowish discharge from the umbilicus. This is a both-sided affair. That is, abnormal relation between the umbilicus and the intestine. And beta, can you tell me what is this abnormal relation called as? This is fistula. So this, what we are seeing here, this will be a umbilical fecal fistula. And if I say, beta, suppose this story persists after birth, then we can understand that urine from the bladder will be coming out from the umbilicus. A newborn baby presenting with watery discharge from the umbilicus. This is due to failure of involution of the allantois. Sometimes God says that he has not done that many bad deeds. So what I'll do is, I'll only keep the umbilical end patent. Only the umbilical end is patent, maybe of the vitellointestinal duct or maybe of the allantois. Now, beta, this is not a both-sided affair. This is just a one-sided affair with the skin. And beta, what do we call that one-sided affair with the skin? That is a sinus. So, because this area will be lined by mucosa, so it will be secreting some mucus. If you find a newborn baby presenting with mucus coming out from the umbilicus, then it can be a case of umbilical sinus, which may be due to persistence of intestinal end of vitellointestinal duct or umbilical end of, not the intestinal end, beta, this is the umbilical end of the vitellointestinal duct or the umbilical end of the allantois. Right, so this is umbilical sinus. Sometimes God says, okay, let me create something like this. Herein, it is not the umbilical end, but it is the other end, the intestinal end. And here again, it is not the umbilical end, but it is the vesical end. So, beta, if the intestinal end of vitellointestinal duct remains patent, this is a one-sided connection with the organ. Here, it is the vesical end of the allantois which is patent. So again, this is a one-sided connection with the organ. And one-sided connection with the organ, this is called as a diverticula. This is the famous Meckel's diverticula, and this is congenital urinary bladder diverticula. Right? Congenital diverticulas, beta, they are true diverticulas. Congenital is something which is present right from the birth. बच्चे मन के सच्चे. तो congenital जो diverticulas होते हैं वो सच्चे diverticula होते हैं, true diverticulas. Congenital are true because they contain all the layers of the organ. We should differentiate congenital from acquired diverticulas. Acquired means which are acquired later in life. And the story of acquired diverticulas is something related to traffic jam. For example, if we look in this image beta, herein, this we all can understand is the large intestine. And here, suppose this is the rectum. We know that rectum and the sigmoid, these are the two reservoirs of fecal matter. It is only because of this rectum and the sigmoid that we are getting 1 or 2 opportunities in a day to pass the feces. If by chance God has not created the rectum or the sigmoid, you can just imagine what would be happening inside you right now. If there is no rectum and sigmoid, the fecal matter would have been coming here, and as soon as it comes into the anal canal, because there is no storage, it will be coming very soon in the anal canal. And if suppose the fecal matter is coming in the anal canal right now inside you, then you will try to do something to hold on to it. Right? That means continuously the fecal matter is coming here, then the frequency of defecations would drastically increase. That is why God had to create the reservoirs, rectum and the sigmoid. And the same concept lies in the urinary tract also, beta. The kidneys, the nephrons are continuously filtering the urine. So the urine is continuously coming in the bladder. If God has not given us the urinary bladder, then you can imagine from the ureters, if there would have been direct connection with the urethra, then urine will not be staying inside, and continuously when urine is coming towards the urethra, then you will be going for frequent micturations. I repeat this in Hindi beta. जो GI ट्रैक्ट देखें या यूरिनरी ट्रैक्ट देखें, तो भगवान ने यहाँ पे रिजर्वॉयर्स बनाए, टंकियाँ बनाई स्टोर करने के लिए. फीकल मैटर को स्टोर करने के लिए रेक्टम सिग्मॉइड बनाया, और यूरिन को, सुसु को स्टोर करने के लिए ब्लैडर बनाया. अगर भगवान ने हमको ये स्टोरेज ऑर्गन्स नहीं दिए होते, तो जैसे ही सामान नीचे आता वैसे ही अर्ज हो जाती कि जाना है अब. यानी कि हम आधा घंटा भी कहीं पे ठीक से नहीं बैठ पाते, इसलिए ये टंकियां बनाई गई. अभी लेट अस ट्राई टू इमेजिन अ कॉन्स्टिपेटेड इंडिविजुअल. इफ सपोज somebody is getting one opportunity in 4, 5, 6 days, the fecal matter would be staying inside the rectum for a long period of time. And if the fecal matter stays here for a long period of time, you can understand there would be a traffic jam type of situation. And if there is a traffic jam here, what will happen to the proximal people? Dilated. Pressure in the proximal people increases. जैसे जैसे उम्र बढ़ती है, इमारतें कमज़ोर होने लगती हैं. As we grow old, the tissues become weaker and weaker, and just imagine elderly people with constipation. High pressure in the sigmoid will force the mucosa, submucosa of the sigmoid to protrude outwards and may result in diverticulas in the sigmoid colon. These are acquired diverticulas which are acquired later in life. They are not true diverticulas because they do not contain all the layers. They contain mucosa and submucosa usually. Another acquired diverticula, Zenker's diverticula. Now, this is a pharyngeal pouch, which again in your anatomy classes and ENT classes, you know the esophagus starting point is the cricopharyngeal sphincter, which is the narrowest part of GIT. If the tone of the cricopharyngeal sphincter is high, that means if this area remains tight, the pressure in the pharynx will increase. High pressure will force the posterior pharyngeal wall to protrude through a weakness in the posterior pharyngeal wall. That is Killian's triangle or Killian's dehiscence, the inferior constrictor muscle between the cricopharyngeus, thyropharyngeus muscle fibers. So this is called as pharyngeal pouch, pulsion diverticula. This is acquired diverticula, especially in elderly people. Acquired are false diverticulas. They do not contain all the layers. They just contain mucosa and superficial submucosa. Beta G, you can apply the same concept in acquired bladder diverticulas. Imagine elderly person, 70-80-year-old gentleman. What is a common urinary problem in a 70-80-year-old male? Very good. So it is BPH, benign prostatic hyperplasia, which is this prostate gland is located around the prostatic urethra. Elderly person, if the prostate gland enlarges, it will start compressing the prostatic urethra, traffic jam in the prostatic urethra. That means the bladder will get distended and the pressure in the bladder will increase. 70-year-old bladder will not be able to tolerate such high pressures. And this bladder mucosa, submucosa may protrude outwards, resulting in acquired bladder diverticulas. So beta G, we were trying to discuss the story of diverticulas. For that we had to discuss the background story of congenital diverticulas, where we started from our anatomy, the relationship between the intestine umbilicus and bladder umbilicus. Okay, so we discussed about umbilical fecal fistula, umbilical urinary fistula, umbilical sinus, Meckel's diverticula, congenital bladder diverticula. Meckel's and congenital bladder, they are congenital from birth. They are true because they contain all layers of the organ. We should differentiate congenital from acquired. Acquired, which are acquired later in life. Right? They are not true diverticulas. They are false because they contain only mucosa and submucosa. Whenever there is a traffic jam, proximal people dilate, pressure in the proximal area increase. If the wall of the proximal area is weak, then this pressure can force mucosa, submucosa to protrude outwards. Lovely. May God bless you all. I hope you are able to understand this concept nicely. Now let's take a look. What is the story of Meckel's? Right, beta. So herein, if we just try to understand umbilical fecal fistula, this is basically failure of involution of vitellointestinal duct. That is the omphallomesenteric duct. The intestinal contents coming from the umbilicus of a newborn baby. Umbilical urinary fistula, failure of involution of allantois. Urine or watery discharge come out from the umbilicus in a newborn baby. Umbilical sinus can be the patent umbilical end of either the vitellointestinal duct or the allantois. Mucus will come out from the baby's umbilicus. Meckel's diverticula is the patent intestinal end of vitellointestinal duct. Congenital urinary bladder diverticula, patent vesical end of allantois. Congenital diverticulas are true diverticulas because they contain all layers of the organ, like Meckel's and congenital urinary bladder diverticulas. They are present since birth. Acquired diverticulas, they are false diverticulas because they do not contain all layers. They contain only mucosa or superficial submucosa. And ध्यान रखना, जैसे जैसे उम्र बढ़ती है, इमारतें कमजोर होती हैं. as we grow old, the tissues become weaker and weaker, and high pressure in any area of the body can force the wall of that area to protrude outwards. So they are commonly seen in elderly people, like sigmoid colon diverticulus, Zenker's diverticula, and acquired urinary bladder diverticula. Meckel's diverticula. This Meckel's, this what we are seeing, beta, is the intestine. And if you can see, there is something hanging from the intestine here. This is Meckel's diverticula. Meckel's is a congenital diverticula, true diverticula, present since birth. This here, what you are seeing, is the mesentery, which is having the blood vessels supplying blood to the intestine. So look at the screen, beta. This becomes the mesenteric border of the intestine, and the opposite border will be the anti-mesenteric border. I repeat, this is the mesenteric border and this is the anti-mesenteric border. MCQ people want to know Meckel's is seen on which border, mesenteric or anti-mesenteric? Very good. So it is the anti-mesenteric border. Meckel's follows a rule of 2, that is, it is 2 centimeter wide, 2 inches long, and it is located 2 feet proximal to ileocecal junction. From this junction, it is located 2 feet proximal. That means, beta, Meckel's is present in the small intestine, right? Meckel's, 2% of population. 2% of population is big number. If we are 100 people watching this session, then 2 of us would be having this Meckel's inside us. Somebody has done good deeds in his previous life. So God may think that let me give this person something extra. So God has given him extra Meckel's diverticula, right? 2% of population, but generally doctors don't see this very often in clinical practice because Meckel's are usually asymptomatic. जिंदगी गुजर जाती है और एहसास भी नहीं होता कि हम ही वो थे जिनको Meckel's था. Usually they are asymptomatic. Patient passes the entire life and patient never ever comes to know that he was having Meckel's inside. This is the usual story. Rarely patients can present with symptoms maybe at around 2 years of age. 2% of patients can be symptomatic at 2 years of age. Again, 2 to 2. Meckel's may also consist of heterotopic epithelium. Meckel's, what we are seeing here, beta, is a part of the intestine. So, intestinal epithelium is present in Meckel's. Understood. But Meckel's may also contain epithelium of some other area. Now, this is a December 23 question. Which other area epithelium is present in Meckel's? And the answer is gastric. Gastric, 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 gastric. Commonly, intestinal epithelium is there. But very often, we also find stomach lining inside the Meckel's. Most commonly, gastric epithelium. Colonic, pancreatic epithelium can also be found in Meckel's. And beta, please remember, whenever gastric lining ulcerates or gastric mucosa ulcerates, we call it as peptic ulcer. The commonest site of peptic ulcer is first part of duodenum. Second commonest site is the stomach. It may be seen, peptic ulcer may be seen in the lower esophagus, Meckel's diverticula, and sometimes in stomas of gastrojejunostomy, which we'll be discussing in detail in adult surgical problems, right? But we have to remember that if gastric lining is present here and it ulcerates, that is a peptic ulcer. Peptic ulcer in Meckel's, right? Okay. Apart from this, beta, sometimes this Meckel's can go into the inguinal hernias. If Meckel's is forming a content of the inguinal hernia, then such a hernia is called as Litter's hernia. Litter's hernia. So this is the background story. What we have discussed, that sometimes the patient may present with symptoms, and this may be because whatever intestinal contents, they are going into the mucus. They may stay inside the mucus. Stasis is an open invitation for the party, and then party of mucus, diverticulitis. This will present just like acute appendicitis, because appendix is located here. If appendix gets inflamed or diverticuli mucus gets inflamed, they both present with almost the same symptoms. So mucus mimics acute appendicitis sometimes. Sometimes complications can occur in mucus. Most common complication is bleeding in the mucus, and this blood will trickle and go into the cecum in the colon, and the patient may pass blood and mucus and stool. Diverticulitis can occur. Sometimes when the tension in the diverticula increases, these diverticulas may even perforate. Diverticular perforation can occur. Peptic ulceration can occur. Mucus is making this portion of the ileum heavy. So peristalsis can force this heavy part to right into the adjacent part. That means mucus can also cause intussusception. Mucus can even cause intestinal obstruction. Look at me on the screen, beta. Mucus is not causing any problems to the movement in the intestine. So why there should be intestinal obstruction? The reason for intestinal obstruction in mucus is not mucus, but it is something else. If suppose mucus is present in some person, like if I say, beta, this is suppose the intestine, and here is the mucus diverticula, this one. Sometimes a band may present from umbilicus to the apex of mucus, like this. A band is present, and just imagine, beta, band is like a thread or a string. अगर सोच के देखो, I first say this in Hindi and then I'll repeat this in English. अगर सोच के देखो बेटा कि हम कहीं चल रहे हैं, अपने घर में ही कहीं चल रहे हैं, और नीचे कोई लूज तार पड़ा हुआ है, तो कभी हमारा पैर उस तार में उलझ सकता है ना? ऐसे ही अगर अपने पेट के अंदर भगवान ने कोई एक्स्ट्रा धागा या कोई रस्सी बनाई, तो जो स्मॉल इंटेस्टाइन्स है ना बेटा, जो 6 मीटर लंबी है, ऐसे ही पेट में फ्री घूमती रहती है, वो जेजुनम हाइलियम, अगर पेट के अंदर कोई तार है, कोई धागा है, तो ये इंटेस्टाइन्स उस धागे में आके उलट सकती हैं और उससे इंटेस्टाइनल ऑब्स्ट्रक्शन होता है। डाइवर्टिकुला की वजह से इंटेस्टाइनल ऑब्स्ट्रक्शन नहीं होता, धागे की वजह से इंटेस्टाइनल ऑब्स्ट्रक्शन होता है। आई रिपीट दिस इन इंग्लिश बेटा। The reason for intestinal obstruction is not the diverticula, but just imagine if all of us who are watching this session, if we have got a thread-like of thing in our abdomen, extending from the umbilicus to the apex of mucus, small intestine, 6 meter long, jejunum, ileum, they are freely mobile. If there is a thread-like of thing in our abdomen, these small intestines may rotate around this thread. So reason for intestinal obstruction is not the diverticula, but it is the thread, which we call as band, right? So I repeat beta, the complications of mucus, bleeding, diverticulitis, diverticular perforation, peptic ulceration, intussusception, intestinal obstruction. The best investigation to diagnose mucus is a radioisotope scan, which we call as mucus scan. In this radioisotope scan, beta, all these images what we are seeing, these are all independent images, and in every image what we are able to see is, this is the abdominal area, this is the upper abdominal area, this is the lower abdominal area, this would be the pelvic area, and these are the lower limbs. I repeat this beta. This is the upper abdomen, this is the lower abdomen, this is the pelvic area, and this is the lower limb area. Meckel scan is a radioisotope scan where we use technetium pertechnetate. The radioisotope used here is a technetium pertechnetate. And this radioisotope is labeled in such a way that it will be taken up by gastric epithelium wherever it is present in the body. Just give me a moment. Wherever there is gastric epithelium, this gastric epithelium will take up the technetium pertechnetate and it will appear as a black shadow. So beta, just imagine you are given this technetium pertechnetate and you are searching for the black shadow in the entire body. This area, in all the images, you are seeing the black shadow in the upper abdomen. That is because of stomach epithelium. Stomach is there in this area. If you find another black shadow in the lower abdomen, like in these images, you are able to see a black shadow in the lower abdomen. That means gastric epithelium is present somewhere else also. And this confirms the Meckels. So this is how we diagnose Meckels. However, if suppose we have to do a contrast study to diagnose Meckels, then which contrast study will you do for small intestine or ileum? Barium swallow, barium meal follow through, or barium enema? Very good. So you will be doing a barium meal follow through, not barium enema. In barium enema, you are giving the contrast from below. So the contrast is coming from the anal canal, rectum, sigmoid, descending, transverse, ascending, and cecum. And there is a ileocecal valve here. So the contrast from cecum will not be able to go into the ileum. That is why to see the ileum, we do a barium meal follow through. That can show us this Meckels. We have been doing endoscopies very commonly. There is no opening in the body left. All the natural openings in the body, we have passed the endoscope in all these openings. Nasal endoscopies, upper GI endoscopy, colonoscopy, cystoscopy for urinary bladder via urethra, hysteroscopy, that is for the uterus via the cervix, vagina, cervix, uterus, Sial endoscopy, the salivary gland ducts. We can pass a endoscope into the salivary gland ducts, Sial endoscopy. Breast lactiferous ducts, we can do a ductoscopy in lactiferous ducts. So Meckels also says that I also want to get visualized by endoscopy. But beta, we have a challenge here. We know that for GI tract, we have got two natural openings for the GI tract. We can pass a endoscope from the mouth, or we can pass a endoscope, or I'll change my position a bit here. Right. So for GI endoscopies, beta, there are only two natural openings, this and this. So if you pass a endoscope from this area, this is upper GI endoscopy. And if you pass a endoscope from this area, this is the lower GI endoscopy. And when you are scanning the entire colon, we call it as colonoscopy. Upper GI endoscopy, it is having a limitation that we can take this endoscope into the stomach, first part and second part of duodenum. But we are not able to take this endoscope beyond the second part, because here you can see this is 6 meter long, lying as loops. So we will not be able to take the endoscope in these loops. That is why beta, third part, fourth part of duodenum, jejunum and ileum, we are not able to do the upper GI endoscopy. So upper GI endoscopy is limited for the esophagus, stomach, first and second part of duodenum. When we are doing a colonoscopy, we already know that we can pass the colonoscope up to the cecum, but we will not be able to pass the colonoscope into the ileum. And the reason is there is a ileocecal valve here. because of which we will not be able to pass the colonoscope into the ileum. There is a ileocecal valve here. When the colonoscope is coming, we can only pass the colonoscope up to this area. We will not be able to pass this colonoscope because of the ileocecal valve into the ileum. That means the third part of duodenum, fourth part of duodenum, jejunum, ileum, endoscopy is not possible. That is why we prefer doing a CECT for these areas. Now, Mikkels is saying that, see, you have reached onto the moon, but you are not able to pass a endoscope and try to identify me on endoscopy. So the doctor said that, see, now because of the advancements in the techniques in the industries, we can make a capsule, put a camera inside the capsule, which can take the pictures. Patient swallows the capsule goes inside. Mikkels is very happy. Yes, now today somebody is going to take my pictures. Yes, endoscopy. So the capsule is going inside. The capsule, suppose, is programmed to take pictures at every 5 seconds. Sometimes what can happen, beta? When the capsule has come here, it takes the picture. Capsule comes here, it takes the picture. Mikkels is eagerly waiting for photograph. Maybe in the next 3-4 seconds, the capsule goes here and takes the picture here. Mikkels, who was eagerly waiting for the photograph, is just looking at the capsule. Hey, capsule, take my picture, take my picture. But the capsule doesn't listen. The capsule moves ahead. That means this video capsule endoscopy may not give the accurate results. So we cannot rely on video capsule endoscopies. Right. What should be the treatment for Mikkels? Because majority patients are asymptomatic, so nothing has to be done. If by chance the patient is symptomatic or there are some complications in Mikkels, then we have to do something depending on the mouth of the Mikkels. If mouth of the Mikkels is narrow, suppose the mouth is like this, then beta, what we can do is we can take a linear stapler. This was a 20th of January 2023 image based question. Something like this image was there and they asked, what is this instrument? So this is a linear stapler. This is a linear stapler. Right? Herein, the difference between a surgical stapler used inside the body and the stationary stapler. जो स्टेशनरी वाला स्टेपलर होता है ना बेटा, जिससे अपन पेपर क्लिप पिन करते, that stationary stapler only has pins, so it sutures. But a surgical stapler used inside, it has got a knife and pins, so it cuts as well as sutures. Right? So now if we take this linear stapler and try to do the surgery for Mikkels, you fire the linear stapler something like this. After firing it like this, what you are left with is something like this. That means the lumen of the intestine is quite wide, and whatever the patient is eating, suppose patient is eating samosa, then this samosa will not be facing any problem and the samosa will be passing from this area. But beta, if we try to do a diverticulectomy for a wide mouth Mikkels, suppose I say that mouth of the Mikkels is quite broad, and if we are doing a diverticulectomy here, we have to fire the linear stapler like this. That means what we will be left with after diverticulectomy would be something like this. And now if you carefully take a look at the lumen, what is left here, only this much area is left. So when the patient is taking samosa, now the samosa is not moving ahead. So doing a diverticulectomy in a wide mouth Mikkels, it may create a traffic jam. So for a wide mouth Mikkels, it is not the diverticulectomy which is the right answer. What we should do is, we should remove a segment of intestine which is bearing the Meckel's. You can remove a piece of the intestine. You know, the length of intestine is 6 meters. So if you remove a 10 centimeter segment of intestine which is having Meckel's, not a problem. And you join the remaining ends. So resection and anastomosis would be a better option for a wide mouth Meckel's. Right? Fine. Let's see beta what all is written here. Okay. Meckel's diverticula. This is persistence of intestinal end of vitello-intestinal duct or the omphallomesenteric duct. Meckel's is found on the anti-mesenteric border. Meckel's is a congenital diverticula, and congenital are two diverticulas because they contain all layers of the intestine. Meckel's has its own blood supply and follows the rule of 2% population, 2 centimeter wide, 2 inches long, that is 3 to 5 centimeters long. And Meckel's is located 2 feet, that is 60 centimeter, proximal to ileocecal junction. 2 feet, that is 60 centimeters, proximal to ileocecal junction. Meckel's presents at around 2 years of age. Only 2% of patients can be symptomatic, and Meckel's consists of heterotopic epithelium. December 23. Most common epithelium present in Meckel's is gastric. Herein, why there is a high probability of this MCQ in December 23? Because this question has been asked in NEET PG exam in the year 2022, and this is a hot area from where the MCQ people are picking up the questions, right? Most likely, if they have to ask a question from Meckel's, then it should be something related to this, that which other organ lining is present in Meckel's. So we feel that this can be a high probable question for December 23. There can be pancreatic and colonic epithelium in Meckel's. If Meckel's is found in the hernial sac, such a hernia is called as Litter's hernia. Usually patients are asymptomatic. Rarely there can be symptoms which mimic acute appendicitis. Complications in Meckel's. Bleeding is the most common. There can be diverticulitis, diverticular perforation, peptic ulceration, that is ulceration of the gastric mucosa in Meckel's. And Meckel's can make the intestine heavy, so peristalsis can cause intussusception. Intestinal obstruction in Meckel's is due to a band from the umbilicus to the apex of diverticulars. Investigation of choice for Meckel's is a Meckel's scan. This is a radioisotope scan or a technetium pertechnetate scan. We can do a barium meal follow through or a video capsule endoscopy as well, but the best one is a radioisotope scan. If patient is asymptomatic, nothing has to be done. But if Meckel's is symptomatic or there are complications, then depending on the mouth of the Meckel's beta. If the mouth of the Meckel's is narrow, we do a diverticulectomy. If the mouth of the Meckel's is wide, then we do resection of segment of intestine bearing the Meckel's with end-to-end anastomosis. And beta G, we prefer staplers in Meckel's surgery especially. This what we are seeing is a linear stapler. If we go into the left iliac fossa, there we have to talk something about Hirschsprung disease. That is a congenital aganglionosis or congenital megacolon. Basically, We know that the entire GI tract, beta, we take food, we swallow the air, we release the air. So there is a continuous peristalsis in our GI tract, and this peristalsis is because of muscle contractions. And beta, who is responsible for these muscle contractions? The nerves. Suppose somebody has done bad deeds in his previous life and God says, I will not give ganglion cells in the nerve plexus. So the muscle contractions will not occur and there won't be any peristalsis in that area where there are no ganglion cells. This absence of ganglion cells in the nerve plexus, especially in the rectosigmoid area in the babies, is what we call as Hirschsprung disease. And beta G, please remember, rectum is always involved in Hirschsprung disease, though the commonest site is rectum and sigmoid. Depending on what is the length of a ganglionic segment, the presentation of the patient will depend accordingly. For example, if there is a only small aganglionic segment, the peristalsis, just imagine a newborn baby who is born, right? If this area does not have ganglion cells, that means peristalsis are not present only in this area. Peristalsis is normal in all this area. Baby is born. Generally nowadays, beta, what is happening? Everyone is trying to record every moment, every precious moment. Like these days, before the weddings, there is a pre-wedding shoot. है ना बेटा? शादी से पहले आजकल प्री-वेडिंग शूट वगैरह चलते हैं. शादी के बाद जब बच्चा होता है तो बच्चे के पहले पहले मोमेंट्स रिकॉर्ड करने लगे हैं. बच्चे की पहली सुसु, बच्चे की पहली पॉटी, all these, right? Nowadays, the parents are trying to record every precious moment of the baby, whether it's the urine or the potty. So just imagine, newborn baby who is born in the family, the parents want to record the first urine, the first potty of this baby. Now what can happen in Hirschsprung disease, beta? If there is no peristalsis in this area, and if it is only a short segment which is aganglionic, the peristalsis which is coming here, the force of this peristalsis may be sufficient enough to force the fecal matter to pass through this small aganglionic segment. Though it may take some time for the fecal matter to pass. That means generally the baby will pass the meconium within 24 hours or maybe in 48 hours. But here there might be a history that parents were waiting with that video camera, but the baby did not pass stool even in 48 hours. Maybe after 48 hours, 72 hours, the baby has passed meconium. So there may be a delayed passage of meconium immediately after birth. Generally, I repeat, if only a short segment is aganglionic, the force of peristalsis is sufficient to force the fecal matter to pass through a small aganglionic segment. So no problems, just a delayed passage of meconium. When this baby grows, maybe in childhood, if the aganglionic segment also grows, then peristalsis may not be sufficient to continuously force the fecal matter at a normal pace. So the baby may suffer from constipation. March 24, you are in the OPD. If you find a baby with constipation, the first thing what we do as doctors is try to modify the diet. But if it is Hirschsprung disease, even dietary modifications are not going to help. So we have to identify what is the cause, what is the problem. To look for constipation in a small baby, we can do a barium enema. And when we do barium enema, that means we are giving the contrast from below. For example, if we see here, this is a flatus tube which we have passed into the anal canal. And now through this we are giving the contrast. The contrast is moving like this. In the aganglionic area, there is no peristalsis. So, you will find a narrow area here. This is the aganglionic area. That means this is the site of traffic jam basically. And if there is a traffic jam here, then the proximal colon will be dilated. Peristalsis is present in this area but absent in this area. So the narrow contracted area is pathological, but the proximal dilated area is actually normal. There is a traffic jam just proximal to the aganglionic segment, right? Barium enema can also tell us the length of aganglionic segment. Like if you look at another picture, oh my God, can you see what a big, long segment is narrow? So this is the long aganglionic segment which we can see on barium enema. And the proximal, there's a traffic jam here. So the proximal colon is grossly distended. So first we do a barium enema, and also we should know better that depending on the severity of traffic jam or severity of aganglionic segment, the pressures in the proximal part will increase accordingly. That means if we can put some instrument into this area and try to measure pressure in this area, depending on how much pressure is there, we can classify what is the severity of Hirschsprung disease. Measuring pressure in this area, we can call it as anorectal manometry. Whether it is barium enema or manometry, we can come to know that yes, there is a traffic jam. But what is the exact reason of traffic jam? If we have to conclude that it is Hirschsprung, then best investigation to diagnose Hirschsprung will be you take a biopsy from this aganglionic segment. Biopsy will demonstrate absence of ganglion cells. So the best investigation is a rectal biopsy, which is a suction rectal biopsy. Once the diagnosis is confirmed, you want to restore the normalcy, you can do some operations to deal with this aganglionic segment. Maybe you can chop it off and join the remaining parts. So we can do various operations to deal with this aganglionic segment. These are Duhamel, Swenson and Sove operations. Another story beta, if suppose a long segment is aganglionic, अगर इतना लंबा segment में ganglion cells नहीं है, just imagine newborn baby. Parents are trying to record the first potty of this baby. But if such a big segment is aganglionic, when the peristalsis is coming here, the peristalsis force may not be sufficient enough to force the fecal matter to pass through such a big aganglionic segment. That means this peristalsis will not be able to force the fecal matter out. So all the fecal matter is going to get impacted in this area only. And this is a complete traffic jam. The parents are trying to record the first potty, but 2 days, 3 days, 4 days, 5 days, nothing is coming out. And now what is happening? Because of a complete traffic jam here, the proximal colon is going to get distended. And when the proximal colon is getting distended here, there is a risk that this colon may rupture. And if this colon ruptures, the potty will leak into the peritoneal cavity. Oh my God, potty in the peritoneal cavity, potty full of bacteria. Potty in the peritoneal cavity. Bacterial inflammation in the peritoneal cavity. Peritonitis, potty peritonitis. Because of such a big bacterial load, this patient can die. This baby can die. Oh my God. If there is a complete traffic jam, newborn baby, proximal colon distended, colon may rupture, potty, peritonitis, septicemia, baby can die. You are the second God. You cannot let this baby die. So this is the emergency situation. If there is a complete traffic jam in the newborn baby, baby presenting with gross abdominal distension, now don't let this colon rupture inside the peritoneal cavity. Small 5 minutes operation. Make a cut in the epigastrium. Put your thumb index finger inside the peritoneal cavity. Bring the distended colon out on the abdominal wall. And then make an incision in the transverse colon. All the potty will come out of the transverse colon, but not inside the peritoneal cavity, but outside the abdomen. So no peritonitis, no septicemia, no death. You have just brought the distended colon out on the abdominal wall, incised it, removed the potty outside. Proximal colostomy. Yesterday, we were talking about a complete traffic jam situation in different areas now, beta. We were trying to understand the pressure cooker, how God has given, how the pressure cooker has a vessel, right? The same thing is what we are doing here. Complete traffic jam, risk of rupture inside, peritonitis, septicemia. We don't want this to happen. So we have just brought this transverse colon out on the abdominal wall as a proximal colostomy. Please remember, my dear lovely doctors, whenever there is a complete traffic jam in the large intestine, if you want to save the life of this patient, do a proximal colostomy. The reason of complete traffic jam can be anything. कारण कुछ भी हो सकता है बेटा. अगर large intestine में complete traffic jam है, तो proximal colon पूरी तरह से dilated है, जिसकी वजह से proximal colon के फटने के chances हैं. अंदर नहीं फटना चाहिए, क्योंकि अगर अंदर फट गया तो सारी पॉटी पेट के अंदर लीक कर जाएगी, पूरे पेट में पॉटी हो जाएगी, पॉटी पेरिटोनाइटिस हो जाएगी, जिससे सेप्टिसीमिया में जाके उस पेशेंट की मृत्यु हो सकती है. आप जो दूसरे भगवान हैं, जिंदगियां देते हैं, ऐसा नहीं होने देंगे. जब भी कोई ऐसे हालात दिखे, प्रॉक्सिमल कोलॉन को पेट से बाहर निकाल दीजिए और सारी पॉटी को बाहर डाइवर्ट कर दीजिए. उससे पेशेंट की जिंदगी बच जाती है. आई जस्ट एक्सप्लेन the same concept what we have been discussing in English in Hindi language also, right? Okay, beta. So please do remember this. Let's see what all is written here in Hirschsprung disease. Hirschsprung disease or congenital megacolon or congenital aganglionosis. A means absence, so absence of ganglion cells in the nerve plexus. Most commonly the rectosigmoid, wherein rectum is always involved. This story can present to us either in the OPD or in the emergency. Generally, if a short segment is aganglionic, the story presents in the OPD in childhood, baby having constipation. First, what we have to do, barium enema. This can show us the extent of disease. On barium enema, the narrow contracted part is pathological, while the proximal dilated part is normal. To know the severity of obstruction, we can do anorectal manometry. However, the investigation of choice to diagnose is suction rectal biopsy. And once the diagnosis of Hirschsprung is made, then we can do various operations like Duhamel, Swenson and Sove operations. Various operations what we are doing here, Duhamel, Swenson and Sove operation. Beta, please cut the sparks here. Nowadays we don't call it as Parks anastomosis. It is just a Sove anastomosis. Another story, beta, if it presents in emergency, generally when a long segment is aganglionic, then the story presents in emergency in the neonate with intestinal obstruction, and the treatment for this emergency story will be proximal colostomy. Proximal colostomy. Right. So this is about the Hirschsprung disease, beta. Right. So now what we'll do is we'll just quickly revise what we have talked about after that short break. Meckel's diverticula and Hirschsprung disease. Meckel's. There we discussed about the various issues with the umbilical fecal fistula due to failure of involution of the vitalointestinal duct or the omphallomesenteric duct. Greenish yellowish discharge from the newborn baby's umbilicus, umbilical fecal fistula. Persistence of allantois even after birth, failure of involution of allantois, urine or watery discharge from the newborn baby's umbilicus, umbilical urinary fistula, patent umbilical end of either vitalointestinal or allantois, mucus discharge from the baby's umbilical sinus, patent intestinal end of vitalointestinal duct, Meckel's diverticula, patent vesical end of allantois, congenital urinary bladder diverticula. Meckel's and congenital urinary bladder diverticulas are true diverticulas because they contain all the layers of the organ. They are present from birth. They should be differentiated from acquired diverticulas which are acquired later in life. Whenever there is a traffic jam, proximal people dilate, pressure in the proximal part increases. Elderly people, when the tissues are weak, mucosa, submucosa moves outwards. Acquired diverticulas. They are false. They do not contain all the layers. Only mucosa and submucosa, like sigmoid colon, Zenker's, and acquired urinary bladder diverticulas. Meckel's is a congenital diverticula. True, contain all the layers, present since birth. Patent intestinal end of vitalointestinal duct, has its own blood supply, antimesenteric border, rule of 2% population, 2 centimeter wide, 2 inches long, 2 feet proximal to ileocecal junction, may present around 2 years of age, 2% symptomatic. Most commonly contains heterotopic epithelium, that is gastric. Colonic pancreatic epithelium can also be present. If it is found in the hernial sac, Litter's hernia, usually asymptomatic, but symptomatic mimic acute appendicitis. Complications, most common bleeding, diverticulitis, diverticular perforation, peptic ulcer, intussusception, intestinal obstruction due to band from the umbilicus to the apex of Meckel's. Investigation of choice, Meckel's scan, technetium pertechnetate scan. We can do barium meal follow through, video capsule, endoscopy. Treatment, asymptomatic, nothing. Symptomatic complicated, depends. Narrow mouth, wide mouth. Narrow mouth, diverticulectomy, linear stapler. Wide mouth, resection of segment of intestine bearing Meckel's and end-to-end anastomosis with the staplers, linear stapler. Hirschsprung disease, congenital megacolon, congenital aganglionosis, absence of ganglion cells in the nerve plexus, most commonly in the rectosigmoid where rectum is always involved. Depending on the length of aganglionic segment, the story can present differently. Only short segment aganglionic presents in OPD, childhood, constipation. First, barium enema. This can show the length of the aganglionic segment. Narrow contracted area pathological, proximal dilated segment normal. Anorectal manometry, pressures to know the severity of traffic jam. To conclude or investigation of choice for making the diagnosis, suction rectal biopsy. Treatment, operations, Duhamel, Swenson, Sove. If it's a long segment which is aganglionic, story presents an emergency with a complete traffic jam, intestinal obstruction, newborn baby, proximal colostomy. So thank you very much. This is all for today, and tomorrow you are having a long ENT class, I think from somewhere 9:30 to 7 o'clock. So enjoy your ENT classes, and as we know that ENT classes will be conducted only online live and they'll be deleted as soon as the class is done. If by chance, due to any reason, some of you are not able to attend these ENT classes, maybe because of internet poor connection, or maybe because in some areas where electricity is an issue or something like that, we have made another provision to conduct the ENT classes by another awesome faculty whose classes can be made available for you for 24 hours. And those classes are scheduled later on. And when those classes are scheduled, then at that point of time, if you have attended these current ENT classes, you can skip those classes. But if you have missed out on these classes, then attend those ENT classes for sure. Thank you very much. Hope you are keeping yourself sound and strong, and you enjoyed this session. Thank you very much for your patience. I'll just have a look at any of the WhatsApp queries and would be more than happy to respond to your queries. A notification which we have been seeing today from the NMC regarding the eligibility certificate. So I think I am not the right person to give any clarification related to eligibility certificates, because to be very honest, I do not know much about it. Plus, I do not want to misguide you, right? Because NMC is NMC. So I do not wish to comment about anything. Best thing would be if you have sent an email to them, even if they have not responded, at least we have a proof that what we can do if suppose they do not issue the eligibility certificate. Beta, you messaged me at 17:48. So at that point of time, we were doing what? We today started with intussusception. So I think you are talking about intussusception. Yeah, beta, there are chances of intussusception. The question is whether there are any chance of recurrence after hydrostatic reduction. Probably this is the question. There are definitely chances of recurrence, but as the baby grows, then those hypertrophy of the PS patches and all that stuff, the baby's intestine, they get used to that top feed. So it is not that every time there is a recurrence, but there is a remote possibility of recurrence for sure. The first part of intussusception, if some portion of the intestine becomes heavy, peristalsis forces the heavy part of intestine to ride into the adjacent part, and that causes intussusception, most commonly in the ileocolic area, because at 6 months of age, when weaning starts, when top feed is given to the baby, it can cause infections in the intestine which may cause hypertrophy of the Pierce patch